Sanjay, I have known since a very long time Dr. Sanjay Kumar. He has been my resident during his MD days. He started off in Bhopal after doing his BA in Gastroenterology from PJ Chandigarh, from where I have also graduated. Starting off with a very modest venture, starting with Madhyam Lab and OPD and subsequently starting a hospital way back in 2013. He has grown by leaps and bounds. This hospital today is one of the best referral centers for gastroenterology in Central India, which is equipped with practically all the facilities that you can think of. He has an excellent endoscopy units, good EVL setup, very good team, good surgeries. You have multi-specialty care here, and what all you require actually for any sick patient. His ICU is wonderful. I had an opportunity to work in his ICU also. Excellent team, especially the intensivists who are working there are very good. I have also joined here as one of the faculty, and I think we have also received recognition for Diploma National Board in Gastroenterology, that is DNB. And we are shortly expecting the students to come and join this session. Probably 2 students are likely to come shortly. So it's going to be a good teaching institution also, and a training institution also. So this is what I want to tell you, and I think we will soon start our deliberations regarding this. Thank you very much.
थैंक यू डॉक्टर चावल सर। और जैसा मैंने आपसे कहा कि हमारे बहुत से एक्सपर्ट्स यहाँ पर हैं, शहर से बाहर से, और कार्यक्रम की शुरुआत में हम उनका स्वागत करेंगे और उसके बाद हमारे साइंटिफिक सेशन शुरू होगा। स्वागत के तौर पर सैपलिंग्स दिए जाएंगे, वैसे ही जैसे यह बिग का सैपलिंग, भोपाल इंस्टीट्यूट ऑफ गैस्ट्रोएंटरोलॉजी का सैपलिंग आज एक विशाल वृक्ष बन गया है, और आज उसी के सानिध्य में, उसी के कार्यक्रम में हम सब लोग यहाँ पर शामिल हैं। मैं रिक्वेस्ट करूँगा डॉक्टर संदेश शर्मा सर से, डॉक्टर संदेश, डॉक्टर एच त्रिवेदी सर हमारे सीनियर डॉक्टर पैट्रन, डॉक्टर एच त्रिवेदी भोपाल की वो शख्सियत जो हर डॉक्टर, हर स्टूडेंट, हर कंसल्टेंट जानता है, और एक जोरदार तालियां चाहिए। डॉक्टर नीतू कुमार से मैं निवेदन करूंगा कि डॉक्टर AC आनंद सर का स्वागत करें। डॉक्टर AC आनंद सर एक्सपर्ट बाहर से आए हैं और हमेशा बिग अपडेट में उनका हमेशा सानिध्य मिला है। जोरदार तालियां। डॉक्टर मयंक भूषण पटेल से रिक्वेस्ट करूंगा कि डॉक्टर SP मिश्रा सर का स्वागत करें। डॉक्टर मयंक, और जैसा मैंने कहा कि डॉक्टर संजय के साथ देश भर के ख्यातनाम डॉक्टर्स, कंसल्टेंट्स जुड़े हुए हैं, उनके स्वागत के लिए डॉक्टर मयंक को बुला रहा हूँ। डॉक्टर SP मिश्रा सर। तस्वीर में कैद करने की थोड़ी सी कोशिश, उसी में हल्का सा समय का, और डॉक्टर मयंक एक बार जोरदार तालियां। गैस्ट्रोकेयर के एक और सॉल्वर डॉक्टर नवीन TMG से मैं रिक्वेस्ट करूंगा कि डॉक्टर उदय सोमशेखर सर का स्वागत करें। डॉक्टर नवीन प्लीज, जोरदार तालियां। डॉक्टर नवीन MPISG के प्रेसिडेंट भी हैं। अब मैं रिक्वेस्ट करूंगा IIM ग्रेटर भोपाल ब्रांच के प्रेसिडेंट डॉक्टर कमलेश तावरी, डॉक्टर RK सिंह का स्वागत करेंगे। डॉक्टर RK सिंह का स्वागत जब आएंगे तब हम फिर करेंगे बीच में, और डॉक्टर कमलेश से ही मैं रिक्वेस्ट करूंगा कि वो डॉक्टर जयंत यादव, डॉक्टर जयंत यादव हमारे पुराने साथी और अपने फील्ड के एक्सपर्ट, इंडियन सोसाइटी ऑफ वेस्कुलर एंड इंटरवेंशन रेडियोलॉजी ISVIR के प्रेसिडेंट। सोसाइटी का जितना लंबा नाम है उतने ही लंबे काम है डॉक्टर जयंत यादव के। अब मैं रिक्वेस्ट करूँगा डॉक्टर अनुपमा पाठक, एपीआई भोपाल की प्रेसिडेंट। डॉक्टर अनुपमा पाठक, एपीआई भोपाल के प्रेसिडेंट से रिक्वेस्ट करूँगा कि डॉक्टर राजेश श्रीवास्तव का सम्मान करें, वो भी नहीं आए हैं। डॉक्टर अनुपमा पाठक से ही मैं रिक्वेस्ट करूँगा डॉक्टर राजीव शारदा का सम्मान करें। यस सर प्लीज। भोपाल सर्जन्स क्लब के प्रेसिडेंट डॉक्टर राजीव शारदा, एक्टिव मेंबर और भोपाल के ख्यातनाम सर्जन। एमपीआईएम प्रेसिडेंट डॉक्टर एन के जैन का स्वागत के लिए मैं डॉक्टर आई के चुप को बुला रहा हूँ। डॉक्टर चुप हमारे सीनियर कंसल्टेंट भोपाल के। डॉक्टर एन के जैन,
सर सामने लीजिए प्लीज, सर हाथ लगा दीजिए।
डॉक्टर भान सिंह रघुवंशी से मैं रिक्वेस्ट करूंगा कि वे डॉक्टर मज़ाहिर हुसैन मलिक का स्वागत करें। आईएमए सेक्रेटरी डॉक्टर रमेश मलिक और डॉक्टर भान सिंह रघुवंशी। स्वागत के बाद मैं रिक्वेस्ट करूंगा हमारे सभी साथियों का, हमारे अतिथि, हमारे एक्सपर्ट्स के स्वागत के लिए भी और स्वागत संबोधन के लिए डॉक्टर संजय कुमार को। सुना था कि वो आएंगे अंजुमन में, सुना था कि वो आएंगे अंजुमन में, सुना था कि उनसे मुलाकात होगी। तो आज सभी से मुलाकात के इस क्षणों के पहले मैं रिक्वेस्ट करूँगा हमारे प्रिय डॉक्टर संजय कुमार।
मॉर्निंग, नमस्कार, आप सभी का स्वागत है। फर्स्ट ऑफ ऑल आई वुड लाइक टू welcome all of you to this SWEZOCON. As Dr. Chaubal has already briefed all of you that this is a unique concept, and in this concept we wanted to incorporate not only gastroenterologists but gastrointestinal surgeons, interventional radiologists, hematologists, physicians, surgeons, pathologists. So this is a theme which actually connects everyone. In fact, if you look at the major illnesses which trouble human body, bleeding and thrombosis form one of the major chunks. Apart from, I think, infections, these are the major killers. I welcome all my esteemed faculty members who have come from different places of the country. In fact, we are all passing through a very difficult phase, which started in Pahalgam last month. And we are happy about Operation Sindoor, which has been carried out very effectively, and we are all with our soldiers and our defense team and the government in this aspect. We had a difficult time in arranging this conference during this hour also, because a lot of our faculty were finding difficulties in flights because some airports have been shut down and there are delays in flights. So I'm truly thankful to all those who have come in spite of all these difficulties. I especially thank Professor H.S. Trivedi, my teacher, who is always a guiding force and who is always here to bless us in our all ventures, for having come today in the morning. I especially thank Professor A.C. Anand and Professor S.P. Mishra sir, who have come all the way from Bhubaneswar and Prayagraj. I know it wasn't easy, especially looking at the prevailing conditions. I always thank Dr. Chaubal. He is kind of my role model, I would say. I have always looked upon him, not only for academics, but also for all other things. I mean, we find him to be a complete man like Raymond's. So I thank all the participating associations, especially Indian Society of Gastroenterology, MP chapter, Dr. Uday Somshekar is here, is present. IMA Greater Bhopal, Indian Society of Vascular and Interventional Radiology, Association of Physicians of India, and Surgeons Club of Bhopal, and Bhopal Hematology Association too. So all these associations are our partners in this conference. As I said, this is a huge theme, and we require everyone's participation in this. Big update, as you all know, we started in 2014, and this is the 10th edition. In fact, due to COVID in between, we could not do it for 2 years. But big update stands for Bhopal Institute of Gastroenterology update. But in other sense, like Dr. Atul has said, it has actually grown big also. So it is a big update in that sense also because of participation of all of you who come regularly and encourage us. About the program, Dr. Chaubal has already said, we have very interesting topics. Most of these are panel discussions because these are the problems which require multidisciplinary approach. And we have tried to incorporate in our panels not only gastrosurgeons, and especially radiologists, interventional radiologists. I am thankful to Dr. Jagdishan, who has come all the way from AIG Hyderabad. He's an interventional radiologist. And Dr. Nitin Shetty, who's come from Tata Memorial Hospital, Mumbai. Dr. Amar Mukund, who is the president of ISVR and is working at ILBS Delhi, could not come because of some reasons, but then he will be connecting him online. In fact, we have made an arrangement that all those speakers and panelists who have not been able to join us today, we'll be connecting them online. So our program will stand as it is mentioned. So we'll not be having any absenteeism because people are here and some of them will connect online. Finally, I would like to thank my team who's always with me, the Gastrocare team, and my family who support me in all these ventures in spite of all odd problems. I would also like to thank pharma industry for being generous in continuing this event for all these years. So I wish everyone a great conference for this 1.5 days, brainstorming, informative sessions, and interactive sessions. I welcome all of you again. Thank you.
Pick in time and treat them well. ज्ञानवर्धन की इस एक्सरसाइज शुरू करें उसके पहले सरस्वती वंदना के लिए मैं डॉक्टर सविता मेहता और डॉक्टर नीतू कुमार को आमंत्रित कर रहा हूं।
कॉन्फिडेंस देखो मैं
बंद है
इधर से
चेक करो।
महादेवी वर्मा की दो पंक्तियाँ। सब बुझे दीपक जला लूँ, सब बुझे दीपक जला लूँ, घिर रहा तम आज दीपक रागिनी जगा लूँ। तो ज्ञान की इस दीपक रागिनी के जलाने के लिए मैं हमारे सारे डिग्निटरीज से रिक्वेस्ट कर रहा हूँ, निवेदन कर रहा हूँ कि लैंप लाइटिंग के लिए प्लीज़ यहाँ पर आएँ। डॉक्टर संजय कुमार, डॉक्टर एच त्रिवेदी सर, डॉक्टर AC आनंद सर भुवनेश्वर से जो आए हैं, प्रयागराज से हमारे पधारे अतिथि डॉक्टर SP मिश्रा सर, डॉक्टर उदय सोमशेखर जो ISG MP के प्रेसिडेंट हैं, डॉक्टर मज़ाहिर हुसैन मलिक जो सेक्रेटरी हैं IMA भोपाल, डॉक्टर जयंत यादव जो ISVIR के प्रेसिडेंट हैं, डॉक्टर राजीव शारदा जो भोपाल सर्जन्स क्लब के प्रेसिडेंट हैं, डॉक्टर MK जैन MP IMA के प्रेसिडेंट हैं। मैं सभी से रिक्वेस्ट करूंगा मंच पर आकर लैंप लाइटिंग के लिए। तालियां दीपक की रोशनी भी बढ़ा देंगी, उनकी ज्वाला भी बढ़ा देंगी। साथियों, कार्यक्रम के आखिर में आज के दिन तो और ज़रूरी जनगण मन राष्ट्रगान सभी से रिक्वेस्ट है कि अपने अपने स्थान पर खड़े हो जाएं। जनगण मन अधिनायक जय है भारत भाग्य विधाता, पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल बंगा, विंध्य हिमाचल यमुना गंगा उच्चल जलधि तिरंगा, तव शुभ नामे जागे तव शुभ आशीष मांगे, गाहे तव जय जन गण मंगलदायक जय है भारत भाग्य विधाता, जय है जय है जय है जय 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 है। वैसोकॉन की पढ़ाई लिखाई और शुरुआत हो, उसके साथ ही एक बार धन्यवाद, शुक्रिया आप सबके यहाँ आने का और इस कार्यक्रम में शामिल होने का। थैंक्स अ लॉट।
We would like to thank Dr. Atul Kataria, sir, and all the dignitaries for joining us and setting the tone for what promises to be an insightful and impactful event. We are truly privileged to have you all here. While we set the stage for the scientific session, we would like to invite Dr. Rakesh Bhargav sir words about organ transplant.
नमस्कार, थैंक्स टीम गैस्ट्रोकेयर कि हमें यह मौका दिए एक अंगदान के लिए। हमारी टीम लगभग 10 साल से ऑर्गन डोनेशन के लिए भोपाल में और मध्य प्रदेश में काम कर रही है और हमारे प्रयासों से लगभग मध्य प्रदेश में इंदौर, जबलपुर, भोपाल में 90 लोगों ने ऑर्गन डोनेशन किया, जिससे लगभग 260 लोगों को ऑर्गन्स ट्रांसप्लांट हुआ है। जैसा कि आप मुझसे बेहतर जानते हैं, किडनी पेशेंट तो 5 साल 7 साल वेटिंग में बैठेगा ट्रांसप्लांट के लिए, लेकिन लिवर पेशेंट में अक्सर मैं देखता हूँ हमारे पास मदद के लिए फ़ोन आता है तो हर 1-1.5 महीने में किसी न पेशेंट की लिवर ट्रांसप्लांट की वेटिंग में डेथ हो जाती है। तो जैसे कि हमारा हर 15 मिनट में एक पेशेंट ट्रांसप्लांट के लिए लिस्ट में ऐड होता जा रहा है और हम लगभग हमें ज़रूरत है 4-5 लाख ट्रांसप्लांट की, लिवर, किडनी, हार्ट वगैरह, और हम सिर्फ करते हैं 28-30 हज़ार, जिसमें से 1000 पेशेंट्स ने लास्ट ईयर ऑर्गन डोनेशन किया आफ्टर डेथ, जिससे लगभग 3100 लोगों को ऑर्गन्स ट्रांसप्लांट के लिए मदद मिली। जैसे हमारा परंपरा हम पढ़ते हैं हर जगह, हर धर्म में, या जो धर्म को नहीं भी मानते हैं, एक मानवता, इम्यूनिटी के नाते हम मदद करते हैं, या हमारे घर में कोई जन्म लेता है बच्चा तो हम दान करते हैं, पैसों से दान करते हैं, या कपड़ों से किसी को बांटते हैं, या गरीब की मदद करते हैं। जैसे हमीदिया में हमारा सोसाइटी है, प्रेरणा सेवा ट्रस्ट, गरीबों के लिए मदद। उसी तरह हम जैसे बोलते हैं ना कि कुछ लोग अपने धर्म में 2% दान करते हैं, या 5%, या जो भी अपनी कमाई का हिस्सा एक दान करते हैं हम सभी लोग। तो जैसे जब हम पैदा होते हैं तो हमारा वज़न होता है 2.5-3 किलो, 3.5 किलो, और जब हम जवान होते हैं 17, 18, 20 साल या 50 साल, 70 साल के, जब डेथ होती है किसी भी उम्र में, तो हमारा वज़न होता है 60, 70, 80 किलो। तो मेरा कहना रहता है कि हमारा एसेट सिर्फ पैसा नहीं है कि मैंने 50 लाख कमाया, 1 करोड़ कमाया, जो भी कमाया हम उसका 10% दान करेंगे। ये शरीर भी तो हमारी कमाई है, इससे बड़ा एसेट तो कुछ भी नहीं है। तो जो हमारा शरीर 3 किलो का 70 किलो का हो गया, तो अगर हम उसका भी 2-5% अगर दान कर दें तो कितने लोगों को नया जीवन मिलेगा। हार्ट, लिवर, किडनी, इंटेस्टाइन और लंग्स, आई लोग। और मैं भोपाल के उदाहरण देता हूँ। जैसे भोपाल में लगभग 170 है जो कॉर्निया ट्रांसप्लांट के इंतज़ार कर रहे हैं, कि मतलब कितनी छोटी सी चीज़ है कॉर्निया, और भोपाल में रोज़ लगभग 40-50 लोगों की डेथ हो रही है। अगर 2 लोग भी रोज़ करें तो हम 2 महीने में हमारी वेटिंग ख़त्म हो जाए। लेकिन जब तक हम इसके लिए हम सब लोग मिलकर आगे बढ़ के जागरूक नहीं करेंगे, पब्लिक को अवेयर नहीं करेंगे, तो और मैं आप सबसे अपील करता हूँ, उम्मीद करता हूँ कि आप जहाँ भी हों, जिस शहर में भी हों, इस मिशन को हम आगे बढ़ाएं, जिससे साउथ में जितना वो 10 दिन में करते हैं उतना हम मध्य प्रदेश में 1 साल में उतने अंगदान नहीं कर पाते। हम साल में 10 कर पाते हैं पूरे मध्य प्रदेश में, और साउथ में हर 10 दिन में 10 होते हैं। लगभग ऑलमोस्ट डेली वहाँ पे ऑर्गन ट्रांसप्लांट होता है आफ्टर डेथ। थैंक यू, नमस्कार।
Thank you, Dr. Rakesh. Dr. Rakesh is a qualified pediatrician and he has virtually left his practice just to help organ transplantation. Give him a big applause. Now we start our academic sessions, and since this is a very tight schedule, we have kept 5 minutes relaxing sessions in between, which you will enjoy.
Thank you, Sanjay sir. With this, I would like to invite our first speaker, Dr. Manisha Srivastav ma'am, on the stage for the topic blood transfusion and components, when and what. I would request the chairpersons for the session to please join us stage. Dr. U.M. Sharma sir, Senior Pathologist Bhopal, Dr. Gopal Batni, Senior Physician Bhopal, Dr. Sanjay Gupta sir, Senior Nephrologist, Aradhana Hospital Bhopal, Dr. Tarun Sainia, Head Department of Surgery, Chirayu Medical College Bhopal.
Good morning, everyone. Uh, uh, I think there is no need to introduce Dr. Manisha. She's a very well-known figure in Bhopal and the pioneer and founder of transfusion medicine in Bhopal. Ever since we even did not know that what transfusion medicine is, Dr. Manisha was here in BMHRC to tell us about the nuances of blood transfusion. So we have gone far ahead from the days when we used to be residents and believed only in whole blood transfusion. Now the transfusion has gone ahead, years ahead, where only the components are being used. We know about the complications of blood transfusion, and I consider it as a liquid organ transplant. So let us know more about this liquid organ transplant from Dr. Manisha. Dr. Manisha, please.
सभी को मेरा नमस्कार, गुड मॉर्निंग एवरीवन एंड फर्स्ट ऑफ ऑल आई वुड लाइक टू थैंक डॉक्टर संजय कुमार because he thought of me as the first speaker also and in such an important conference where we talk of bleeding. But somehow I would like to say that the best transfusion was the one which was not given, is the dictum of transfusion medicine. This is a paradox because we are here to give blood, but that is the truth. Next, please. Can I have the first slide? Okay. So first of all, I would like to say that, you know, why it is so important in your field, because as a surgeon or as a gastromedicine specialist, all acute and chronic GI bleeding, they affect 47 in 100,000 people worldwide. So we are having patients, they come in a very serious condition and they need immediate intervention. Then upper GI bleeding is associated with a mortality rate of 3 to 14% and almost the lower GI bleed with 3%. Before we say what and how and what, I would like to just emphasize a few facts. One is that whenever we think of giving blood, we think of hemoglobin, while hemoglobin levels are not always indicated of full extent of blood loss in patients with GI bleed. So the fact remains that when we treat a patient, is looking at hemoglobin level important. The fluid movement from interstitial space to the vascular compartment really confuses the clinician. The infusion of IV fluids or overhydration may also lead to false low concentration readings. So whenever the patient is coming to you, I think the transfusion is the last thing we have to think. There is a risk of rebleed. Everyone knows that there is a risk of rebleed due to vasodilation and increase in blood pressure that can result in erosion of vessels. It's moving, actually one slide is jumping after the other. Then of course impact of hypothermia when patient is coming to you, overexpansion of plasma volume in bleeding because of portal hypertension. All these lead to the hemoglobin levels which are confusing. A real paradox is that a normal initial hemoglobin level also does not exclude the possibility of severe bleeding. So most of the time we are looking at the CBC and we are trying to, you know, treat the patients after looking at CBC, which is, the slides are jumping actually. So hemodynamic parameters become very important. This I'm saying because usually whenever we get the request for blood transfusion, we are, you know, first of all looking at the indications. And most of the blood requests will not have any indication written. So general, because we have now super specialization, as Dr. Sanjay Kumar said, and people have knowledge, but still I think we are living in the older times as far as blood transfusion is concerned. So nature, source and activity of bleeding, that's important. Extent of bleeding, more important. And likelihood of rebleeding. So that is for all of you to understand the comorbidities that increase the risk of severe bleeding, like anticoagulation if patient is on antiplatelet drugs. Comorbidities that increase the risk of tissue hypoxia, like CVA, organ dysfunction, heart failure, ischemic heart disease. All these, you know, they are important when you go for a clinical judgment. So the most important is the clinical judgment of the physician or the surgeon. It's not the labs, it's not the other things, it's your clinical judgment which will help us. Guidelines are important. We have international guidelines, we have national guidelines also, national standards, but still your clinical judgment will determine whether the patient needs transfusion or not. Also that previously it was like whenever patient comes, just you have to start transfusion and give lots of units of blood. But now a lot of systematic reviews I have undergone and the GI medicine articles and algorithms developed, so and so forth, have determined that a restrictive transfusion model that precludes the use of blood to increase blood volume has been recommended latest, the dictum is. That is, if you are giving blood, then you give 1 unit at a time. Give 1 unit of RBC at a time in a bleeding patient, and except in very severe cases where the bleeding is uncontrolled, and of course, then you will need to explore and look at through blood transfusion. I always say that blood transfusion is a supportive therapy, it's not a therapeutic end of the day. And we got recognition, as he said, I landed in Bhopal in 2000 in BMHRC, where people would ask me what degree I had taken, but somehow I had studied from SGPGI and had little knowledge of this field, which was called as immunohematology and blood transfusion. The slide is jumping actually, so it's a little confusing. But our field got recognized with a threat of HIV. When HIV came and public came to know and the doctors came to know that HIV is transmitted through blood, then this field was, really understood, and we started testing our blood for hepatitis B, C, HIV, malaria, and syphilis. HCV came very late in 2004. So we all know that a donor who comes with hepatitis B, they are now being controlled by the Hepatitis Control Program, the national program. And we are working to control hepatitis in the society. So restrictive use of blood because of the cost and all other factors, as well as a risk of getting transfusion-transmitted illness, has really, gave us a recognition. And our field has gone up to the patient blood management. As it was said, that it is the oldest form of transplant, this blood transfusion. And now patient blood management, even in the liver transplants. Previously it was said that you have to give hundreds of units, and the main aim is to improve patient outcome. Everybody is looking at improving the patient outcome. Can I have someone to see whether the slides are jumping? I think the timing is set that the slides start jumping. So we need to improve the patient outcome. So what I said was that patient-centric decision making is important. First thing, we have to look at optimizing the coagulation. That is the second thing. Managing anemia. There are many methods of managing anemia other than blood transfusion somehow. And multidisciplinary, we have to blood conservation modality. In Western world and our world also, it's difficult to find real good donors who would be zero risk. So instead of treating the patient with bleeding disorder and sending him off happily after getting treatment, you would be giving him a gift of either hepatitis B or C. HIV is not that common. Syphilis gets treated with antibiotics, but we do have patients with landing up with hepatitis B and C. So we talk of rational use of blood, the right blood in the right quantity to the right patient. That is what we expect, and that is what is to be done. So the clinicians have to know that good clinical practice will involve specific replacements. The cost of treatment also is very important. Many of the blood banks will now have component facility, but still the availability of donors is scarce, and we have to avoid unnecessary transfusions for better safety and efficacy. No blood transfusion is 100% safe. So that is to be remembered. And also when we talk of patients going in for transplants, you will be giving them antigen and antibodies, and they will sensitize them to foreign antigens and antibodies, and they may land up in rejection even if you have chosen the best organ for them. So blood is definitely a sensitization and a treatment modality which will not be, so feasible for patients who will undergo transplants. Of course, we waste the important resources, we deprive the more needy patients, because if I have 1 unit of rare blood group unit, I would like it to be used best for the patient who needs it most. So, of course, we are increasing the healthcare cost, and I need not be saying this, but there are many studies which say that patients' hospital stay, then morbidity and mortality increases with transfusions. So, somehow being a specialist, I need to advocate that no transfusion is the best form of transfusion. And of course, now we have components which have come up, but in 2000 when I started the blood transfusion department in BMHRC, it had already got 100% components and apheresis, and we have never had whole blood units in our blood bank. And it was a kind of an experience which has led us to become the National Nodal Training Center and to have a department with specialists. And many of the doctors who have worked in BMHRC know that blood transfusion is never a question, because we have gone for the best way, that is the right blood to the right patient in the right quantity. And components is the way of life today. So there is no need for fresh blood that I would like to advocate. Very many cases where doctors are asking for fresh blood, that's just a dictum, because I would say that a unit of packed red cell increases the hemoglobin by 2g%. The platelets which you get from single donor apheresis units or a fresh blood will not have more than 300 platelet increment, 300 only. And to stop bleeding, you need at least 20,000 to 30,000 platelets. So a fresh blood unit is not of any use. Rather, it will have all the viruses, bacteria, and all harmful interleukins and all, which will affect badly your patients. And you are the best judge. So I would say that, weighing indication versus clinical benefit is the first thing. Whenever you are prescribing blood, you need to, judge whether it is the right blood for this patient. Just for the information, I would say that packed red cells are required only for transfusion-dependent anemias to increase the oxygen carrying capacity. So there's never an indication, if you're giving 1 unit, if the patient has oxygen problem, then you can give 1 unit of blood. Otherwise, if he gets into a setting like Dr. Sanjay Kumar's, and good ICUs now, Bhopal has very good hospitals, so you need not give transfusion to start with. Because oxygen is available, you do not need to increase the oxygen carrying capacity. So only for transfusion dependent, this I have taken the algorithm from a latest article from Gastromedicine Journal only, that if you have GI bleed, then an acute anemia and less than 8 gram hemoglobin, you consider, giving 1 unit at a time. I think they're saying my time is over. So for chronic anemia, the dictum is that hemoglobin less than 5 only you need to consider RBC transfusion. In chronic anemias, wherever your patients are landing up with Crohn's disease, adenomas, colorectal cancers, and they have, so iron deficiency can be treated with iron and not with blood. So again, these algorithms, they suggest that restrictive therapy is important. Here I would definitely give an important advice that compatible IV solutions with blood. Sometimes we land up with transfusion reactions within your endoscopy unit or your OT because you have not checked the compatible IV solutions. Normal saline actually is the only IV compatible solution with blood. 5% albumin and ABO matched plasma. If you have a good blood bank, they will give you ABO matched plasma and mix your blood with it. And the incompatible IV solutions like lactated ringer, dextrose, and hypotonic. Whenever there is blood transfusion, we need to, wash the IV lines with normal saline and not with all these solutions. Because once it is there, that will cause hemolysis and your patient may land up in transfusion reaction. Of course, I need not tell the blood transfusion sparing drugs, aprotenin, desmopressin, erythropoietin, all these can be given in place of blood. FFP is the most abused component. Everyone is asking for FFP, give me 1 unit of FFP, while 6 units of FFP are the ones which is the correct dose. We will not give half a paracetamol to a person with a fever. Similarly, blood has its own dose. But again, I will say that FFP is the most common reason for getting transfusion-transmitted infections. So we have minimum 600 plasma as a therapeutic component. Correction of coagulation abnormalities with FFP is not recommended when your patient is already vitamin K antagonist treatment is going on for that patient. And prothrombin complexes are not so readily available, but patient's bleeding source should be identified. That is the most important. And INR nowadays is not a reason to treat a patient with GI problems, you know that. There are other facilities which are available to guide you through the anticoagulants and all. Platelet is, again, I would say that it is the most contraindicated in thrombocytopenias. The thrombotic thrombocytopenic purpura, ITP, the platelet is contraindicated. So this also has to be remembered. Platelet transfusions in less than 30,000 platelet only has to be given, and when they have significant bleeding. So I have summarized this. These slides can be shared with our students. And there is another component called cryoprecipitate. That is the only adequate fibrinogen concentrate available for intravenous use. So if you want to give fibrinogen to a patient, please give cryoprecipitate, which is also given to hemophiliacs, von Willebrand disease, and as a component where you need fibrin glue. And everybody is aware of the apheresis systems which are available now. So if you want to give single donor platelets, if suppose a dengue hemorrhagic comes, or for any other reason on a patient with chemotherapy, you need to go for apheresis components. Then the blood transfusion, as Dr. Sanjay said, that it is a personalized medicine, as treatment decisions should be individualized, and guidelines are just to guide, not to supersede your acumen as a clinician. That is very important. And my slides are always, the last slide is that it is a transplant and it's not a simple decision, and no transfusion is the best transfusion. So every time you are transfusing a patient, you have to think. Thank you.
Thank you, Dr. Manisha, for the elaborate presentation. I'll just like to add one thing for the information of the House, that the term blood banks has been abolished as per the national norms. All the blood banks are now known as blood centers. Secondly, all the blood banks previously or blood centers, they had to get a license from the Food and Drug Administration of India. Why? Because blood is considered as a drug in the law. And as all of us are aware, blood, since it is considered as a drug, it should be used like a drug, that is prescribed only when needed and in minimal effective dose. And as Dr. Manisha has rightly pointed out, no transfusion is the best transfusion, because transfusion of any components, it carries the risk of alloimmunization and transmission of infections. Any questions from the House?
So can we have questions later? We are a little behind the schedule.
Okay.
Thank you.
Thank you, Dr. Sanjay, and thank you for giving me the opportunity. Thank you.
To capture the moment, I request the speaker and the chairpersons to please join us for a group photograph on the selfie point. The next session is the panel discussion on the topic non-variceal UGI bleed with Dr. H.P. Yadav as moderator. I would request the panelists for the session to please join us on the stage. Dr. Mohan Ramchandani sir, Dr. Nitin S. Shetty sir, Dr. Ajit Swikani sir, Dr. Preetam Nath sir, and Dr. Amit Thorani sir. Now, I invite our esteemed expert discussant to join us on the stage. Dr. Manoj Joshi sir, Senior Gastroenterologist, Haldwani, Dr. Atul Setha sir, Senior Surgeon, Narmadapuram, Dr. M.H. Usmani sir, Gastroenterologist, Riva, Dr. Bhan Singh Raghuvanshi sir, Physician, Gastrocare Multispeciality Hospital, Bhopal.
Dr. Mohan has not been able to make it today, so he will be connected online. Rest of the panelists are here and the expert discussants too.
Good morning, everyone. Thank you, Sanjay sir, for inviting me and giving me the very important topic. And first of all, I wish a big success for the big update. And my topic is panel discussion on non-varicose upper GI bleed. The panelists are Dr. Ajit Sevkani, Amit Thavrani, Dr. Nitin Sethi, Mohan Ramchandani is joining online. I don't know where is Mohan. He's not visible on the screen. And Dr. Pritam Nath. So GI bleeding is one of the very important emergency in GI practice, and since last decades the mortality is almost stable around 10%. In spite of we are having very advanced imaging and now newer accessories to control the bleeding, but the mortality is around up to the tune of 10%. So in this discussion, we'll discuss what should be the initial management, when to do the endoscopy, what are the current endoscopic treatments available, what are the advances in endoscopic treatment, how to reduce the rebleed rate, and how to manage the patient who are on antiplatelets and anticoagulants during GI bleeding. The causes, you know, the peptic ulcer varices, they are the commonest causes. In some center in India, the varices is the first, in some center the peptic ulcer is the first cause. Other causes are also not uncommon, like esophagitis, gastritis, ABM, GAVE, medullary malignancy, Delophus lesion, hemophilia, hemosuccus pancreaticus, and very rare aortoenteric fistulas. The cases can be simple one, and the cases can be very challenging. So in my discussion, I'll just present few real cases and discuss with the panelists and with the house also. So I request all the audience to please interact and make your comments. This was 56-year-old male patient post-bypass on dual antiplatelet drugs admitted with hematemesis with symptoms of hypovolemia, melena, dizziness since early morning, low BP, heart rate 114, HV was 8.6. The question to Dr. Amit Thavrani, you have seen the patient in emergency room. What will you do immediately? What will you plan for this patient?
When we see the patient in emergency, we follow the typical ABC of resuscitation. We see first maintain the airway. If patient is drowsy, we intubate the patient and secure the airway first, because there is a risk of aspiration if patient is drowsy. Secondly, we see for the circulation, we put two wire word cannulas and give transfusion of typically crystalloids. Colloids are not indicated. We give crystalloids for resuscitation to maintain the blood pressure. And then after stabilization of the patient, we plan the endoscopy, which can be in urgent endoscopy or planned endoscopy in 12 hours or 24 hours.
Okay.
And regarding transfusion, the transfusion of
we'll discuss these things later. So when you see the patient immediately, we start the IV fluid. Should be patient landing in emergency, starting the IV fluid should be less than 10 minutes. These are standard guidelines. And at the same time, we plan what should be the strategy of this patient. When you're planning endoscopy and all these things, alerting your intensive care team if patient is very sick. So issues in this patient was risk stratification, resuscitation or blood transfusion, pre-endoscopy treatment, antiplatelet medication, and what should be the timing for endoscopy. We'll discuss all these things. So what is the importance of risk stratification? This question is to Dr. Pritam Nath. And are you using any of the scoring system for risk stratification in your practice?
Good morning, sir. Risk stratification is very important, as you rightly said, that despite all the advances, the mortality still remains at 10%. So there will be a subgroup of patients who will be at higher risk of mortality. So mostly the hemodynamic status, comorbidities, age, they are looked upon, and different scores are available. The ROCAL score is most widely used and validated. The pre-endoscopic ROCAL score is used to just triage what will be the risk of rebleeding or risk of mortality in these patients. So as a teaching institution, we encourage our postgraduate DM students to use this pre-endoscopy ROCAL score, and depending on that, the patient is either managed, and the transfusion and the timing of endoscopy is determined.
My question to the audience, how many of you are using any of the risk stratification system in your practice? Out to the panelists. Can you raise your hands? How many of you are using? Okay, very few. So I'll tell you what is the use of this risk stratification. One is the patient who is having the not at a high risk, you can manage on OPD basis. You're saving the resources, that is one important thing. And second, very sick patients should receive the appropriate treatment. So there are three commonly used systems: Glasgow, Blatchford score, ROCAL score, AIMS score. The Glasgow score is commonly used, and ACG and ESG recommend Glasgow score. And these are the parameter variables in the scoring system. But I tell you, subconsciously, we all are using some of the scoring system. For example, a patient entering your OPD walking, vitals normal, looking pink. We never admit. We just ask a quick hemoglobin, we do the OPD endoscopy, we discharge. They are using some scoring system. And a patient who is in hypotension, coming to emergency, requiring the admission, means you are subconsciously using one or the other scoring system, but formally, most of are not using any of the scoring system. So before we do that, prepare the patient for endoscopy, start at the same time research session. So what is prokinetics and somatostatin or nasogastric suction tube? This question to Dr. Mohan Ramchandani. Can you elaborate all these things? Dr. Mohan, role of PPI, prokinetics, somatostatin, nasogastric tube in patient of non-variceal upper GI bleed before endoscopy.
Mohan, are you there?
Okay. Dr. Yadav, can you hear me?
Yeah, Mohan, please.
Yeah, I'm here. Can you hear me?
Yes, we are hearing you.
Yeah. Thank you, Dr. Sanjay, Dr. Yadav, for your kind. Okay. So regarding the question of preparing the patient, so the role of medicines like PPI, everybody gives PPI, but we must know that IV PPI will not reduce mortality, rebleeding or surgery, but yes, it will downstage the ulcers. Now, the ulcers can be actively bleeding or a clean base ulcer. So if you give PPI before endoscopy, you may downstage the ulcers, but it will not reduce. So the role of PPI before endoscopy is to downstage. But after endoscopy, once you have done some therapy, then it is very important. It reduces the rebleeding, it reduces the surgery requirement. Moreover, all the patients who are having acute bleeding may not be, if you do endoscopy, the stomach will be full of blood. So in such situation, you can give erythromycin. Unfortunately, IV erythromycin, which is well studied, is not available in India much. So we always give IV metoclopramide, which also improves the visibility. And once you have improved visibility in the stomach, you can do a justice, like if there is a clean base ulcer, you can discharge the patient. But if there is full of blood, you cannot see anything, then endoscopy is not fruitful. So to make endoscopy better, these prokinetics may be used. The role of Ryle's tube is not very significant. It can be used when you have a patient whom you are not able to distinguish between hemoptysis or hematomesis. You can use it. Sometimes when the patient comes with melena and you want to check whether it is upper GI or lower GI, in that also the role is limited because the negative predictive value is less. That means if the patient has upper GI source of melena, sometimes the Ryle's tube aspirate may come negative. But if it is positive, That means if you can draw the blood, then you are sure that it is upper GI source. So you can use the rice tube judiciously, but not routinely. No need to give any cold saline lavage or other things which are of no use. So the roles of rice tube is debatable, but if there is an acute bleed, you may use it for decompression or sometime differentiated hemoptysis, hematemesis, or upper GI source of melena. Somatostatin, I think nobody use, but if you have a doubt whether it have variceal versus non-variceal bleed, and you are not able to be 100% sure, and the endoscopy is not available, you can still start the IV somatostatin. But if you have a 100% non-variceal source, it may not be effective.
So, thank you, Dr.
But
Mohan.
sometimes in older patient, we see GI bleed. Yeah.
Yeah,
Hello.
thank you, Mohan. Yes, sir.
Well, Mohan, can you hear me? Chawbal.
Yes, sir, go ahead.
I'm just, now we are in the era of PCABs. Now, PCABs versus PPI, which one will you prefer in a patient who has GI bleed?
I think still the acute GI bleed, the role of PCAB is not very well studied because we have a robust data on PPIs, IV PPI, even the randomized controlled trials on our own Indian study like oral omeprazole versus IV, but we don't have much of data, hard data on PCAB.
And we don't have IV PCABs.
Okay. Yeah, thank you, Dr. Mohan.
Yeah.
Sir, regarding the PCAB, acutely bleeding patient, most of our, we are not giving anything orally, so they should not be any effective. And there are few studies after doing the successful endotherapy, and at the place of IV PPI post endoscopy, you can start the oral PCAB also, they are equally effective. So there's a definite role of PPI, they reduces the stigmate of bleed and they downgrade the ulcer. ACG doesn't say you can start, you don't start, but definitely ESG says you start the PPI. And the next is resuscitation and blood transfusion. So we start the IV fluid immediately. Next is blood transfusion. To whom and how much? This is questions to Dr. Amit. How much of the blood to give and to whom to give?
Sir, we follow.
Please give a brief answer.
We follow restrictive transfusion practices. Generally, blood transfusion, if the hemoglobin is less than 7, targeting up to 9 gram%. In cases of patient who have cardiac disease, who may be more prone to risk to ischemia, so, we may initiate transfusion earlier. And patient who are having massive upper GI bleed, we may give early transfusion.
Just like we have just seen in the last lecture also, it should be as less as possible. So we follow the restrictive strategy, and this has been, we are practicing for a very long time. The threshold for giving the blood is 7 gram for a patient who is stable and not having any comorbid condition, and the threshold can be higher. So this study is showing survival in patients of restrictive and liberal transfusion. So in liberal group, the survival was less, and but with this study, they have all sorts of patients, including cirrhosis and varicose, non-varicose bleed. So in restrictive group, the requirement of blood products is less. Probability of survival at 6 weeks was higher in restrictive group. Rebleed was also low in restrictive groups. Adverse events were more in liberal group. So we all follow the restrictive strategy. We give the blood transfusion when HB is 7, that is the threshold. And the same findings are in this meta-analysis regarding blood transfusion. These are the guidelines by ACG. Give the blood if HB is less than 7. Start the blood if patient is having cardiovascular disease at the HB level of 8. ESG also says the similar recommendations. So, but all these studies, all these guidelines doesn't say anything about patient who is continuously bleeding, is having the hypotension. And in that case, you have to take your own decision. The patient require the blood transfusion at higher hemoglobin level because they are bleeding and they have the, because of the high level is falsely high because of hemoconcentration. So this patient was on anticoagulant, and what is the suggestions for managing the antiplatelets? Should we stop all the things? Dr. Amit, one quick answer.
Sir, if the patient is on primary prophylaxis for aspirin, we stop aspirin. We continue aspirin if he's on secondary prophylaxis. We stop clopidogrel and start at our 5 to 7 days of control of GI bleed. We don't stop ecosprin.
Yes, rightly said. Patient 75 ecosprin, there's no need to stop. If patient on dual antiplatelet, stop clopidogrel and then restart it within 5 to 7 days. So the recommendations also says the same. And patient who are for primary prophylaxis, you stop, then reconsider the indications. And patient on dual, stop the second drug and continue with ecosprin. And patient with stable patient, low stigmata of bleed on endoscopy, means low grade ulcer, you can continue the dual antiplatelet as well. There's no need to stop. And patient who have had the history of GI bleed requiring the dual antiplatelet, there are recommendations to prescribe PPI as a co-therapy to prevent the bleeding in future. So endoscopy has been defined variably in literature: urgent, emergency, early, delayed. So what is the right time to do endoscopy, Dr. Preetham?
So as the evidences suggest, the ideal time is an early endoscopy within 24 hours, and that should be done after adequate resuscitation of the patient. So if there is any hemodynamic instability, correction of this hemodynamic instability. But if the patient is having an exsanguinating bleed with persistence of this hemodynamic instability, that patient very early or urgent endoscopy can be considered.
So that is right, we do the endoscopy after adequate resuscitation, but all the studies, they have excluded the patient regarding the timing, regarding the transfusion, who are continuously bleeding, not responding to resuscitation. You have to take your own decision. You may go early also. So the all the guidelines say the endoscopy within 24 hours. Coming to the case, next day the HE was 6, was not better by waiting, and this is the endoscopy picture. This is a D1 full of blood. And here I would like to emphasize the importance of having the scope with water jet and the distal cap. So this patient was continuously bleeding. By applying the tamponade with distal cap, we could stop the bleeding temporarily, and we localize the bleeder. You can see here the tamponade is applied around the ulcer. Now we can identify the bleeding point. Now what should be the next for this patient? What kind of endotherapy? Definitely there's indication. Which tool to use? Dr. Mohan, this question is to Dr. Mohan, this actively bleeding ulcer. Which modality would you like to use for this patient?
Yeah. This is a very difficult case, Dr. HP, you have shown. The patient is actively bleeding, so we must quickly have a forest classification in our mind that this is patient has forest type 1, which is spurting. So it rebleeds. If you stop by some temporary measures, it rebleeds in 100% of the time. So we must have armamentarium. As you said, I will have at least 2 modalities. Like one is injection. I will quickly inject around this actively bleeding ulcer to achieve some tamponade.
One is injection, second?
I can use by adrenaline. Second, you can choose, like you can use the gold probe, or you can have a clips, so that when there is actively bleeding, the vision is not good. By quick tamponade, you can have a good vision, arrest of bleeding, but one modality is not enough. You must add something else. So I use now more of coag grasper with soft coagulation, and there is a lot of good papers coming up of using coag grasper. I will also have a gold probe ready. I will have hemoclips, and if required, I may use OTSC clip if the bleeding vessel is too big.
Yeah, thank you, Mohan. There's definite indication for doing some endotherapy for visible vessel or patient who is actively bleeding. But now regarding the patient who is having adherent clot or not actively bleeding, there's some confusion. There are 2 kinds of recommendation, that you can wait. That is one recommendation. Second, continue PPI, and second is remove the clot and do the endotherapy. So what is your opinion if you see an adherent clot in a patient of peptic ulcer?
Yeah, so adherent clot should never be, we should not wait. Actually, we should use a cold snare to remove the clot and then see what is happening underneath the clot.
Then do the endotherapy.
If underneath the clot there is a clean, then you don't do anything. But if there is a visible vessel, you must do something, like you can inject and do a gold probe, or you can do a coag grasper. These are the 2 modalities.
Agri should not be left, should be treated according to the findings. So we have various modalities available to treat injection, thermal coagulation, and mechanical hemoclip OTSC. That's just now Mohan has enumerated all. So which tool is better, and we'll discuss it. So this patient was actively bleeding. We have discussed the indications for ulcer. Another modality, this is OTSC. They have the stronger grip, deeper grip. They are often recommended for recurrent bleed and failure. First line therapy in patients of ulcer 2 centimeter visible vessel, bigger visible vessel, ulcers on posterior DU, lesser curvature, dulophobes, ulcer with fibrotic base. They are more effective in achieving hemostasis and low rate of recurrent bleeding. They have certain limitations also. There should be clear in-front visualization of the vessel to apply the clip. Scope should be in a straight position and sometimes tricky to use in certain situations. There's a reduced visualization, difficult to use in acute bleeding. And there are studies comparing the standard endoscopic therapy with OTSC as a first line. There's no significant difference in the overall mortality and outcome, but definitely the clinical success is higher with OTSC, rebleed is less with OTSC. So guidelines recommends for ACG recommend for unsuccessful hemostasis or for recurrent bleed, and ESG says in higher risk ulcer you can use the OTSC as a first line of treatment. Another thing is monopolar hemostatic forceps, that is co-grasper. There are 2 RCTs available. They compare the co-grasper with hemoclips and heater probe. They say similar efficacy compared to hemoclips, better efficacy compared to heater probe. So coming to this patient, we used co-grasper to control the active bleeding. I'm just running this faster.
Is that red diachromatic imaging?
Yes, yes, sir.
Yeah.
And after controlling the bleed with forceps, we applied one more clip. Here we did not use the epinephrine. For just temporarily stopping the bleed, we used the distal cap, and then we coagulated the ulcer, and then we apply one more clip. So that was the treatment, and the patient was discharged successfully. And post-endoscopic, what are the important thing in post-endoscopic therapy, Dr. Amit?
We continue PPI for 2 weeks, and in some studies it has been shown to extend up to
IV PPI for 72 hours, and then second look endoscopy is often not indicated. That is the endoscopist's discretion to do it or not. As palliative testing and treatment recommended for all patients for palliative PPI when patient require the dual antiplatelet. Coming to the next case is the post-bypass patient on ASA, and he was having very bad course after bypass surgery. I was having pneumonia and effusion requiring decortication, had the bleed, and this was the endoscopy. There was no indication for doing any endoscopy, any endotherapy, but after 4 days, patient had bleed in the night, and this was the endoscopy report. A big ulcer in the esophagus, non-bleeding, but this is the scene in the second part of the duodenum. Dr. Mohan, what will you do for this ulcer? This is actively bleeding ulcer, very difficult situation on the lateral wall of the second part of duodenum. Which tool you will use? Just quick
this
comment.
This is again actively spurting. Actively
spurting, yes.
Bleeder.
And very difficult situation. Just one quick answer, one sentence answer.
I will put clips directly on this.
Okay.
So they are in front of me.
We thought applying the clip would be difficult in this situation. So we again use the co-grasper to control the bleeding, and this was successfully controlled with the co-grasper. Actually, this was very difficult for using any of the clip for us. Very challenging. The patient remained stable. 6 days later, had melena hypotension. Again, there's a rebleed. Preetham, what is the approach in doing for rebleed? Or what are the predictors for rebleed?
The predictors of rebleed after a successful endotherapy is whenever the patient presents with hemodynamic instability, especially shock, and when the size of the ulcer revealed on endoscopy is more than any dimension or diameter more than 2 centimeter, and patients who actually if there is a fibrotic base around the ulcer and the modality like clip, if it is applied, that was not satisfactory, that is also a risk factor.
Right. This patient had the bleed from the same side where we did the endotherapy. So again, what should we do? The recommendations are use OTSC in the case of failure, but this was a very difficult situation for OTSC because the angulated position of the scope, and we used the bigger clip here. It was very challenging to apply the clips, but successfully we could clip this ulcer, and the second rebleed was also controlled. But unfortunately, the patient dies 3 weeks later because of the chest problem and septicemia. This is another case of rebleed I encountered long back. This after endotherapy, there was a torrential bleed, and this was controlled with using the multiple clips. and the second endoscopy is the 5 days after this second endotherapy. So recommendations are you do the endoscopy, consider OTSC, failure, refer the patient for interventional radiologist. If interventional radiologist is not available, then surgery is the another option. This is another case of post-bariatric surgery. The patient admitted with bleed, significant bleed, and you can see the very large ulcer at the anastomotic site with big visible vessel. Obviously, most of us would be agree with that. This is a big ulcer, fibrotic base, big vessel, so we should directly go for the OTSC. I think we used the OTSC in this patient, and this bleeding was controlled, and there was no rebleed. So one interesting case, some diagnostic problem. See this patient, post-PTCA day 1 on dual antiplatelet, and had the hypotension in the night. The ICU person thought some cardiac problem. He started with NORAD till morning and called, patient had melena, and then I was called for endoscopy. So can you guess what is this? What is the diagnosis? So some diagnostic, Amit, or anyone from the house. What is the endoscopic diagnosis?
Some tumor, G-junction tumor.
Yeah, this is the video. Basically, this was a intramural hematoma, spontaneous intramural esophagus hematoma that was confirmed by the CT scan, and there was no active bleeding within the hematoma. It was just left, and patient improved. This patient brain tumor had DVT and had hematemesis. The case of patient who was on low molecular weight heparin, how you manage, Dr. Mohan. And this is the endoscopy. Patient had mallory-bees. Would you leave this as it is, or would you like to do the endotherapy? Patient DVT on heparin.
I think we must do the endotherapy.
Right,
and this
right.
patient,
Agree,
there
Dr.
is
Mohan,
adherent
because
clot.
the patient
I will
is
remove this adherent clot.
Yes, not bleeding, but require the this low molecular weight heparin for DBT. So we did place the multiple hemoclip, just like closing the defect of poem. So we apply 5-6 clips, and the patient started low molecular weight heparin after 24 hours. So patient who was requiring anticoagulant, they should receive the anticoagulant, because by withholding the anticoagulant, you are increasing the other risk. So these are indications for treatment in mallory-bees. Stigmate of bleeding there, patient requiring the having coagulopathy, requiring the anticoagulant, they must be treated. This again diagnostic problem, the patient with SCB-related cirrhosis with recurrent bleeding. This is the lesion after 2 weeks of index endoscopy. I was not sure what to do for this patient, so we just left it like this is the lesion, and this was not varices. We did the CT scan. There was the CT scan was not continuity, and 2 months later admitted again with hematemesis. And this is the lesion which was most likely bleeding in this patient. I mean, what should we do for this patient? Just quick comment.
Seems like injectasia, we can go for APC or something like that.
So, we just injected 1 ml of glue beneath this lesion, and after that patient never had a bleed. Most likely this was a Dulophi lesion to us. Any other comment on this diagnosis? Was it Dulophi or something else?
It looks like Dulophi is here, Sanjay. So, but even band works very well.
We were not sure what was that, so we decided to inject the glue beneath the lesion, and luckily that bent into
luckily
the
you
culprit
came out, but see, glue is best injected if you are there in a vessel, so or an ectatic area.
So for our side was too empirical, we were not sure what was that, but luckily there was no rebuild after that. This is again patient on aortic valve replacement on acetrom, had massive bleed, and I will discuss the case leaving this thing. So we did the endoscopy. The endoscopy, everything was full of blood. We could not identify where is the ulcer from where the patient was bleeding. But my impression was the ulcer is in the pyloric channel or first part of the duodenum. During endoscopy, patient had drop in the BP, unstable, we stopped. What should we do the Preetham? Just quick comment. What investigation we should do next?
In this case, we should go for a CT with angiography for outer and abdominal vessels.
Yes, we did the CT angiography. Now the question to radiologist Nitin, you see there's a free air in the abdomen, outside the bowel, there's a air. Most likely we have did perforation. That was in our mind.
Yeah, there is free air. and there are few clots seen even in the bowel loops. So in the run, I could not see any active bleed anywhere in the vessel.
Okay,
So
I'm playing it again. You can see our radiologist reported there was some bleeding from the GDA
if you
branch.
can
GDA branch,
just
you
go
can
it
see
slowly.
here.
Yeah. So there is
GDA
the
branch.
bowel
So
loop.
we have a patient with failed endoscopy, or we cannot do anything on endoscopy. Now there's a year. What should we do? The question to the surgeon and surgeon and radiologist. Endoscopists have failed here. What should we do? Ajay sir. And remember, the patient is aortic valve on anticoagulant. INR was 4.5 and requiring the anticoagulant further also, after your surgery also. You cannot stop the acetylene because there is recently placed aortic valve. Patient will die of aortic valve thrombosis.
The free air is there, the perforation is there. So you need to operate the patient.
Will you operate the patient?
Yeah, need to operate the patient.
So we decided with our team, because there was very high risk for surgery, we did the angioembolization in this patient. And Dr. Sethi, you can read all these pictures black and white because we are more familiar with the color pictures, not with black and white. So our radiologist embolized the vessel. And the question is CT is mandatory before doing all your procedures? You just go for directly before doing the CT, because doing CT has complicated the matter.
If the patient is able, if fit enough to do undergo CT scan, we would definitely ask for a CT scan, because that gives us a roadmap. We don't have to hunt for the bleeding vessel. We know where it is.
Any contraindication doing the embolization?
If it's transarterial bleed, then the only contraindication is if it's a venous bleed. That's it. Any arterial bleed, we should be able to embolize.
Just can you enumerate what are the common cases you see in your practice?
In my practice, I am from Tata Hospital, so predominantly it would be malignancies, say GI, for stomach malignancies, pancreatic malignancies, CAGP.
You see the more of malignancy, the patient was...
and post chemo, post RT changes.
So in this also, one thing, all throughout your patients having aspirin and clopidogrel.
Acetylene?
No. So two things, just comments. First of all, the coagulation has to be established. I mean, coagulation has to be corrected. This patient is on an aortic valve replacement and the INR is 4.5. But for the time being, his INR has to be brought down. It cannot be on this INR. Even if you puncture, do a angioembolization, you puncture, you have a high risk of bleeding. So you have to give FFP to bring it down so that within next 48 hours to 72 hours, you should not have an anticoagulation on board so that bleeding does not happen. One. Second thing, anytime you give aspirin in throughout the discussion, please also look at into the structure where aspirin not only works on the qualitative, because there's a qualitative dysfunction of the platelet which happens. एस्पिरिन देने के बाद 7 दिन तक प्लेटलेट का क्वालिटेटिव फंक्शंस खराब रहता है, क्वांटिटी नॉर्मल रहती है. पर जब भी आपके पास जीआई ब्लीड है, so please look at the coagulation parameters thoroughly. The platelets are above 1 lakh. Second, APTT PT is normal, and then all these measures can all be targeted very well.
Sir, can I have a comment on this?
This is a bit controversial. What Dr. Rahul
Aspirin only works on the.
Aspirin
doesn't
no
decrease the
recommendation even to stop aspirin.
No, so don't stop the aspirin. So only thing is you have to, if the platelet is less than 50,000 and you have a bleeding patient, you will try to correct the platelets and not only do the local measures.
The recommendations are that don't wait to correct the INR. You go ahead. You can give the plasma and patient will massively bleeding. Give the plasma, give vitamin K, but the action is very slow.
I have a question for you.
But so maintain the INR in therapeutic range. In such patient who is aortic valve, if you make the INR normal, the patient will die of aortic valve thrombosis.
No, sir. थोड़ा सा confusion हो गया. हम ये कह रहे हैं कि आप उसको normalize मत करिए, but आप उसको coagulation parameters को अपने algorithm में रख लीजिए, so that those needs to be corrected.
That's okay.
Sir, if may I add, I'll tell what we do it. So in such a situation, we do not wait for the entire correction. I completely agree that we start correcting.
Yeah, we have a separate dedicated session for that. Can we go to some next?
So sir, FFP will give you in 1 hour, it will correct because 250 ml will have, every factor will have 1 ml into that.
We have a separate session for that.
The moment you give it,
I think let's allow Dr. Hari to go further because we have a full session on this.
We have a separate dedicated session for that.
And Dr. Umesh is there.
How many times do you see complications of angiography?
Angiography?
Yes, I mean.
When you say complication, what? When we know
so
that.
Right now I have a patient who had a similar episode and he was selective angiography was done and embolized. his whole duodenum necrosed because
Bleeding from that, sir, from tumor.
the entire duodenum has necrosed.
So that should be very careful as to what feeder we are embolizing. So
And
if
done
it
by a
is-
very experienced intervention radiologist.
So the type of the embolizing material also makes a difference, and one of the important thing that we need to see is how much of the bowel is getting perfused from that particular artery, and if it
GDA.
is not safe, we should not do.
Sir, the patient had gas under diaphragm and you chose a non-operative management because you said he was high risk for surgery. So you chose to save him from bleeding and let him die of sepsis. What other factors were there that you did not choose surgery? A gas under I don't want the message to go across that a person with a gas under diaphragm means a hollow viscous perforation, and that means the patient, unless he doesn't have gross contamination, is going to end in sepsis. So why did you choose a non-operative management in this patient? Let aside his risk. His risk of death is 100% even if you leave a...
There were multiple reasons for choosing the non-surgical management, because our surgeons say if I operate, this patient is going to 100% die. This is one option. IR may save this patient. One, why? There was some confusion if you see the...
But IR will only save the bleeding, sir.
Let me speak. There was some confusion among the radiologists. The ear was intraperitoneal or extraperitoneal. There was some, and it was not the ear, it was the CO2. We always use the CO2 during endoscopy. So in this patient, after angioembolization, we were also thinking that patient may die of sepsis because of perforation. So next day, we did the CT scan by putting the contrast in the RALS tube. And luckily, there was no leak. And this patient, after 48 hours, we started the nasogastric feed, and the patient remained stable and could be discharged. So this was either contained small leak and it was a CO2, and there was no contamination of the peritoneum, no fluid and outside the, so that's why the patient survived. Otherwise, doing the surgery, this patient would not have survived because of the surgery, because of a very sick patient.
Just quick comment regarding the stoppage of anticoagulation and bringing down the, I think, parameters, coagulation parameters.
I think, sir, we have dedicated session for that.
I'm only going to talk. Just I thought I'll do a brief comment on that.
Yes, okay.
I think it's already been alluded to.
Sure.
Aspirin should be actually continued. That's no problem. Whether you continue or you don't continue, it's not much of a difference. Anticoagulation has to be stopped just at least 2 days prior. That low molecular weight heparin has to be given prior to the procedure, and 1 day prior you have to stop it. And in spite of that, if there's a bleeding ongoing, you have to offer the therapy. You can't actually wait for the therapy to go on. Thank you.
Yeah, this is the recommendation regarding the anticoagulation. Stop immediately and achieve the coagulation, then start as soon as possible, depending on the thromboembolic
You don't have
risk.
to wait. You don't have to wait for the coagulation to get completely
There's
corrected.
no need to
As
wait.
it is being
Yes,
corrected,
yes,
still you can
definitely,
continue
definitely.
therapy one.
So,
other than that, INR up to 2.5 is also acceptable to go on along with the treatment of endotherapy.
Endoscopy should not be delayed while
Anything
coagulation-
supratherapeutic is anything more than 3 or 4 is supratherapy, but less than 2.5 you can still go with the
Still okay,
endotherapy.
okay.
That's very clearly
Yes,
mentioned.
definitely.
Actually, even patients who have deranged coagulation, they bleed from a certain source. So you have to control the source.
the source.
They are bleeding
Without
from
that,
the
you are
artery.
not going to achieve anything. Yes, right.
Hari, you can quickly finish off.
Yeah, I'm just rushing this. So, this was the patient presented with hematemesis. The endoscopy, this was the small lesion. They had history of pain. Is well alcoholic. What should we do next? This is endoscopy, not contributory. This is some minor lesion. We also not sure what is that. But there's significant pain, alcoholic.
So it may be an angioectasia looking like.
Yeah, this may be significant, may not be significant. Don't forget the pain. The patient has a significant pain abdomen. I was alcoholic, so this was the aneurysm in the territory of gastroduodenal artery. So there was a bilobed aneurysm and it was treated by our interventional
Hari,
radiologist.
do you interrogate such a lesion endoscopically?
The previous one.
Yeah.
Yeah, we just thought this could be the source, this could be the source. That was in our mind. What to do for
I
that?
mean, do
We
you
thought could be-
endoscopically and gently interrogate that lesion?
No, we just
can-
used the water jet to flush it. It was like that only. That was in our mind. This could be the site of bleed, but significant pain. We did, and history of alcoholism. We did the CT scan and we found the aneurysm and it was embolized successfully. So another patient, cirrhosis, bleeding into the stomach, and first endoscopy. There was no aneurysm and no active bleed, CT angio. So we asked surgeon, he said we cannot do anything, and at the most I can do the big surgery, remove the pancreas, remove this vessel, and we just decided to wait. Will you do surgery in such cases you are not sure there is a big pseudocyst from where is bleeding? So surgery obviously is very difficult without any knowing any reason. The patient again had second bleed. It was again massive bleeding from the same pseudocyst. This time we did the CT angio, we found the aneurysm. So CT angio versus conventional angio, which one is better? Again, same question, should we do the CT angio or not go ahead with the conventional angio?
So here we know the cause is in the secondary to pancreatitis, and there are very little vessels that you need to target. Either you go to the celiac SMA and you would pretty much find the bleeder.
So second time we found this aneurysm in the territory of...
Had you put in a LAMS in this patient? LAMS डाला था क्या इसमें?
नहीं कुछ नहीं, nothing. And this patient had aneurysm and that was treated. I can skip this case.
We can
so
just have some
audience
interaction and finish.
Yeah. Now there's a neurotherapy. Dr. Mohan can comment on all these things. Now we can take any questions from the house regarding all this. So, in summary, when you see a patient of acute upper GI bleed, assessment, risk stratification is very important because that is going to decide the line of treatment. And it is very important to take appropriate care of comorbidities, particularly the cardiac patients who are on antiplatelet, anticoagulants. We are seeing more and more patients with antiplatelet, anticoagulants. Resuscitation, adequate blood, not too much, not less. Timing of endoscopy is very important. Doing early may not help, but in patients who are continuously bleeding, not responding to resuscitative measure, you have to go in. While treating the patient or doing the endoscopy in sick patient, you have to have good anesthesia team, good critical care team. You may need the intubation also. And the endoscope with water jet, distal cap, they are very important treatment of GI bleed. You must have all the tools in your endoscopic room, clips, OTSC, thermal probes, APC, cautery, and do the appropriate endoscopic therapy. Which tool to use? You have to decide by seeing the ulcer position, ulcer size, ulcer character, and your own experience and capabilities. Post-endoscopic therapy is very important. PPI are very important, reducing the rebleed rate. Must test for the H. pylori, patient requiring the co-therapy with the PPI. Advise the long-term PPI. And backup plan is very important. Intravenous radial is very important. Having the surgeon is very important. In last, I can say, in 10 years, only one of patient required the surgery where endotherapy failed, IR failed, and that patient required the endoscopy surgery. Ultimately, the patient died of sepsis and multiple problem. Thank you very much.
Thank you. I think we'll have to wind up. We cannot have questions here. Let's move to the next session.
Thank you, sir.
We can discuss it during lunch.
Yeah, hemo spray basically it's a powder. When you spray over any bleeding site, it forms a layer and this stops the bleeding. At the same time, it increases the concentration of coagulation factor. But the rebleed rate is very high and it can be used in any locations, and it is particularly useful when there is a bleeding from tumor. We are applying the hemoclip, all these things are very risky and they don't work. So in those cases it is very useful, but most of the cases require the second therapy also because the rebleed rate is up to the tune of 30%.
Now since you have raised the point of a local action, you are talking about hemo spray, there are 3 more kinds of sprays, endoclot is there,
yes,
Nexus sprays is
3,
there.
4 available, yes sir.
But there is something new which has now come, that is Purostat. I don't know whether any of us have any experience of Purostat in India. That's a kind of a gel which acts exactly by topical action, but the advantage is great. You can see everything below that particular gel. Hemospray actually covers the entire bleeding lesion. If the entire view gets obscured, so if the patient bleeds any substance, you are unable to see that and you cannot actually know. So Purostat actually works better. I still remember Boshen talking most often about this in AIG, this latest conference. That is America, they are using Purostat. I don't know, Mohan, whether you have any experience of Purostat in India. That local gel.
Yes, we recently used it it will be good for oozing blood. And as you said, in comparison to the powder which completely obscure the vein, this is a transparent gel. So if you are doing a procedure like M or ESD, where you want to stop the procedure, this is good material to have, but when there is a actively spurting bleeding, it does not help us. It also helps in preventing post-ESD strictures because it's a polymer which is placed over the surface. So it's not like a wonder drug, but yet it has got some.
Sir, I have one more minute. Mohan, one more comment on your experience on use of US guided therapy for vascular, means this peptic ulcers or kind of thing. US guided therapy. Your experience.
I think he has already left.
Okay.
So he has another session in the afternoon. You can discuss at that time.
Thank you very much. Thank you, everyone.
Thanks all the
Thank you all the panelists.
panelists and chairpersons.
Recording stopped.
In fact, best is that you have to have such a team which was sitting in the center and side. So to manage a case of non-varicose GI bleed.
I would like to invite the moderator, panelists, and the expert discussants to please join us at the selfie point for a group photograph. Now, for the next panel discussion on the topic, hemoperitoneum, traumatic and spontaneous, I would like to invite Dr. Sandesh Sharma sir and Dr. Salim Nayak sir as the moderator, followed by the panelist, Dr. Vineet Gautam sir, Dr. Mahim Kosharia sir, Dr. Shekhar Srivastav sir, Dr. Prakash Sonkosari sir, and Dr. Kamlesh Talsera sir. I now invite our esteemed expert discussants to please join us on the stage. Dr. Y.S. Raghuvanshi sir, Senior Surgeon Guna, Dr. Atul Agrawal sir, GI and Laparoscopic Surgeon, BELS Hospital Bhopal, Dr. Jyoti Valecha ma'am, Senior Pathologist Bhopal, Dr. Abjeet Deshmukh sir, GI Surgeon Bhopal.
Good morning, everybody, and a warm welcome on behalf of organizing committee. I am one of the person who is in the organizing committee. Fortunately, I have been given a task to complete a moderation in one of the very common problem that we face right from our residency days up till we finish our practice. So the topic of today's discussion, we have a panel discussion on hemoperitoneum, and I had my colleague, my friend with me to support me and conduct this session on hemoperitoneum. I welcome all my panelists and Dr. Salim to start the proceedings.
Thank you very much. I am a student of Dr. Sandesh. Whatever I've learned in GI surgery, most of it has been taught by him. So it's a pleasure to be with all of you today. This topic also has increased importance in this day when we are at war. So if we are ever called as gastroenterologists or GI surgeons to help them, so hemoperitoneum is going to be one of the conditions we all should be familiar with. So we want to familiarize the doctors with various aspects, the diagnostic and therapeutic interventions, and when to conserve a patient and when to operate, and how important the multidisciplinary approach is. That's why we have a distinguished panelists sitting from different specialities. So hemoperitoneum is the presence of blood within the peritoneal cavity, which is usually secondary to trauma, or sometimes it's spontaneous because of rupture of vascular or visceral structures like peritonitis. Unlike peritonitis, which is infection-driven, hemoperitoneum requires urgent resuscitation and surgical control of hemorrhage and not antimicrobial therapy as a first line. Why it matters? It's life-threatening if not managed timely. There are various diagnostic and therapeutic challenges. It's often missed. So it requires prompt and coordinated care. So what are the key causes of hemoperitoneum? It's usually because of trauma, which is usually solid organ, spleen and liver being the common organs. It can happen because of, on its own, because of ruptured ectopic, aneurysmal rupture, mesenteric or bowel vessel tear, iatrogenic during an injury in an abdominal surgery or during laparoscopy. So we will not be speaking much about spontaneous hemoperitoneum, which occurs without trauma, and because we do not clinically suspect it, so the diagnosis is often delayed. So the etiological spectrum is HCC rupture. Gynecological, it happens because of ectopic pregnancies, we all know. It happens in patients who are on anticoagulants, in variceal rupture and hemorrhagic pancreatitis. So as a surgeon, how would you assess the hemodynamic impact of hemoperitoneum in a patient? Dr. Mahim, would you want to take that?
Hello. Good morning, everyone. So as a surgeon, when we come across a patient of hemoperitoneum, as you have said, we will be discussing more on the trauma. So you should have a higher suspicion. You must clinically evaluate your patient. You should look for all the parameters and signs, looking for tachycardia, hypotension, cold extremities, and any clinical observation and signs, abdominal signs, abdominal distension, guarding, rigidity, any fluid in the intra-abdominal cavity that will, you can assess the free fluid inside that. And definitely you will like to have fast and e-fast examination bedside as a bedside, very important tools. So that will give a fast assessment of the abdomen, and for taking, preparing your patient for if he requires any OR shifting or immediate exploration. Now, why fast? Basically, it's a focus assessment with sonography for trauma, and you can assess all the quadrant, right and left, hypochondrium, pelvic area, and pericardial area. And simultaneously, if you access the chest area, that is e-fast. And like the trauma patients, mostly the solid organ injuries and the liver injuries and splenic injuries, most likely they are associated with hemothorax also. So that can be simultaneously taken care when you look for. And this detect intraperitoneal free fluid, and though it has its own limitations for detecting solid organs, and CT is a better modality, though, and it has a 90% sensitivity and 95% specificity.
Okay, Dr. Mahim, thank you. Regarding the fast, I would like to ask Dr. Kamlesh Talresa, when would he recommend the patient for CT scan? And what are the information that you can obtain by doing a CT scan? Would be a plain CT, contrast CT, or triple phase CT?
So, as Dr. Mahim said, so when patient is not hemodynamically stable, the immediate thing possible is the fast. So fast becomes the best option when patient is not stable, and immediate decision is required. So it can be done in ER, it can be done at the bedside. When patient is relatively stable, because for the CT some logistics will be required definitely. So if patient is relatively stable, patient can be, and in cases where we are suspecting either polytrauma, we are suspecting visceral injury, bowel injury, then CT definitely has advantage over ultrasound, because for the solid organs, for the bowel injury is very difficult to pick up on ultrasound. Again, localizing exactly the solid injury, solid organ injury, where the injuries is, what is the nature of injury, what can be the treatment option. So CT helps there. And in cases of polytrauma, it becomes very imperative to have a CT that includes, and even in those cases, CT includes right from the head, neck, chest and abdomen up to the almost groin region, so upper femur, it includes the pelvis. So that it becomes comprehensive assessment. But yeah, definitely this, to an extent, patient should not be very unstable to undergo the CT. Contrast CT, see, contrast CT, role of contrast CT will come when clinically we are suspecting some definite vascular arterial injuries which may need vascular management in those cases, or in those cases where the plain CT is equivocal, where there are suspicions, suggestions, but there is no definite conclusion. In those cases, contrast CT can make things better.
So you mean to say it should be preferably a contrast CT?
I have to add one point. If we are suspecting liver injury and we have to see whether the bleeding from hepatic artery or portal vein or hepatic vein, then we should go for triple phase or contrast for see the exact vascular injury.
So in nutshell, a CT scan is a very good tool to give a comprehensive picture regarding the site, source of injury.
Yeah,
and
I will just one point I can add to this. So nowadays with the current CTs available, when we are doing contrast CT, so see, contrast CT and CT angiography, this discussion was in the previous session also, now it will be remain. So it doesn't make much of the difference basically in the amount of contrast as well. So wherever there is in the mind that we need to see vessels, so we are just changing the protocol. Almost same amount of contrast, we put the patient for contrast CT. So then first RTL phase makes the CT angiography and followed by a phase which gives the CECT information. So the same study will do everything. So it is very much possible. So we can go in most of the patient with contrast angiography followed by CCT.
Now a question to Dr. Jyoti. Would you any time recommend MR for patients of hemoperitoneum? What is the role of MRI or MR angiography?
You're not
MRI is useful in special scenarios, like if the patient is pregnant, because at that time the CT is contraindicated. Otherwise, CT plays the primary role, or sometimes in the spontaneous hemoperitoneum, like in the postpartum patients, if the patient presented with a spontaneous hemoperitoneum, to look for uterine rupture or any retained products of placenta. Otherwise, CT is the primary modality in pregnant patients, but MRI will help.
Thank you.
Dr. Kamlesh, how would you distinguish between an acute hemoperitoneum and other causes of free fluid on CT or an ultrasound?
Okay, so yeah, so right from the ultrasound, it helps us. In ultrasound, we can see the nature of the fluid. So on the ultrasound, we can see whether it is a clear, homogeneous, anechoic fluid, then there are high chances that it is transudative fluid of other nature. When in hemorrhagic fluids, you will either get in the form of some internal echoes, dense internal echoes. Even when the clots are there are hyperechoic clots. You can see separately hyperechoic structures. Even in cases of hemorrhages, you can find fluid levels. So dependent hemorrhagic fluid, along with that, the relatively lower density fluid, also fluid levels are possible. When come to CT, so CT gives you the HU values specifically. So in CT, blood, when there is a hemorrhagic contents or there are clots, the CT values are more than 30 up to 70. So 30 to 70s are the hemorrhagic contents. Below these usually are the transudative fluids.
Dr. Shekhar, the next question is for you. When do you think is an immediate laparotomy indicated in a case of hemoperitoneum?
Basically, if the patient is very much unstable and all our efforts to bring the BP and everything normal, distension of abdomen increasing, there is a clear-cut sign there is a hemoperitoneum, and we are not able to go for the CT or MRI or angio, then it is better to open the patient earliest.
I think one of the important thing regarding hemoperitoneum, somebody having a penetrating injury, you should have a very low threshold for opening.
If we are suspecting peritonitis, then it is also indication.
Yeah. In the last session, that's the exact reason why I stood up and objected to the fact.
So if we are suspecting peritonitis, then we have to operate anyhow.
Yeah.
Okay. Question to Dr. Vineet. What are the surgical options for managing a ruptured spleen with hemoperitoneum?
So first, if we are operating on a ruptured spleen, we have to see the amount of spleen ruptured, whether it is partial or completely shattered. So depend, we can go for splenography or just compression or packing.
We need to keep it little close, Mike.
Or partial splenectomy or complete splenectomy. So depends the amount of spleen ruptured. If it is only limited laceration, then we can go for packing only. And if less than 1/3, then we can go for partial splenectomy also. But if there is shattered spleen, massive bleeding, severe hemodynamic instability, then we should go for complete splenectomy.
Okay, just a small question. Do you decide operating on a spleen based on splenic trauma grading?
So it depends on clinical signs, vital stability. If patient is unstable, then it doesn't matter.
So the decision of operating on a spleen is basically depends upon the clinical condition of the patients, not on the trauma grade. They are just a guide that what level of seriousness we are facing.
Another question for you again, sir. Would you talk about the grades of liver injury?
Previously, before 2018, there were 6 grades in the liver injury, but after 2018, there is revised grading, and now they are also having only 5 grades. So it depends on the subcapsular hematoma and depth of laceration.
whether less than 10%, 10 to 15% subcapsular hematoma or more than 15%. So depends on first and second and third grade. And again, depth also less than 1 centimeter, 1 to 3 centimeter, more than 3 centimeter. Then the involvement of the lobe, 1 to 3 segment or 25 to 75% of one lobe involvement is grade 4, and more than 75% one lobe involvement or more than 3 segment involvement, that is grade 5.
Is there any special grading for a hilar injury?
No, there is no special
So
grading.
it's not like spleen where there is a special grading for hilar injury. For liver, there is nothing like it.
So, when you are exploring a patient for a liver injury, sir, how would you manage it? What are the things we need to know if we need to explore a patient for a liver injury?
First of all, we have to see the hemodynamic stability. If patient is hemodynamically stable, we have to monitor clinically, and we have to monitor hemoglobin 12 hourly or 6 hourly, depends on that. If patient is stabilized, then we usually doesn't operate. I have managed up to grade 4 injury conservatively, and patient recovered very well. Even one 9-year-old child and one 12-year-old child, both have had grade 4 injury and both managed conservatively. So till now I have not operated on, I have seen during my training only. So if severe injury, hemodynamic instability, then we have to operate. Then once we open the abdomen, we have to see the amount of bleeding. What is the amount of bleeding, how much there, whether bleeding from hilar structure or from the liver side. So initially we try to debride the lacerated part and packaging only. If it doesn't stop by that, then we have to suture the bleeding point. If not stopped by that only, or we cannot suture because of so much liver laceration, we cannot go there, then depends on lobe, we have to go for either segmental resection or complete right or left hepatectomy. I have seen one right hepatectomy during my training period, but during my post MCH, I have not operated, only managed conservatively up to grade 4 injury.
I might just add a little bit to it, sir. When I went into private practice to Delhi, people would not refer patients to me, not the routine cases, but a lot of people used to call me for emergency surgeries, and many of them for road traffic accidents, especially on the Agra-Delhi road. So there was one particular hospital which had a very good infrastructure, but the first few cases which we did there, both of them died. I have operated 4 liver traumas there. So later on I realized, because I was a traveling surgeon, I used to come and I used to ask them, take the patient to the OT, start this, and there was a general surgeon, I used to ask him, you open the patient, then I would reach. So I realized a patient lost a lot of blood in that particular, that procedure in opening up the patient, everything. So next time, whenever the next trauma happened, I changed my practice and I would not allow them to touch the patient till I did not reach there, and we did not have adequate blood and the products there. Because the tamponade which the liver gives them in a trauma patient does somehow congest bleeding. I have done even IVC repairs in one of the patients. I did an IVC repair also, but we successfully managed to save that patient. So one of the things is we have to be prepared if we have to operate at all, that is. So of course, I absolutely agree with you. Majority of the patients would never require surgery, but if there is a vascular injury and we do need to go in, so we need to be absolutely prepared before we open a patient of liver injury.
Of course, similar my experience during my training only. The patient had a severe injury, grade 6 according to that time, and we operated that case, and that patient didn't survive because of massive bleeding.
Shekhar sir, would you explain Pringle's maneuver and its surgical relevance?
Basically, the purpose of that is the compression and to hold the bleeding. And if it is not there, then you can apply a clamp. The temporary clamp can be applied at the hepatoduodenal ligament, which can compress the portal vein and hepatic artery for some time, and you can get a time for that.
I have a question to Dr. Adala. How long you can use Pringle during the operation? For one sitting, what is the longest duration you can safely apply Pringle?
We usually try to avoid it more than 15 minutes, sir. We every 10 minutes will
Okay.
use.
Okay, so the bottom line is that normally these trauma patients, they are young patients, they had a normal liver, most of the cases, and a total portal clamping can be tolerated by the liver up to 15 minutes. Had it been a diseased liver, in which there is an SCC or and there is a background liver disease, the Pringle should not be extended more than 8 minutes. That's normally the standard guideline.
Sir, I have to add 2 points only. By Pringle manner, first of all, we have to see that whether bleeding from portal vein or hepatic artery or from hepatic vein. If bleeding is from hepatic vein, then the bleeding will not stop even after Pringle maneuver. So we have to differentiate this thing. Second, for the timing, cumulative timing, we can go for Pringle maneuver in normal liver up to 2 hours, cumulative timing. But after 15 minutes, we have to give 5-minute gap.
Yeah, so the question was very straightforward. One single setting. So one single setting, like Dr. Adala said, it's for 15 minutes. As far as the importance of it, even if it is a hepatic vein injury, it does give you a better field of vision to actually pinpoint or localize. So Pringle is a must in most of the time whenever you are operating upon liver trauma patients.
Sir, any tricks?
One more thing I would like to. It's not only in the hepatic trauma, but this is a procedure which at the resident level you should be able to know. There are various emergency situation, bleeding situation while operating hepatobiliary gallbladder surgeries, and you may come across bleeding also. So this is a procedure which everyone should know how to control intraoperative bleeding.
Dr. Prakash, a question for you. How would you handle anticoagulated patients who present with spontaneous hemoperitoneum?
After the initial stabilization, we can use the reversal agents in cases of anticoagulants. If the patient is on vitamin K anticoagulant, we can use the vitamin K or FFP, or you can use the prothrombin complex concentrates, either 4 or 3 factors. And if the patient is on other agents, like low molecular weight heparin or conventional heparin, we can use the protamine. If the duration of the use of heparin is shorter, less than 3 hours for the standard heparin, if it is less than 12 hours for the low molecular weight heparin. Other agents are also there, but they are not easily available for the factor 2 and factor 10 agents. And we have to monitor the coagulation profile repeatedly, and as soon as the patient is stabilized, we can go for the surgical intervention if it is required.
Dr. Mahim, you have operated a patient. You wanted to add something, sir?
The evaluation of a patient on anticoagulant is very important. Sometimes there is a bleeding from the gastric ulcer and underlying vessels. So it usually doesn't stop with vitamin K FFP. So you require endoscopy with clipping also that vessel. I have seen 2-3 patients such kind of patient. So it requires sometimes it won't stop by the conjunctive management only.
That's very obvious. I mean, you have to treat the disease as well.
So, Dr. Mahim, the next question is for you. You operated a patient with hemoperitoneum and you're managing the post-op. What are the red flag signs?
So in a post-operative period, it's very important to monitor this patient very closely, and if there is a increased drain output in form of bile or blood, despite of resuscitation. So this is an important thing. There is any clinical abdominal signs, rising abdominal girth, and there is a persistent hypotension despite of IV fluids. So these are the very important signs. One has to be careful, and if there are any signs of abdominal compartment syndromes, if there is raising renal parameters and rising lactates, and if there is any coagulopathies which you are seeing.
My question to Dr. Atul regarding, do you believe in serial HB monitoring on a post-operative status?
No, it could be very erroneous and quite misleading, to be honest. In my practice, I normally see the urine output as the most important sign of monitoring the patient who had an operation. Because anybody who has got a reduced renal perfusion will probably drop his hemoglobin, drop his urine output, and that is very good indicator for monitoring point of view. The serial hemoglobin level is of no importance because the patient has got probably misleading. If somebody has had transfusions, probably it's not gone up to that level. So post-operative monitoring of the hemoglobin itself is not that important. Hematocrit value itself can be more important, because drop in hematocrit value will indicate that probably the patient.
Yeah, that's a very good point. So hematocrit is more important than HB monitoring. If you at all, you have to monitor these patients, do hematocrit rather than hemoglobin.
Dr. Prakash, next question is for you. Do you think there is any role of medicines in controlling these types of bleeding in a hemoperitoneum?
We can use the tranexamic acid in such cases if we are not sure about what is the cause of bleeding until the time we want some control. So it is found that in CRASH 2 trial, if we are using this agent within the first 1 hour, it has the maximum effect. On the first 1 to 3 hours, it has a moderate effect, and after 3 hours, it has not that much effect.
Can I add something here? In patients with portal hypertension, sometimes you can have bleeding from peritoneal varices. We have seen one of such patients, and especially in those conditions, somatostatin or terlipressin may be important.
Yeah, in fact, when we do shunt surgery, sometimes we start primitive somatostatin infusion to decrease the pressure, and that does help in actually handling the various collaterals during our operations.
So now Dr. Sandesh will be presenting a series of different cases in hemoperitoneum. We'll like all of you to participate wherever you think you can give inputs.
So these are the couple of cases that we have collected over time. Our first case is 45 years old nurse. She is actually a pediatric nurse working in one of the hospitals in Bhopal. Suddenly presented with to the emergency with pain in abdomen and the features of shock. She was initially evaluated, resuscitated, and an ultrasound was done, which suggested some collection in the pelvis. She also underwent a couple of tests like urine pregnancy test, which was negative. The hemoglobin was 7.9, 610, and the ultrasound was suggestive of right adnexal mass, significant amount of free fluid in the pelvis, consistent with the blood. What is the probable diagnosis, Dr. Shekhar?
Most likely the ectopic pregnancy, ruptured ectopic pregnancy may be the
Now this is 45 years old female, had a 20 years old son, UPT negative. And she, in history, she's saying she had just a couple of, like the normal menstruation.
Beta HCG is raised.
Okay. So in this, the clue is that there is a collection in the pelvis. The menstruant that she was actually saying that she had a normal menstruation was just a spotting, and which is common with the in cases of abortions or ectopic pregnancies, and there is a definitive amount of blood-like collection in the pelvis. So what will you do next?
Once the patient is stable, we will go for diagnostic laparoscopy, and then we can go for the...
Why laparoscopy? Why not open?
That depends upon how chronic the things. If it is fresh, it is better to go by laparoscopy because you can save the
so if the patient is stable, you can go for with laparoscopic.
Yeah.
What are the problems of laparoscopy that you face, Dr. Vineet, when you operate on something like, of course, ectopic not routinely you operate, but as a surgeon, you sometimes.
If the amount of blood is more than, if we immediately put the site will not visualize, the camera will contaminated, and difficult to put the laparoscope or creating pneumoperitoneum in that cases. I have to add a few points in the diagnosis. As the more than 35 year age is a risk factor for ectopic pregnancy. Second thing, UPT usually comes positive after missed period, 1 to 2 weeks of missed period. Immediately after conception, within 4 to 7 days, only serum beta HCG will rise. So UPT is definitely we cannot rely on
so
that.
UPT should not be is not a reliable. That is what the message that we want to
Until unless patient is having missed period, there is no reliability. Usually it comes after 1 to 2 weeks after missed period.
Second case.
There is a role for serial beta HCG levels. If this is not acute urgency, if you are just conservatively following, then serial beta HCG will give you a clue.
For diagnosis of pregnancy, we are suspecting, then serial.
So she underwent a successful laparoscopic tubectomy and removal of the embryonal sac. Patient recovered very well, and the recovery was uneventful. Our next case is 12-year-old male had a fall from bicycle, had a cycle handle injury, presented in emergency with a right upper quadrant pain, features of shock. Dr. Vineet, what will you do next?
So first presenting complaint, as you told, injury at the right upper quadrant and with pain, and the vital sign is unstable. So first I will assess clinical sign and will go for ultrasound of the abdomen. So what is the injury, why he is having such kind of symptoms? So most likely the site of injury in right upper quadrant is usually liver. So first investigation will the CBC, vital signs, hemoglobin monitoring and ultrasound.
Dr. Jyoti, would you like to suggest something at this point? Like, or would you straight away go, I mean the question is that, like, would you straight away go to for a CT scan, or you'd like to do an ultrasound and then go for a CT scan?
We can do the ultrasound, but if we see the free fluid collection, then we will go for CT scan. But if there is no free fluid and the patient stable, then we can wait and watch also.
Again, the same thing. If patient is clinically stable, we can go for CT scan. But ultrasound, we can go for bedside also, immediately for ultrasound.
That is fast that we have discussed. So the CT, can you see the CT image?
Yeah.
Dr. Kamlesh, would you like to comment on the CT scan? They are not full pictures, but probably an arterial phase.
So there is heterogeneity, hypoechoic, mixed hypo and hyperechoic and hyperdense areas. In the segment, this is the segment 7 of the liver, right lobe. So definitely there is a small to moderate size area, and then the kidney is also involved. So right kidney appears to be again showing the areas of contusion, laceration. So this is the possible liver as well as kidney. And there is definitely there is a hemoperitoneum. Lower down there is a fluid possibly in the pelvic area.
So Dr. Vineet, this patient had liver injury on a scan with no hematuria. How would you manage?
And the most probably is a grade 4 injury, level laceration approx 25% must be. So if patient is clinically stable, I will go for conservative management only. And if patient remains clinically stable, then we will do conservative treatment and hemoglobin monitoring. That will be the only thing.
So this patient is actually Dr. Vineet's patient. He managed this patient conservatively. Despite having grade 4 injury on a segment 6 and 7, the patient did very well on conservative treatment, and I think recovered in 10 days and was discharged successfully.
I would like to add something. This is very important thing. So whenever you take up any conservative line of management, non-operative management, it is pertinent, very important to rule out the hollow viscous injuries. And even small, this younger patients, colonic injuries are the very tricky injuries. They will present not immediately. Even they can present you after 2 weeks also. We have operated, we were on verge of discharging a patient, but that patient after 2 weeks started having tachycardia and all signs of peritonitis, and it was explored and found to have colonic injuries. So colonic injuries post-traumatic, they can present later on also.
Yeah, that's a good point.
Dr. Sandesh,
yeah.
Just wanted to go one step back about the question about sonography versus CT scan as the initial imaging modality. So I think it is justified to do a sonography first, because like you have said, it was injury in which the cycle handle was sort of injured the abdomen. So it is not necessary that it would be a liver injury up front. You cannot say. It could just be a muscular injury. A hematoma could be there, which is causing the child tenderness and pain. So then initial ultrasound, if it doesn't show any liver injury, if it doesn't show any intra-abdominal hemoperitoneum, then we might not need a CT scan for the child either.
Okay.
I think CT is better, sir.
So the point is well taken. We would like to run through the cases. We have a couple of cases, interesting cases. So next case is again a trauma patient, 80-year-old male, had a road traffic accident, met with and then presented in emergency in a state of shock. he had a blood pressure of 80/50, respiratory heart rate 130, cold peripheries. Initial management was, of course, resuscitation at ICU. A fast scan revealed free fluid in abdomen. Further CT scan was contemplated, and these are the CT run. Okay. Quick comment by Dr. Kamlesh. We are running short of time, so just brief.
So this is high-grade liver injury along with that gross hemoperitoneum. So, and there are multifocal lacerations, large lacerations. So, yeah, definitely high-grade injury with the gross hemoperitoneum.
So this patient had a shattered liver, very high-grade injury, but fortunately the hilum is preserved. Dr. Vineet, how would you proceed? What is your next step?
A patient is clinically stabilized on conservative management, then I will continue.
No, patient did not stabilize.
Then then he will require immediately laparotomy, exploratory laparotomy.
Okay, so laparotomy was planned. What would you do in laparotomy?
Initially only packing only, that will the only option. If with packing bleeding stops, then we have to do the packing and drain placement, and we should come out.
So this patient had a packing, then a patient got stabilized, but on third day he again started bleeding. The drain was actually draining the blood. Patient again become unstable. What would you do next?
Again, then we'll go for CT scan and a CT triple phase or angio and see the point of bleeding after that.
So CT was done, and CT suggested an extravasation of contrast from the left hepatic artery. What do we do next?
Then DSA and radioembolization.
Okay.
Dr. Kamlesh.
Dr. Kamlesh, what would you like to comment on these images?
Okay, so there's first image showing there is a definite pseudoaneurysm. There's globular structure looking like that is pseudoaneurysm over there. So that is being taken, super selectively cannulated, reach close to possible to pseudoaneurysm, and then metallic coils are being placed. So in the third, we can see the metallic coils, and the last run is showing that pseudoaneurysm is completely being taken care of. Normal vessels we are able to see, but that pseudoaneurysm is gone. So yeah, it will definitely stop the bleeding from the pseudoaneurysm at least.
So now the bleeding has stopped. When will you remove PAC, Dr. Vineet?
Usually 40 to 72 hours. And we have to after that we have to remove the.
So this patient had a removal of PACs at 72 hours, and what kind of surgery would you do at this moment?
It stops at the time of PAC removal. Then we usually didn't do only simple debridement of the necrosed material.
So that is known as debridement necrectomy. Only the necrosed part of the liver should be removed. You can again pack the raw liver surface with some kind of a gel, which are available nowadays commercially. Dr. Soni, this patient after few days start having draining bile from the drain. What do we do?
There might be injury to the biliary system. We can go for MRCP. If it is there, then we can go for ERCP and stenting.
Okay, so MRCP did not reveal much, but there was a small leak from the cut surface of the liver from the right segment, and of course this patient had an ERCP, and subsequently after the ERCP stenting, the drain stopped. Patient had a very long ICU course, recovered well, and was discharged after 35 days of stay in the hospital.
The next case is a 45-year-old female who had a liver biopsy, and post-procedure she had sudden right upper quadrant pain, lightheadedness. There was significant drop in hemoglobin. So diagnosis, if we can rush through this one.
Most likely the arterial injury during the iatrogenic during that biopsy.
Iatrogenic liver injury during the liver biopsy. What would you do? How will you manage this patient?
If the things are well maintained, we can wait and we can go for CT and we can do the embolization.
So the CT was done. Dr. Kamlesh.
So just I will come to that also. That in all the cases of bleeding, means all the cases of liver biopsies, means if there is bleeding post, again the procedures will remain like that. By post biopsy, if there is some bleeding, we can follow, and then if required that bleeding is significant, then going for CT angiography. Here in the CT angiography, we can clearly see in the right lobe of liver segment, it is segment 6. So where we can see this is a multilobulated, there is pseudoaneurysm, and there is in the last picture we can see there is significant hemoperitorrhea, means significant clot all around the perihepatic location. So big perihepatic clot, so it is any pseudoaneurysm which is almost actively bleeding, so significant hemorrhage is there, it needs to be tackled.
Okay, how have you tackled this patient actually managed by you? Just give a brief of it.
Okay, so so this is not exactly my case, but yeah, so I can just show you. So here we can see on the DSA. So DSA we can see the right hepatic artery arising from the SMA, so the variant, and that right hepatic artery at the in the distalmost part it is showing the pseudoaneurysm and bleeding actively. So I am aware of this case. So this because the severe spasm in the vessel. So it was not, this is ideally, otherwise it is the best route to embolize. So we can just use the microcatheters, go into the vessel as distal possible, as close to the aneurysm, and then put the metallic coils, and if required, some glue along with the metallic coils.
So the coil, glue or gel form, which would we prefer for coil, glue or gel form?
Okay, so wherever, in such case, coil is the best option, going into the distal vessel, putting the coil. Along with that coil, some glue can make the things 100% sure. So that way, but glue, liquid embolizing agent doesn't give you so much control, so not in all the cases, and it will slightly differ person to person with how comfortable they are with. So in this case, especially the inner side approach was not possible, so in this case, access was taken percutaneously, and glue was placed from the percutaneous approach, because from the percutaneous approach, again, you can put the coils and glues, but from there, putting the glue is the best option. So it was done with the glue and bleeding is stopped.
In paucity of time, we are skipping the other cases. So with this, we would come to the takeaway message. Early recognition is critical when we manage hemoperitoneum. We have to maintain a high index of suspicion in trauma, ectopic pregnancy, and ruptured organs. The key symptoms are abdominal pain, distension, hypotension, and signs of shock. Imaging is essential, as we all discussed. Fast scan is rapid, reliable, bedside for bedside. A CT abdomen is of gold standard for stable patients. So the manager is cause and severity dependent. So if it's a hemodynamically unstable patient, have a low threshold for emergency surgery. If it's a stable patient, monitor, give supportive care, keep your intervention radiologist at hand. And a multidisciplinary approach is what improves outcomes. That's why we have such a distinguished panel here. Involve a surgeon, an intervention radiologist, and a critical team early. So time saves lives, rapid diagnosis and timely intervention are the key. Thank you so much. If there are any questions, we're open to it.
A big thanks to all the participants and the audience. Thank you very much.
If you allow a quick comment, so see, there was discussion and it will remain. So not in all the cases we are going directly for the CT. So it clinically definitely depends on the severity of trauma. So if severity of trauma is low, then definitely, like in the case of the injury with the bicycle handle. So if that clinical judgment, that injury might be higher side, so you may go directly for CT, but if it is the trivial injury, definitely we are going for ultrasound
As per ATS protocol, it's always better to go for a fast scan or a DPL for an unstable patient. I'm talking about ATLS protocol. And for any abdominal trauma, you need to have a CT scan because you miss a lot of things which cannot be seen only on CT, like a retroperitoneal injury, a cycle injury in the epigastrium, somebody is driving a cycle, hitting by a cycle could be a pancreatic injury. So it is a retroperitoneal which will probably not miss.
And a trauma in obese patient also poses a special challenge in which the CT can be more useful.
But there will be complete spectrum of trauma. See, some trauma will just come to you, show it to you, okay, यहाँ पे दर्द हो रहा है, चोट लगी थी. लेकिन आप clinically, if you can make out, this is just trivial trauma. We are not going for CT in those cases. Ultrasound is okay in those cases. Ultrasound will at least rule out a thing. Yeah, you are thinking a serious trauma, impact of injury was significant, and then ultrasound is negative, CT is justified.
And we're justifying CT now because it's retrospective thinking, sir. We found a grade injury like that. Many a times, a patient who's hemodynamically stable with just a bit of tachycardia, maybe because of a lot of other reasons as well. So an ultrasound is always a good initial screening modality. So many of these patients will require a CT scan as well, but if you have to choose, then I think all patients with trauma should undergo ultrasound before they undergo a CT scan.
Dr. Hari, the last comment.
Question to Dr. Kamlesh. Now, the liver biopsy is done by radiologists, not by gastros. During our residency, we used to do it blindly. Now, they do under USG guidance, they see the vessels and they choose the safest place. And at our center, whatever the radiologists, they, in some cases, or maybe in the most of the cases, they put the gel form in the tract just to prevent the bleeding, and they observe for some time on the table itself whether the patient is bleeding or not bleeding. So what's the utility of putting the gel form into the biopsy tract? Does it helpful in preventing the bleed, or is just
No, sir. So for the biopsy, it is not possible to embolize the tract. Because in the biopsy, what you are doing, we are just from the surface, we are firing the gun. So we are not getting any excess of the tract. So it is very rare to have now, first thing first, so it's very rare to have these bleedings after biopsies. Numbers have increased so much so that you will bound to see some cases of bleeding.
Yeah, this
One.
is known, yes, known
Second thing is, yes, what you are talking about is in these, those are the cases of intervention where we are taking the transhepatic approach. So there we do have control of the tract and everything. Like in cases of embolization, we are getting into portal vein. So on those times, we are having catheter in place. So while withdrawing the catheter, we pull the gel foam or glue to embolize the tract. But in biopsy, we are not taking excess of the tract, so it is not possible to put gel foam
So
or
in
glue.
nutshell, it is of no use, don't put it. And we will be closing the session. I think we can discuss it later on. Thank you very much for all the participants and audience.
Thank you. Thank you. Thank you.
I would like us, panelists, and the expert discussants to please join us at the selfie point for a group photograph. Yeah. For the next panel discussion on the topic Budd-Chiari syndrome, I would like to invite Dr. A.C. Anand sir as the moderator, followed by the panelist Dr. Ajay Jain sir, Dr. Neeraj Saraf sir, Dr. Amar Mukund sir, Dr. and Dr. Rita Singh Saxena ma'am. I now invite our esteemed expert discussants to join us on the stage. Dr. Sunil Jain sir, Senior Gastroenterologist, Indore, Dr. Sachin Gupta sir, Hepatologist and Gastroenterologist, Medilive Hospital, Bhopal, Dr. Piyush Manoria sir, Gastroenterologist, Manoria Hospital, Bhopal.
It's a great pleasure to be here, and I'm grateful to Dr. Sanjay Jain for giving me this opportunity and interacting with a very illustrious and distinguished panelists, which includes, can you project my slide? Dr. Amar Mukund, who is an interventional radiologist from ILBS, Dr. Pavan Adala, he's a GI and liver transplant surgeon at Yashoda Hospitals, Hyderabad. Dr. Neeraj Saraf, who's a consultant, senior consultant hepatologist at Medanta, Gurgaon. Are they available online?
Yes, yes, sir.
Dr. Rita Singh Saxena, she's a hematologist at Gandhi Medical College, Bhopal. And Dr. Ajay Jain is my old friend, again senior consultant gastroenterologist at Shalby Hospital, Indore. And I am the moderator below that. I have been asked to discuss a case of Budd-Chiari syndrome, and I have borrowed this case from PG clinics conducted in Chennai some time back. And I'll show you the case a little later, but let me just introduce you to Budd-Chiari syndrome. Budd had described this one case of this kind of syndrome in 1846, and Chiari described the pathophysiology almost 50 years later. And thrombosis was found to be the cause of this syndrome only in 1959. That's almost another 50 years later. So after a span of 150 years of development, we still call it Budd-Chiari syndrome. The other name is hepatic venous outflow tract obstruction. And it occurs because of obstruction occurring in any of these sites. That is, any one of the three hepatic veins, inferior vena cava. But to produce clinical symptoms, at least two hepatic veins must be blocked. The clinical presentation is with a triad of symptoms of abdominal pain, ascites, and hepatomegaly, and that sequence. And usually, patients have a chronic presentation, about 70% of them, but acute and subacute presentations can also be seen in about 1/3 cases, and fulminant presentation is rare, and it's seen in less than 5% cases. About 20% patients would remain asymptomatic despite obstruction and may gradually progress to chronic liver disease. 9% patients present with hepatic encephalopathy and 5% present with variceal bleeding. So with this, now I'll move on to the case. I have only one case to present, and that case is from Chepak. And this is 20 years old male college student from Chennai who presented with yellow discoloration of eyes for 20 days, abdominal pain for 15 days, abdominal distension for 10 days, bilateral leg swelling for 5 days. And history of present illness was that the jaundice was noted about 20 days ago, insidious onset, progressively increasing, associated with high-colored urine, no waxing and waning pattern, pruritus or pale stools were seen. Abdominal pain was felt 15 years ago, insidious in onset and again progressive, non-radiating, right upper quadrant, dragging type, mild to moderate in intensity, no fever, vomiting, no aggravating or relieving factors. Abdominal distension was noted in over last 10 days, insidious onset, progressive, uniform in later, and about 5 days back he also noted bilateral leg swelling. Some negative symptoms, no hematemesis, melena or hematochezia, no altered sleep pattern, chest pain, breathlessness or facial puffiness, no history of CAM intake. Past history, no similar episodes in past. Personal history, no sexual behavior, smoking, alcohol, drug abuse. Family history, nothing significant. On general examination, he was icteric, he had bilateral pitting edema. There were no signs of clubbing, cyanosis, or generalized lymphadenopathy. Vitals were within normal limits, except for tachycardia. Systemic examination showed abdomen was distended, umbilicus was in midline, liver was palpable 5 centimeters below costal margin with smooth surface, rounded margins, and was mildly tender. No dilated veins were seen, no back veins were seen, shifting dullness was present. Other systemic examination was normal, and the unit made this differential diagnosis. Here I'd like to mention that about 7 to 10% of people who are roaming around under the diagnosis of chronic liver disease or cirrhosis of liver have underlying hepatic venous outflow tract obstruction or Budd-Chiari syndrome. And therefore, my first question will be for Dr. Ajay Jain. Are there any clinical pointers to differentiate between chronic liver disease, hepatic venous outflow tract obstruction, or portal vein thrombosis?
Thank you, sir. Good afternoon. So there are a few things which are very important in this patient. If we go back to the history, clinical examination, so there are 3 or 4 important things. 1, liver is enlarged and tender. Number 2, patient had a chronological order, icterus, pain, ascites, and pedal edema. Now this is not the garden variety cases where a patient with chronic liver disease will present. Chronic liver disease patient by and large will present. Chronic liver disease patient usually present usually with first pedal edema and then ascites, maybe icterus if there is an acute insult. Secondly, this patient has an enlarged liver. Except 2 or 3 conditions, chronic liver disease patients will not have an enlarged liver. They will have a third thing, the patient had a smooth and a tender liver, again which suggests that the liver is congested. Now in a chronic liver, in a patient with an ascites, jaundice and a tender hepatomegaly, one would think of that there is an obstruction to the outflow of the fluid, outflow of the blood from the liver. And therefore in this patient, my first diagnosis will be in hepatic venous outflow tract obstruction. Obviously, there are 3 or 4 very important points which will make the differential diagnosis difficult. This patient doesn't have any back veins, patient doesn't have any veins in the abdomen. Secondly, this is a male patient at the age of 20 years without any pre-exposure, except that if he has any underlying hypercoagulable state, which we do not know at this point of time. Again, portal vein thrombosis at a 20 years of age, patient has no abdominal pain beforehand, patient has no history of pancreatitis. So my first impression, a hepatic venous outflow tract obstruction, but with a caveat that I would like to rule out other metabolic conditions in this patient because liver is enlarged and it's a tender hepatomegaly.
Thank you very much, sir. I think he has answered that question very comprehensively. And usually the 3 main things that are required to differentiate a hepatic venous outflow tract obstruction is, number 1, the sequence of events. The sequence of events, as I told you in the first slide, is pain, hepatomegaly, development of ascites. In this case, this pattern was not very typical, and we'll discuss that a little later. But that is the important thing. Second thing is, liver is usually enlarged in these cases. And third is the presence of back veins. Although the picture here is showing only flank veins, but presence of veins in the dilated veins in the back is very suggestive of hepatic venous outflow tract obstruction. So we'll move forward from here. These are the investigation findings. Liver functions, bilirubin was 11.7 and albumin was 1, all indicating it's a chronic disease. Renal function tests were normal. Blood sugar was normal. Prothrombin time was 2.39. It was raised. Lactate 1.8. Viral markers were negative. Ascitic fluid examination showed total proteins were 1.2. Sugar was 108. Albumin was 0.4. That means it was a high SAG, low protein ascites, also not a very typical presentation for a hepatic venous outflow obstruction, where you get a high protein and high SAG ascites. KF rings were absent, ANA and beta-2 glycoproteins were negative. The other investigations were ultrasound showed enlarged liver 16 centimeter, caudate lobe hypertrophy was present, moderate ascites was present. Portal vein diameter was 15 millimeters, velocity 10 centimeter per second. There was no portal vein thrombosis. Normal hepatopetal flow was seen. Flow was not seen in all the hepatic veins. Gross ascites was present. Echo showed ejection fraction 60%. There was no right ventricular, the regional wall motion abnormality. Upper GI endoscopy showed large esophageal varices with stigmata for recent hemorrhage. Severe PHG was present. Now, Dr. Amar Mukund, I can't see on the panel.
He's there, sir.
Is Dr. Amar Mukund there? I'm sure Dr. Neeraj will stand in front.
Yeah, he's there. Yes, Dr. Amar, you are audible.
Can you hear me? I
Yes.
can hear you. You are the voice from the sky.
Can you hear me?
I can hear you. So the question for you is, what are the characteristic findings on ultrasound to differentiate? I can hear you. Can you hear us? Yes, thank you. Can you hear us?
Sir, yes, sir.
Okay. So the question for you is,
Yes,
what are the characteristic findings on ultrasound to differentiate hepatic venous outflow tract obstruction from cirrhosis? Because this is a very easily accessible test and most crucial test to determine whether the patient has cirrhosis, or patient has hepatic venous outflow tract obstruction.
Yes, sir. So, in fact, many times we consider that this is the best test to actually make a diagnosis of HVOTO or Budd-Chiari syndrome, whatever we name it. And recently, it is a Budd-Chiari syndrome. What Bavino has actually agreed upon to call this disease as. So coming back to this particular disease, this has a typical pattern where we see that suddenly the patient jaundice as well as pedal edema, ascites, and history is just for 10 days. So
I'm sorry,
seems like
can I
an
interrupt
acute
you?
Budd-Chiari, but when we see the ultrasound report, it does like acute Budd-Chiari. But anyway, coming back to your question, like what is, so basically why I went to these two things, like there are two components. We can have a acute Budd-Chiari syndrome or we can have a chronic Budd-Chiari syndrome. If it is an acute Budd-Chiari syndrome, then there is a hepatomegaly, and because it develops in a very acute phase, short span of time, so there is no time for development of collateral channels. So it's a enlarged liver with non-visualization or thrombosed hepatic vein, what is seen, and we see ascites. So this is what we see in the acute Budd-Chiari syndrome, and it is a tender hepatomegaly. But as soon as we, the most common what we see in our part of the world. So here what we see is hepatomegaly may be there, but more marked is the caudate lobe hypertrophy, because the caudate vein drains at a much lower position in the IVC. So low of the caudate is preserved. That's why caudate keeps enlarging, and we have a much enlarged caudate lobe as compared to anocirrhotic. So in cirrhosis, all fine caudate is enlarged, but in Budd-Chiari syndrome, the caudate is more enlarged. Then when we try to look at the hepatic vein, it depends on the different stages of disease. In acute or subacute, we may find some thrombus in the hepatic vein, but it may be a cord-like hepatic vein, which is totally sclerosed hepatic vein. Then we can have an interrupted hepatic vein where we see the lumen is preserved, but the ostium is stenosed or occluded. And we don't find any color flow in those hepatic veins. Apart from it, the most marked feature is shaped intercommunicating veno-venous collaterals between different venous channels. So that itself is suggestive that one single vein is unable to drain, and there are multiple collaterals which are trying to decongest the liver, maybe in different part of the IVC. We may also find surface collaterals, and then if the disease progresses, there may be reversal of flow in the portal vein. Side may find ascites, and if it is a long-standing disease, splenomegaly may be there. And how to differentiate from cirrhosis? So hepatic vein appears normal on cirrhosis. You find flow preserved in the hepatic vein, which is not seen here. Hepatic veins do not show any thrombus or any sclerosis in cirrhosis, and more so the caudate lobe is though enlarged, but not as enlarged as we see in the Budd-Chiari syndrome. So this is what we see and how we can differentiate. Okay. So more or less, and the coarse ecotexture is not as coarse as we see in cirrhosis.
Okay, these are the films that were provided by the Chennai people. There is a cord-like vein seen on the left side, and on the right side you can see the ostium is blocked, and there is an irregular wall of the hepatic vein. And the CT scan also has shown similar findings. Caudate lobe is markedly enlarged. So these are the findings which are given. This is the treatment given to the patient. And they mentioned that given the presence of liver dysfunction and portal hypertension, definitive management options including
slides, please.
Liver transplantation and portal systemic shunt were considered. All the hepatic veins were occluded, and a conventional TIPS procedure was not feasible. Hence, the patient underwent a direct intrahepatic portal systemic shunt, that is DIPS, to establish the portal decompression and improve the hepatic outflow. So I will leave the patient here for a minute and ask a little more difficult question now to Dr. Pavan Adala. I told you that the typical sequence of events is pain, hepatomegaly, and then ascites. Jaundice is usually not seen in acute Budd-Chiari syndrome, but jaundice may appear much later in the course of the disease. In this case, we have a patient who presented first with jaundice, then with pain, ascites, and pedal edema. So what could be the possible explanation for this?
Thank you, sir. Looking at the clinical picture and the laboratories and the imaging, we understand that patient is having a component of CLD and something which has caused decompensation acutely. So looking at the sequence of events, I would first suspect that there is an acute on chronic presentation in this patient particularly. And second thing, pain is because of the outflow obstruction, which is stretching the capsule, which is causing the right upper quadrant pain. And then ascites and pedal edema, we can take them together or separately. If we look at together, because of the chronic liver failure and also because of the portal venous outflow obstruction, there is spilling of the serum into the peritoneal cavity causing ascites. And also because of the chronicity, patient might be getting pedal edema, or because, or if there is an expansion of the thrombus into the IVC, that will also cause pedal edema.
Excellent, sir. So this is the explanation. Possibly it is the two of the hepatic veins were blocked earlier, which led to development of chronic liver disease, and the third hepatic vein has got recently blocked, which has caused all the precipitation of the events. And if you look at the clinical parameters, they are quite suggestive of acute and chronic liver failure. Bilirubin is about 12, and INR is 2.39. So those are the things where we have to keep in mind. So now my next question is from Dr. Rita Singh Saxena. What hematological tests should be done when a patient presents with cirrhosis or ACLF? In a case like this, where you are suspecting hepatic venous outflow tract obstruction or Budd-Chiari syndrome.
Yeah, actually, there are a lot of hematological conditions which can lead to chronic liver disease, and but most of those cases are overt. They are very loud, like sickle hepatopathy. We know patient already has a sickle cell disease, like thalassemias. They already speak that they are thalassemics, and then they develop chronic liver disease. But in cases like this, where the patient has presented for the first time and there is no obvious hematological, we should be doing is routine CBC and peripheral smear, of course, followed by those disorders which are hidden behind thrombosis. So the first and the foremost in these cases would be to rule out myeloproliferative neoplasms. They are very commonly associated with hepatic venous outflow obstruction. And what is important is normally we suspect myeloproliferative neoplasm when the counts are high. Like hemoglobin is high in cases of polycythemia vera, or WBC is high in other cases. But in cases like this, we should be suspecting even when the counts are normal, because the counts are masked by splenomegaly and hypersplenism. This is something we should understand. So even if the patient doesn't have high hemoglobin or high WBC or high platelets, we should always do a JAK2 mutation to rule out underlying myeloproliferative neoplasm, because that will impact the long-term management of these cases also. Along with if it is not there, then we should be ruling out other conditions like paroxysmal nocturnal hemoglobinuria. This is also most of the time silent, presenting like this for the first time. So that should be ruled out. Other thrombophilias, whether inherited or acquired, like antiphospholipid syndrome, it should be ruled out if there is no myeloproliferative neoplasm underlying. Autoimmune disorders, ANA should be done in these cases. And other thrombophilias like protein C, protein S, or factor V may be needed if there is nothing else. And especially if there is a family history, then you should do the test for inherited thrombophilias also.
An extension of the same question, when the patient has presented with liver failure, are there some tests for thrombophilia which can be misinterpreted?
Yeah, of course, and especially when the patient has acute thrombus, like this. In these cases, the protein C will be low, the protein S will be low. So it is very important to interpret the test in the clinical pretext. So it's very, a lot of tests will be haywire during an acute event. So that is also very important.
Would you like to say anything?
Just an extension of this question, because we often investigate all these patients with thrombophilic disorders. And most of this time, JAK2 mutation and MTHFR mutation, they are not that common. So what is the commonest thrombophilic disorders which can lead to like this kind of condition?
It's actually JAK2 in studies. So that is why I named myeloproliferative neoplasms first. It's very common to find a hidden myeloproliferative neoplasm in a patient presenting like this. In studies, it is around 20% positivity. So even if you do not have features, always do a JAK2 mutation. JAK2 allele per se is associated with thrombophilia. And after that, antiphospholipid and other investigations.
These are very expensive investigations.
Yeah, but that's needed to manage. So I will not go for a thrombophilia profile first. I will go for JAK2 first, followed by thrombophilia profile.
So can you give us a minimum short list of tests that we should be doing in this situation?
We should.
The
We can
reason
go
is
in a
that
step-wise
full
manner,
thrombophilia profile is a very expensive test. It
You
costs
know,
about
thrombophilia
30 to 40,000
profile
rupees.
doesn't affect the management much as well. Actually, the whole profile need not be done. We should take a family history. We should take a past history. If there is any history of thrombophilia, that's needed. If there is nothing, rule out antiphospholipid syndrome first. Because that has implication in managing, using DOAX versus conventional. So antiphospholipid should always be ruled out if there is no myeloproliferative neoplasm.
Thank you. Dr. Neeraj Saraf.
Can I ask a question? Am I audible? Can I ask a question?
Yeah.
Who's Dr.
Am
Neeraj?
I audible?
Yes, Dr.
Yeah.
Neeraj, please ask. It was your turn
So-
to be answering a question actually.
Yeah, I know. So I just, we do this thrombophilia profile often and we don't find anything positive. So Dr. Rita or Dr. Ajay, what is your experience that, a lot of times none of the tests are, conclusive or positive. So what is your experience of that?
I'll share my experience of last 10 years. We have seen about 77 or 78 patients of vascular disease of liver, starting with portal vein thrombosis, the veno-occlusive disease, and hepatic venous outflow tract obstruction. And our experience is about 1/3 of the patients will have these disorders. 2/3 of the patients, we do not find anything regarding to the thrombophilia or increased viscosity of the blood. That's what I've asked, that every time when we end up asking the patient, okay, get JAK2 mutation, then APLA, and again they came negative, and then we keep on going, okay, this is negative, go again this, go again that.
Can I
At the
request
end,
you to be
nothing.
quick in answer, because in 10 minutes we have 5 more questions.
Sir, most of the time, if the investigations are normal, we need to manage the patient. In fact, we don't do thrombophilia profile when the patient has acute thrombus. We usually wait for the thrombus to resolve, stop anticoagulation after say 6 months for some time, and then do those tests. Because once the patient is on heparin, patient has thrombus, the reports
Thank
will
you,
not
ma'am.
be
Thank you very much. Yes, Neeraj, would you be able to give us in 2 minutes how the epidemiology in India is changing?
Yeah, so, if you look at the earlier studies from India, most of the studies report a high prevalence of IBC membranous web, which is causing the obstruction and which is causing the hepatic vein outflow tract obstruction. But more recently, I think we don't really see the webs that commonly, and we see more of hepatic vein thrombosis and sometimes IBC thrombosis along with it. Now, obviously, this has changed, so I don't know if the epidemiology has changed, or are we diagnosing more prothrombotic states more often now? So I talked to my radiologist also, Amar is also here. So they said that we still see, so a membrane may not be a cause of the Bhatkari actually, it could be a effect of long-standing thrombosis also. So I think we still do see membranous webs, but they actually have a hypercoagulable state and a hepatic vein obstruction, but they could still have a membranous web. But clearly, the previous studies, which a lot of them are from India, show that membranous web was the most common cause. Alone membranous web, I think we hardly see now. Amar, I don't know what's your experience on that.
Yeah,
we'll
so
come back
rightly
to
pointed,
Amar.
sir.
We'll
So
come back to
actually,
Amar.
I'll just quickly wind, sir, 1 minute. Just so maybe couple of more than 2-3% we see membrane. Rest all are having some stricture or thrombosis.
Thank you. Now I come to the very crucial question, that is, Generally, we advise a stepped care approach for Budd-Chiari syndrome management. That is, step 1 should be anticoagulants, then recanalization attempts, third should be tips or dips, and fourth is liver transplantation. So, in a patient who has come with MELD-3 showing 29, with 30-day mortality 92.2%, MELD of 25, CTP 13C, who is in ACLF grade 2, what should be the ideal treatment? What are the limitations of stepwise approach? And is there a role for anticoagulation in such a case? Although this patient was anticoagulated.
Yeah.
The question is for Dr. Pawan Adala and Dr. Rita Singh.
Looking at this particular patient, there is an acute on chronic presentation. So chronic anyways, he is not going to benefit from anticoagulation. But again, acute on chronic, so it's a bit debatable whether it is really useful or not. But for all the benefit, we would like to take that even 1% chance. So we will always put some anticoagulant on these patients. Okay. So diuretics and all, we have to make him symptomatically comfortable and all.
That
so
is
we have
right.
to take care of the liver,
whatever
residual function is there, we have to take care of that, and we have to protect the liver. So we'll do all those measures. So coming to relieve him of the symptoms, I think probably this patient, instead of going for a recanalization attempt, I would think a shunt procedure, as they have already chosen, you have already discussed. I think that is a better approach, but because all the 3 hepatic veins are blocked in this patient, I think DIPS is an option for him. So,
any other opinion from the panel or anybody?
Yes, sir. I disagree a bit. I don't think I would like to anticoagulate this patient at all. He's sick. He already has a high INR, a bilirubin of 12, ascites. I think I would go straight away for a recanalization procedure.
Yeah, I completely agree with Dr. Neeraj because he has already a chronic liver disease, high INR, all the 3 veins are there. So there is no point doing a anticoagulant. Straight away go for the decompression, and if it fails, maybe transplant is the option.
Okay. Dr. Amar Mukund and Dr. Ajay Jain, a conventional question. What are the contraindications for TIPS in this particular case?
So there are a couple of things which we need to take care in this patient for the DIPS. One, we have to look at the cardiac functions because in every procedure there will be significant change in the hemodynamics. So every time we have to look at the cardiac function, and if the cardiac functions are not good, that may be a contraindication for this particular patient. So that's the most important contraindication.
Echo in this case was normal.
So if echo is normal, then you have to look at the other, is there any thrombophil? Because you do these procedures, you have the other parameters like sepsis. Patient can go suddenly into hepatic failure in this particular patient. So patient has a MELD of 29 and doing a TIPS, that may be a relative contraindication, and you have to be very, very skeptical because suddenly these patients go into hepatic because there is a sudden hemodynamic change. There will be a shift in the blood circulation and they can go into hepatic failure and they can die. So these are the 2 important things.
Dr. Amar Mukund, you agree or disagree?
Sir, I think these 2 are valid points, so that holds true for all kind of TIPS procedure. But if we see particularly in a Budd-Chiari syndrome with a high MELD and MELD 3 almost reaching 29. So I need to be very sure that the hepatic parenchyma necrosis because of congestion is not very high. So I will counsel the patient, look, transplant will be an option in case you get into the liver failure post-TIPS. As Dr. Ajay sir has nicely said that a patient may get into post-TIPS liver failure. So that's one thing. However, in Budd-Chiari syndrome, we have seen that decongesting suddenly restores the outflow and leads to, proliferation of the hepatocytes and improvement in the liver function. So we can always take a chance. But backup transplant should always be ready in such kind of scenario, and we should counsel the patient accordingly. So that's the take from my side. And especially if the patient is having hepatic encephalopathy, we should be very sure that he will need a transplant maybe 10-15 days later or a month later.
Thank you.
Just one, sir. Would you like to do a DIPS in a patient who has even a grade 1 hepatic encephalopathy?
In this patient, there was no
Sir, it will be
encephalopathy.
because the encephalopathy means that already hepatocyte dysfunction has been enormous. So 2/3 of the liver has already been necrosed. So it will be just a salvage procedure to bridge for a transplant. He will need a transplant.
Ajay,
These are the pictures they have sent
hepatocyte
for-
necrosis can also be because of the pressure. If you release the pressure, something may improve.
Actually,
That
I'm
question
not-
I'm coming to. I'll come to that question.
What is the amount of parenchyma residue
Amar, I'm coming to
remaining
that
will
question.
determine that.
That question.
Do a
I'm coming
volumetry
to.
then.
These are the pictures they have
But
sent
you know,
of dips that they have done.
In my experience,
Just a minute.
hepatic encephalopathy is very uncommon in Bhattachyari, acute and chronic Bhattachyari.
I told you
You
that
rarely see
only
it.
9% people will present with that. I agree with you. So this is the final slide that boy has sent me. Liver function tests seem to have improved. Bilirubin is 2.4 now. Can I have the slide? Yes. So this is the picture that he has sent to me, and he says that post-dips, the patient improved significantly, and patient is in follow-up currently on low-dose diuretics and beta blockers, planned for genetic studies to rule out hypercoagulable state, and there is a registration for liver transplantation. So I have now two more important questions. First question is this: how the indication for TIPS differ between cirrhosis and Budd-Chiari syndrome? What I'm projecting here is the picture from EASL guidelines, which have been published just a few months back, which show that this patient definitely should be a contraindication for TIPS. So now in this patient, the DIPS has been done and the patient has improved, and therefore I'm asking this question: how the indication of TIPS should differ from cirrhosis and Budd-Chiari syndrome?
Actually, sir, in this particular patient, there were 2 or 3 important things which probably had made the treating unit to treat it with DIPS. One, this patient had a very young age. He was just 20 years old and doing a transplant. So they thought that we should take a chance in this particular patient because the liver is not that bad, because whatever liver has bad, it's an acute on chronic, so that they thought that it is still a reversible point of thing. And second important thing in this particular patient is that patient did not have a hepatic encephalopathy. The pedal edema, ascites, they were all very short duration. So it was not a chronic liver dysfunction, it was an acute liver dysfunction. Probably that made the treating unit think that in this particular patient, despite having a MALD of 29, CTP of 13C.
So I think they took a risk basically, and the pressure was relieved, the acute part was relieved.
And therefore the pressure
do you
released
agree with this?
and little hepatocyte function improved, and that gave a life to the boy.
Neeraj, you agree with what he said?
Yes, sir. So I think the contraindications for, if you look at a cirrhotic patient, let's say you want to do a TIPS for refractory ascites, this patient had every contraindication not to do a TIPS. But obviously, like we just discussed, the TIPS indications and contraindications will differ in Budd-Chiari because the recanalization will actually improve the symptoms. So if you were doing this for refractory ascites, there is no way you would do a TIPS in this, and there's no way the patient would have survived.
I quite agree
So
with
I think, yeah.
I'll just take 2-3 more minutes, not more than that. I'll just show 2-3 slides to support what they have said. These are very old slides to depict the natural history of Budd-Chiari syndrome. There is dismal survival by 3 years. Most patients who present as fulminant and acute, they perish within first few days if they are not treated. Or subacutes may survive for few weeks or maybe a couple of months. And chronic ones are the ones who survive for more than a year. And these are the natural outcomes of BCS, that is Budd-Chiari syndrome, as per the MELD score, which has been shown. Overall risk of dying is nearly 3 times the normal individual, and when the MELD is over 25, there is almost half the chance of a very early death. And therefore, there are separate parameters are used for deciding about TIPS for Budd-Chiari syndrome, and this slide summarizes the value of prognostic scores for Budd-Chiari syndrome. While MELD and child scores are used very frequently, as are Clichy score and Rotterdam score, their predictive probability is very poor. The Budd-Chiari syndrome TIPS score is much better prognostic score with the area under the curve going up to 0.86. If the score is more than 7, the patient is likely to have very poor outcomes after TIPS. And in this patient, we calculated the score to be around 4.9. And therefore, I think their decision to do a DIPS was quite justified. So last question is role of liver transplantation in 1 or 2 minutes.
I think role is well established, sir. Now, looking at the spectrum of Budd-Chiari syndrome presentation, in acute conditions when there is a fulminant liver failure, that is one thing where we go ahead. And if patient is presenting with subacute or acute or chronic and we have opted for medical or shunt management and they have failed, and that is a time when we take these patients for again transplant. And anyway, chronic liver disease itself with MELD score like this particular patient and with significant mortality expected in the next 1 year, I think these patients should be taken up for liver.
Thank you very much. Any questions we have
Dr.
from audience?
Anand, you showed a prognostic West.
Sorry?
You showed the prognostic factor for Budd-Chiari syndrome less than 3 years for chronic Budd-Chiari from the West. Our data is much better. We have a huge data from India, and the survival appears to be better than the West.
There is a AIMS prognostic
The
score
PGI
which
has
has
a
been
huge,
worked out,
South has a...
but that score is looking at the improvement after TIPS. So you can't decide on TIPS.
My question is, do Indians with Budd-Chiari syndrome fare better than the Westerners?
It's a mute question. That's difficult to answer. I don't think we have a direct
No, we don't
comparison.
have an answer, but yeah, I do agree with, because once you do these patients recanalization or do the TIPS, they survive, there is a recompensation and they do much better. Because now I have a patient with 12 years follow-up.
No, the same type of improvement in survival is there in West also. What I presented was...
Natural history. I'm talking about the natural history.
I was talking of natural history when these treatments were not available.
Not available. Okay.
Our patient seems to survive better.
Okay.
Yes, sir, can I just
question?
make a quick comment? So,
Question or comment? Yes, comment from you. Neeraj,
so
comment.
I totally agree that I think we have at least 50 patients, as this is not published data, who have, we have done DIPS for acute on chronic or, subacute Budd-Chiari, and they've been alive for more than 10 years. So I think a lot of people do well for many, many years and they may not need a transplant. So DIPS does very well in these patients.
So, any
Sir,
questions?
this is basically due to the reason that these in the Indian subcontinent, the kind of Budd-Chiari what we get is subacute or chronic Budd-Chiari, and in West what we see the most common is still they have more of acute Budd-Chiari. That's why the outcome of subacute and chronic Budd-Chiari is much better, because they have already a good developed collateral system, and more so they tolerate these kind of treatments very well. And when they present, they can be treated by either recanalization or DIPS. We can always debate upon whether they underwent DIPS or recanalization procedures. Those who undergo hepatic vein or IVC recanalization have slightly better outcome as compared to DIPS. But overall, if we compare the data, because the disease is different, maybe we have a better outcome.
Another major difference is that average age of presentation in West is much higher as compared to the average age of presentation in India. We generally have younger people presenting with TIPS rather than with the BCS rather than old people. Yes.
Dr. Amar, because in our acute Budd-Chiari, if you do these anticoagulants, they respond very well, even if they come in fulminant hepatic failure. So would you still consider them to subject them for transplant, or you would like to give them an anticoagulant, follow them up for another day or two before you subject them? Because within 24 to 48 hours, they do show significant improvement. Acute, especially post-pregnancy and post-delivery.
I think fulminant cases have to be treated as fulminant hepatic failure and not as Budd-Chiari syndrome.
One question. Hepatic vein stenting क्यों नहीं किया?
Hepatic vein, all three were blocked.
Then you couldn't.
It was not possible to enter the hepatic veins, and therefore they did DIPS. Yes, your question.
Sir, in case I can answer, because if you see the ultrasound image of that patient, it was totally sclerosed. So that is one of the reason. And the left one, which was the in acute process, if you see the area of that particular part on the CT scan, that was almost necrosed. So that was the reason for the patient presenting acutely and there was no option of recanalization. Hence, the DIPS was done in that case. So for that case, and the other question which was asked, like we go for anticoagulation. So yes, by convention, everybody anticoagulates, and we have seen that many patients do well with anticoagulation. So this is how stepwise approach is being followed. But again, different patients behave differently, so different opinion.
Yes. Do the usual prognostic scores like LFET score, for example, that you use for usual kinds of fulminant hepatic failure, does it also apply in fulminant hepatic failure related to Budd-Chiari syndrome?
Actually, fulminant hepatic failure to be treated only as fulminant.
Once you become fulminant, it is fulminant.
Yes.
Actually, Dr. Mishra, sir, the problem is all these scores and the treatment is from the biased institute.
Yes.
And therefore, if you are sitting in a center where there is no transplant facility, this score doesn't matter. You have to treat what is available.
That's true for everything.
Actually,
you have to work under your resources.
Dr.
Yes.
Chaubal's
So
question,
you do the best.
Dr. Chaubal's question is hypothetical because there is no data on fulminant hepatic failure and Alfred score.
Yes.
So this can only be answered hypothetically.
Ask Alfred.
Sir, this question is to the Ajay Jain sir. Just actually, I was totally confused whether, see, this type of patients, when you're dealing with a 20 years of age, sir, and you have a facilities of both DIPS along with the liver transplant. Truly speaking, what will be the ideal answer for this case? Either DIPS as a bridge therapy, then transplant, or straight away you can go for the transplant in these cases. Because seeing in this case, acute or chronic liver failure, cirrhosis, so I think so that the transplant will be the ideal answer for this
You have to
case,
take a call on that.
rather than that.
I think that is your opinion, but I told you
But
that...
Amar gave a very good answer, that you do a tips and convince the patient that if something goes wrong, you have to do a
That has
transplant.
already
That's
been
a better
done by
option.
them.
Actually,
that's a very
to
good
answer your question, Dr. Anand sir has shown you a slide. And if you calculate, most probably they have calculated that score. The score was less than 7, and therefore giving a trial of that recanalization or DIPS was probably a good answer before subjecting this patient for a transplant.
Any other question or query?
In role of newer anticoagulants, is it approved or we have to use off-label?
Same as old anticoagulants.
A bit better, a bit better in fact. Bleeding incidents are less.
Bleeding incidents, some people say
in
are
child
the same.
C, you might know that's dicey.
Yes.
And
especially you have an antidote for.
And when bleeding occurs, you don't have any treatment.
Sir, may I have a question? Sir, not this patient. My patient is different. That is young lady diagnosed as a chronic Budd-Chiari with grade 1 varices and myelositis. Improve well on the conservative management with anticoagulant. Do you subject him for recanalization or some other? She is improving well, LFT normal and completely normal. Only anticoagulant.
As long as the patient is in child's A with normal liver functions, I would not recommend interventions.
For recanalization. Because some patients...
Because I'm sure the adequate collaterals have developed.
Yeah.
That is why the liver functions have become normal.
But now, sir, there are studies which show that in any block, if you remove the block, the chances of survival is better, complications better, portal hypertension development is
provided
less.
there is a liver dysfunction.
Even otherwise, even in EHO,
if
people
there
are
is
doing it.
one hepatic vein is thrombosed, liver dysfunction does not occur. And
two hepatic vein thrombose.
So we generally don't intervene in those patients.
Do you still subject for that?
No. If there is a recanalization with the anticoagulants of one of these two veins, I think we will not subject.
No, it was not.
Ajay, that's what I was telling you. Even in extrahepatic obstruction, now there are few studies. Earlier, the AGA recommends that if you have collaterals, do nothing. But now studies have come up that if you remove the obstruction by anticoagulation or by the prognosis is better, development of portal hypertension is less, and they survive longer.
No, but portal hypertension is not there, he says.
So
grade 1 varies.
Grade 1, 2 varies.
In that case, I agree with him.
No, sir, even if it's not that the development of portal hypertension is less in patients in which do invasive procedures. So probably the role will come.
Recanalization can be done. Thank you
Sir,
very much.
If I can add one comment to it.
Yes, Amar.
Yes, Amar.
So, sir, that's a very wonderful question actually. If there is a recanalizable vein and which is just recanalize IVC or hepatic vein, which is the normal physiological outflow, establishing a normal physiological outflow. So that should be done in most of the cases. If they have any stigmata, maybe even grade 1 varices. If there are no varices, so I agree with Anand sir that no varices means their liver is adequately decongested with multiple collaterals. So then you don't need to do anything. But
No,
in case
but
if
Amar,
patient is having blocked hepatic vein or IVC and you can recanalize, it should be done. But for dips, you need to be very clear. Dips should be done only if patient requires it. There is enough, symptoms for the patient to undergo dips. So dips should be taken with a caution, but any decision for recanalization may be taken based on even soft signs.
Thank you very much.
We
I
can
will close this session and just say 2 lines as a form of take-home message. One is that in every case of chronic liver disease, we should clinically look for signs that suggest Budd-Chiari syndrome and very carefully read the ultrasound report, because that may change the management and prognosis of the patient. And the second thing is, yes, ultrasonologists should also be careful. We means it's part of us as a doctors, and in a treatment option, the stepped approach may have limitations in acute and fulminant cases, but in other cases, possibly it can be followed. And in some situations, we have to consider recanalization procedure as the first possibility, or tips as a first possibility. Thank you very much.
Thank you, sir.
Thank you.
I would like to invite the panelists, the moderator, and the expert discussants to please join us at the selfie point for a group photograph. Now it's time for a little bit of fun for the Vaso Relax session. Drop your worries, not your energies. Let's recharge, rise, and have some fun. For this session, I would like to invite Dr. Ravindra Kale sir on stage. Can we please have a huge round of applause?
So we are introducing a Vaso Relax, which will have 3 sessions in the entire conference. And Ravindra, all of us know, is an established yoga player, not only teacher. So over to Ravindra.
Okay. Thank you, Sanjay sir, for giving me this opportunity. So time to relax now. Just follow me what I am doing. You have to do, keep your hands like this and just make them straight. Yeah. And relax. Okay. Loosen the joints.
Please follow him.
Take your head towards upward and downward. Flex your neck. Up and down, and right and left. And now we will do a short pranayam. Be ready for it. Just follow me. You have to keep your hands like this. And whenever your hands go up, you have to take a long breath in, and then whenever the hands are coming down, you have to exhale. So follow me. Do it with eyes closed. It will be more effective. And relax. Relax. Keep your eyes closed. Feel the flow of energy in your body. Now you can open the eyes. Thank you.
Thank you, Ravindra. This was most interesting part. So we'll have many variations of these things till tomorrow. one more session before lunch. I think I'll invite Dr. Umesh Jalihal to come to the dais. Dr. Jalihal will moderate a very interesting session. I think this is the most important session of this VESOCON, that patients who are already on antiplatelets and anticoagulants, if they have to undergo an endoscopy, if they have to undergo a surgery, or if they present with a bleed. So these are the situations which we have to handle day-to-day practice, and these are the real challenges. So they'll invite the panelists. Please come. So for this session, I'll invite the panelists, Dr. C.C. Chaubal, Dr. B.S. Ravindra, Dr. Ajit Verma sir, Dr. R.K. Singh, and Dr. Uday Somsekhar. So we have an elite panel. We have a cardiologist, a neurologist, a surgeon, and 2 gastroenterologists. To be the expert discussant in this channel, I would like to invite Dr. R.K. Gupta, who's come from Gwalior, Dr. Sudeep Pathak, our own physician, Dr. Pranav Raghuvanshi, gastroenterologist from Bhopal, and Dr. Lalji Patel, gastroenterologist from Indore. I think Dr. Ajit Verma has not been able to make it today. He wasn't well. Handing over to Dr. Umesh.
Good afternoon, everyone. Thanks, Sanjay, for the kind invitation. I must congratulate Sanjay Kumar for organizing this especially this particular topic, the surgery, endoscopy in patients who are on antiplatelets and anticoagulants. It's a very important topic, though as gastroenterologists, these drugs, we need to be aware of these drugs. We must have first-hand knowledge of this anticoagulants and antiplatelets, because day in and day out, our patients undergoing endoscopic procedures or surgeries will be having a lot of comorbidities, including CVAs and coronary artery diseases, and on these drugs. So they will pose a special challenges in doing this. So we need to understand these situations. I think it's all of you have seen the upper GI bleed topic when it was discussed. Most of these patients were on anticoagulants or antiplatelets and had GI bleed. How exciting it was, and there were a lot of audience, and there were a lot of doubts regarding when to start, when to stop. I think to address this problem, we have an important panel, elite panel, expert panel, consisting of the 2 senior gastroenterologists, Dr. Chaubal, senior gastroenterologist coming from Bhopal, and Dr. Ravindra B.S., senior gastroenterologist, my dear friend coming from Bangalore. We came together. Somsekhar, who is a surgical gastroenterologist faculty, who has got a rich experience in managing surgeries with respect to when the patients are on this particular drugs. And also important person is the cardiologist, who will probably tell us a little more whenever we have certain doubts regarding what to do with these drugs. So Dr. R.K. Singh is a cardiologist. I think we are missing Dr. Ajit Verma, the neurologist, for the discussion. So the objective of this talk is to understand and classify the endoscopic procedures as the low risk and high risk procedures, and the thrombotic conditions as low risk and high risk, and when to stop or continue antiplatelets and anticoagulation, when to restart after stopping endoscopic procedure, when to consult a cardiologist or hematologist when these patients are on these drugs, and when patients present with acute upper GI bleed or GI hemorrhage when they are on these drugs, antiplatelets and anticoagulants. I think to begin with, I will discuss 3 case scenarios, and I will seek the comments from the panelists, and the audience also can contribute to the inputs. If time permits, I will go through a little bit of literature on these drugs. The first scenario, the question goes to Dr. Chaubal. A 51-year-old male who had CVA in MCA artery territory 5 years ago. Patient is on ecosprin, presented with actually dyspeptic symptoms and referred to us for endoscopy, and we noticed that patient had polyp in the proximal stomach. So this is the endoscopy picture. So when we are faced with these kind of situations, what would we do? What we tell to the patient, and should we take that patient up for further procedures? What would be the counseling as far as the gastroenterologist is concerned? Dr. Chaubal.
Whenever we are faced with such a situation, like this patient had this problem 5 years ago and has been on antiplatelets, DAPT, dual antiplatelets, we have to decide what we are going to do, whether it's an emergency procedure. That is one.
Very good.
Number two, what is the thrombotic risk of the patient at this point of time, and what would be the hemorrhagic risk if we continue this. Given a choice for me, what I will do in this particular situation is, if he is on DAPT, continue aspirin, stop clopidogrel. This is an elective procedure, so I'll stop clopidogrel at least 5 days before the procedure. Go ahead with performing polypectomies. Once you have achieved a proper hemostasis, there is no problem over there. You can restart clopidogrel after, say, about 24 hours. That is what they mention, if you are using clopidogrel. So that is what we can do in this particular situation, because this is an elective procedure.
Correct. Okay. I agree with you. So it's an elective procedure, and it's a low thrombotic risk procedure, because patient had, there is no GI bleed as such, but patient had hemoglobin of 10, so there was anemia. So there is a need to do the procedure, endoscopic procedure, probably polypectomy, but whether it should be done immediately or whether it should be done later, so that should be decided. I think we need to talk to the patient. As Dr. Chaubal said, it's an elective procedure. We can actually plan it. We can stop ecosprin. We can probably, clopidogrel, and continue with ecosprin. Yes.
Umesh, he presented with dyspepsia. So we're not sure whether this polyp is causing dyspepsia or not.
Yes.
It's not bleeding. There are no erosions, number one. Number two, did you do a narrowband imaging or some image-enhanced endoscopy to see what's the polyp?
Yeah, we'll come to that. I think you can see it actually yourself. We did not do the narrowband imaging especially, but patient had hemoglobin of 10. Probably patient had anemia. We don't know whether it's responsible or it's an incidental finding.
He's taking aspirin, so maybe
yes.
some minor bleeds.
Yes. Yes, sir. Yes.
We'll put.
You're right.
I'm talking about this particular patient because there is a gastric polyp and we are contemplating a procedure.
What he says is right, MDS as well as you should do a colonoscopy and maybe a capsule also to see for the area.
Yeah. So definitely this patient warrants investigation of anemia, but if you have found a lesion here,
he has a cause over here.
Yeah. So I showed this. Yeah. Yeah. No, but I'll tell you, sir, if there is a polyp, there is no other lesion, and you have an iron deficiency anemia, that's good reason to go in to consider a further therapy, and patient is already anxious after seeing this polyp, whether it's malignant, not malignant, and we might have further loss of hemoglobin. It is not prudent to leave that polyp. I think let's not debate that issue. Let's move on.
Just a small observation about this patient's treatment. He was receiving antiplatelet for post-stroke strategy.
Yes.
And he was receiving Disprin 150 plus clopidogrel 75. There was no need to give Disprin 150 along with 75 clopidogrel. 75 both is good enough for events who are using dual for stroke prophylaxis.
No, this
and
patient
the reason for
came
anemia maybe because he was receiving double the dose of antiplatelet, especially Disprin. So probably this was not a correct approach.
Your point is well taken. I think we'll come to it whether the dose modification of the drug is required. I'll be asking that question a little later. Yeah.
Even there are studies showing that aspirin in low dose is better than aspirin in high dose.
Yes. Yes, sir.
See, this is not a situation. This is
yeah.
talking about mantle cell lymphoma, and then let me to have seen couple of cases.
What-
they have
what-
multiple
what-
polyps
just
in colon.
what Umesh
They
is
may
trying-
have multiple in the stomach.
Let me
They
show this
don't come
video.
like this.
Sir, what he's trying to say is,
We are talking about the GI problem. Let's not go too much digress from here. Yes, sir. So this is the polyp, what we saw, and we talked to the patient, and electively this patient was taken up for polypectomy after stopping the clopidogrel for 5 to 7 days, and I think successfully the polypectomy was done. 1 minute. So we just did a polypectomy, applied clip, and there was no bleed, and histology it came as hyperplastic polyp. So now I think we'll move to the next question. I think someone answered already. Dr. Ajit Verma is not there. We wanted to know from neurologist what antiplatelets and which one, any modification of the dose or drug needed, any message to the treating gastroenterologist. Anyone?
See, regarding the second point, I will mention because they already raised any modification dose of the drug which is needed. You can go on with the low dose aspirin as has already been mentioned. And of course, the clopidogrel can be continued in the same manner. Now, when to restart antiplatelets and which one? You have clopidogrel over there, you have prasugrel which is used, you have ticagrelor also. As far as the clopidogrel is concerned, what they mention is you can start it on the very next day after performing the procedure. For prasugrel, you can see you wait for sometimes a little longer time, and for ticagrelor also about 2 to 3 days they mentioned to restart antiplatelets after that. So that is what is required.
Umesh, long time back I remember studies coming up that beyond 6 months if you combine the two there's no benefit. That's right, even today? 6 महीने बंद कर देते हैं केवल एस्पिरिन देके छोड़ दो. So that should have been this.
I'll review the literature. I think we'll come to that point later. You can start. Agree with you. Okay. Any differences? Okay. So we'll move on to the next case. I think we might have a time shortage. So the next case is a 69-year-old female, has comorbidities in the form of diabetes, hypertension, atrial fibrillation on apixaban, BD, presented with cholestatic jaundice. And on investigations, patient had high bilirubin, to 10.2, total direct of 9. Obstructive enzymes are also raised. And the ultrasound showed dilatation of the CBD as well as the PD, and there was a mass in the distal part. And we did side-wing endoscopy, and this is what we found. There was an ampullary mass, and biopsy was taken, and biopsy came as ampullary adenoma. So I think I'll ask Dr. Ravindra. 1 minute. Yeah. We did, before that question, I think this is a CT and this is a US image of the ampullary adenoma. So what workup to be done? What is the advice regarding anticoagulation therapy? Patient is on apixaban. And any precautions?
Yeah, I think Dr. Umesh, you have already shown the investigations in this particular case. It's an ampullary adenoma. We need a CT, an endoscopic ultrasound. CT basically to look any lymph nodes are there. or second thing is any SMV portal vein involvement if it is malignant. Number 2, endoscopic ultrasound to know whether it can be resected locally, whether the bile duct is involved, pancreatic duct is involved, and there are any duodenal lymph nodes. I think these are the investigations from gastroenterology side what we need. And of course, regarding the anticoagulation, this is a DOAC. In this particular case, I would like to miss if CT shows there is no metastasis anywhere, limited portal involvement, no lymph node, and endoscopic ultrasound shows it's a limited disease, not involving the CBD, not involving the PD, only the ampulla, only the duodenum, and no lymph nodes on the endoscopic ultrasound, that it becomes less than 3 centimeters. Then it becomes an indication to do a endoscopic resection. In that particular case, if all these criteria they
I'm giving you
carry on,
the criteria or the whatever the investigations available, it shows ampullary adenoma. It's a resectable.
Resectable means endoscopically resectable. Means these are the criteria to say that these are endoscopically resectable.
Okay.
Once it is endoscopically resectable, then of course I will have a discussion with the cardiologist, because whether it is atrial fibrillation with any valve involvement, that is main important thing. Mitral valve, aortic valve, any involvement is there. Then based on and whether he had a stroke and all these things, because this becomes very, very high risk factor, we cannot directly stop apixaban in this particular case. Then we will have a discussion with the cardiologist. At least 3 days we would like to stop apixaban, and of course we will have the cardiologist to be involved in this particular
Dr.
case.
R.K. Singh, your opinion.
Basically, in this particular case, if there is a CT abdomen with endoscopic ultrasound, most of the time we should be able to have this thing, because PET as a direct modality is not required in all the cases, because only the oncologists they use extensively, but none of the GI surgeons and gastroenterologists, every case doesn't need a PET. PET only is indication is for metastasis.
First
not
of all,
for
it's an early
disease.
lesion, like we are only worried about whether it's an adenoma or invasive carcinoma. We are not thinking of an advanced malignancy here, so it may not be a concern, I think.
No, in any case here there is an adenoma on biopsy.
Yeah.
You don't require a PET scan.
No, but that was a endoscopic biopsy. I think we'll have an ampullary biopsy later.
Yeah.
Many of these early cancers we do resect without the PET scan, and once you get that there is
Agree, but that is how you diagnose adenomas and remove endoscopically.
You know, here I would like to say that since he was a high risk for thromboembolic event, he has a atrial fibrillation. So, you know, before you plan for procedure, you can stop oral anticoagulant and then start heparin. Maybe there is a fractional, unfractionated heparin or low molecular weight heparin.
But patient
and
is
you can stop just before the procedure.
No, that's what bridging therapy it's called, low molecular weight heparin. So is it required in case of DOACs?
For all cases you want to have bridge.
3 days to 5 days time to do the procedure. So in between this, when you stop NOAC, you can start heparin.
No, that, I get your point, but I'll show you the literature evidence. No need to add low molecular weight heparin if its patient is on NOACs.
So Umesh, it will differ. Consult the cardiologist. If there's a left atrial thrombus, high risk. Otherwise, if nothing is there.
No. The additional lesions, fine, sir. Cardiology point of view, but stopping anticoagulation if the patient is on apixaban.
You can. If nothing wrong, then you can stop.
No,
but
is there a recommendation to add low molecular weight heparin? Bridging therapy it's called.
Dr. Jalihal is right, because the literature doesn't support the use of bridge therapy.
No, nothing.
There is a reason.
Yeah,
There is a
I'll
reason
show you
for
the
this.
literature.
There is a reason, because these drugs have a rapid onset of action, and the last action also lasts for a short time. So usually the bridge therapy is not required in these situations, and the literature doesn't support the use of this as far as DOACs are concerned.
I'll show you the data.
48, yes, you're right.
Doctor, the problem is the patient develops and he sues you for them. And then that's the problem.
No, sir.
Yeah, we'll come to it, I think. I'll show you the literature on that.
No,
okay.
usually only plain atrial fibrillation with no valve involvement, you can stop. Whereas atrial fibrillation with a valve involvement, this is a very high risk case. In this, probably a bridge may require. This is how we have to differentiate.
Yes.
AF without valve, AF
Correct.
with the valve.
Correct.
And AF with stroke,
Correct.
this is how we have to differentiate.
That is chat.
Yeah.
Chat scoring.
No, that also I'll tell you. I'll come to that. Yeah. Okay.
You have to go by the chat scoring that is already mentioned.
Yeah.
I'm just giving a sort just a corollary to this particular in the sense, since we have already raised the issue of ampulectomy in this particular situation which was performed, we always say that aspirin is not to be discontinued. But this is one situation where the guidelines are very guarded. They say probably the incidence of bleeding. So in some situations, if you're sometimes in ampulectomy also, you may have to stop aspirin. That is it.
No, but here the patient is taking DOAX.
No, I'm just,
No,
I'm not saying
just a ban, but he's saying
just
even
as a
if the patient
corollary,
is on
since
echo,
we have raised this issue and we
in
continue
case-
aspirin in all the procedures.
Yes.
But this is one
This
area
is an
where you may
exception.
have to stop aspirin.
Yes, this is one high risk procedure which. Got your point, sir. I think we'll move on. So, Ravindra, we did, ampulectomy in this patient. This is a video, and this is the post-ampulectomy endoscopy picture, resected specimen, and patient underwent stenting of the bile duct as well as the pancreatic duct. So, I would like to now ask our surgical colleague, Dr. Uday Somshekhar. God forbid, we didn't have any bleed in this patient. God forbid if there is were to be bleed, or if we get invasive malignancy on biopsy after resection. So patient might require a Whipple surgery. So what would be your approach, or what are the precautions you would like to have?
Yeah, so here if the patient has malignancy on the biopsy, or then obviously then we need to go ahead with completion of Whipple's procedure. So here obviously from an oncological point of view, I would have to see the CT scan to see the resectability on, and see what the liver profile now is after the stenting, what the LFTs are, and the serum albumin, what the serum albumin is, because that has an implication on the post-operative outcome. And
with respect to anticoagulation?
Yeah, with respect to anticoagulation, pretty much the recommendations or the precautions would be the same as for endoscopic procedure. Since this patient has been on apixaban, we would need to stop it for about 48 hours before the procedure. And as pointed out, there is no particular need for a bridging therapy here. What is also important in this scenario with respect to anticoagulation is this patient who's undergoing a major surgery would probably need some sort of an epidural analgesia, or would have a central line put in. Again, in those situations, the same kind of recommendation of 48 hours or maximum of 72 hours free of the anticoagulant is necessary before the procedure can be done. As far as post-operatively if it is concerned, then we can restart it in around 48 hours time. That would be adequate time.
Okay, 48 hours you want to restart anticoagulation, no acts.
Even in Whipples.
Okay. Even in Whipples.
Whipples maximum we could be, if you want to be extra careful, maybe 72 hours, but we don't need to stop beyond that, because then if you if you want to stop beyond that, then you have to think of other anticoagulant measures, especially if the valve is involved. If the patient is just on for atrial fibrillation, then maybe we could be safe without a bridging.
Okay.
But otherwise,
okay.
then we would consider.
Thank you.
Yes.
Absorption will be a major problem. And another thing in this has to be watched out is the creatinine clearance. With the apixaban, what is the creatinine clearance? On that basis, you have to stop or initiate. So
if the creatinine clearance is less, most of the NOACs we have to restrict, especially dabigatran. If the creatinine clearance is less than 30, we shouldn't be giving the NOACs.
Agreed.
Okay.
That is also an advantage in terms of post-operative for a patient who is undergoing a major surgery and may be in bed for a longer time. Then LMWH may be a
So
preferred
we
option.
will end our discussion with respect to case 2. Now we'll move on to the case 3. 60-year-old female who had PTCA 1 week back, had upper GI bleed. We did endoscopy and hemoclip application and adrenal injection also, but still patient is having a bleed. You can see the spurting bleed in spite of 2 clips, hemoclips being there. So I would like to know from the panel, both from the gastro and the cardio as well as the surgeons.
I think, Dr. Umesh, this particular case, it's an ideal case because 2 clips have already been placed. I think a hemostatic ovasco clip is the one which I will consider number 1. That is number 1. And number 2, regarding the anticoagulation, he has been just PTCA has been done, and then probably most of these patients will be on both aspirin and clopidogrel. In that scenario, once again, we need to have because it's 1 week post PTCA. I don't think we can stop. We can stop clopidogrel with aspirin with low molecular weight heparin probably. I think that's what we will have to be in conjunction with the cardiologist.
Yeah,
that's why probably aspirin, and if cardiologist says they will never stop, I know clopidogrel they will never stop. Then
I think this situation within 1 week you have to continue both antiplatelets. But if you feel it need to be stopped, then you have to cover with the heparin.
Aspirin with heparin.
Aspirin with heparin.
No, so you can stop both with the heparin.
Will it not be opposite, sir? Aspirin has got the highest potential to cause gastric ulcer in comparison to the clopidogrel.
ये problem ये है कि इसमें see the problem is it's not the bleeding we will have to stop. That's why probably if they want to stop both, we will be very happy. See, we are very happy if they stop both. But they will not be very happy. They want to have 1 antiplatelets. If they are happy with heparin, we are extremely happy as gastroenterologists.
Now let me tell you one thing very there. You are trying to hype up the things too much, single dose and small dose, this thing has been, usually the ulcers which form, they form with a very long-term therapy. It's not that you have started just 1 week of aspirin and they will form a big ulcer and bleed like this. Already existing ulcer may bleed, but what the studies have clearly shown that even if you have an ulcer or any bleeding lesion for that matter, if the patient is already on aspirin and clopidogrel, the main culprit to resulting in severe hemorrhage is clopidogrel and not aspirin. The studies have clearly shown that. Theoretically, it's all right. Studies have clearly shown that even if you continue aspirin, that protects your heart and all these things, prevents stent thrombosis also, and it doesn't have that much of effect unless you have got a good endoscopic hemostasis, which are going to achieve.
Yeah, thank you all the panelists. I think now I'll go through the literature on this. I don't know how much time I have.
Last 2 slides.
8 only, okay. I think, so these are the antiplatelet drugs. I think I will not go into the too much of classification and other things.
2 slides.
This classification of antiplatelets, commonly used heparin, low molecular weight heparin, vitamin K antagonist, dabigatran, and NOACs, rivaroxaban, apixaban, and NOAC pharmacology I think I'll skip. So 1 or 2 important things we need to understand as gastroenterologists is what are the low endoscopic procedures and high risk endoscopic procedures. Most of the endoscopic procedures wherein we do biopsies or stenting are low endoscopic risk procedures, and diagnostic EUS and device assisted enteroscopy, they all fall into low risk endoscopic procedures. High risk endoscopic procedures include polypectomy, ES, and third space procedures, endoscopic dilatations, and so on. Low risk thrombosis, ischemic heart disease without coronary stents, cerebrovascular disease, peripheral vascular diseases. We were talking about this, prosthetic heart valves, atrial fibrillation with CHATS 2 VAS score more than 5, and CNs with drug-eluting stents more than 1 year, less than 1 year, bare metal stents with less than 1 month. So this is about the aspirin we were talking about, antiplatelets. For all endoscopic procedures, continue aspirin with exception of ampulectomy. This is a British Journal of Anesthesia guideline. If there is a secondary prophylaxis with aspirin, there is a threefold interruption leads to threefold increase in the risk of cerebrovascular and cardiovascular events. It's more about 70% in the first 7 to 10 days. I think with aspirin, without aspirin, there are no bleeding risks. I think we discussed this. Antiplatelets, PY receptor antagonists, clopidogrel, ticagrelor, prasugrel. Monotherapy is recommended if in CVA and PVDs, DAPT in ACS with stents, clopidogrel. I think I'll skip this. So anticoagulants, if a patient is on warfarin and heparin, if it's a low risk endoscopic procedure, but we should maintain the INR of around 1.5 in the therapeutic range. If it is more, stop warfarin to decrease the INR. If a patient is on warfarin and heparin, if it's a high risk endoscopic procedure plus low thrombotic risk, discontinue warfarin for 5 days. No low molecular weight bridging is required. Again, warfarin and heparin, high risk endoscopic procedure and high thrombotic states. Warfarin should be discontinued and substituted with low molecular weight heparin. In resumption, we can resume both warfarin and low molecular weight heparin on the same day. This is the coagulation pathway. I'll skip this.
Warfarin के साथ में low molecular weight heparin की breathing चाहिए होती है. DOAC के साथ में low molecular weight heparin की breathing नहीं चाहिए.
Yeah, it's not required.
You don't have to bridge.
You don't have to bridge. Yeah, we already have discussed and it's there.
मेरा question है सर, hematologist आप कितने platelet पे easily endoscopic biopsy और colonoscopic biopsy कर सकते हैं?
I think we'll take up that question a little later. Sir. Let's finish with this. Let's look at the AF. I think we had a discussion on this. Atrial fibrillation on DOACs planned for elective surgery. I think there is a data post-trial published in JAMA, 23 centers, more than 3,000 patients, interruption protocol. I think it's just one day, low risk procedure, 1 day before and 1 day after the procedure you can just restart. In high risk procedures, 2 days prior to the procedure and 2 days after the procedure, you can resume. So this is the chart. Direct oral anticoagulants, I think I'll skip this. Most of it is repeat. Regarding bridging low molecular weight heparin, I think this is where we had a controversy. There's a really trial, bridging of dabigatran with low molecular weight heparin. They did that, they had higher rate of major hemorrhage, 6.5% versus 1.8%. No difference in thrombosis rates. And still to be advocated in patients with on warfarin. But for NEOX or DOAC, the bridging is not required. In case of recent venous thromboembolism, that is VTE less than 3 months, we should not interrupt the anticoagulation. If it's a low risk procedure, continue anticoagulation. If it's a high risk procedure, try to defer it beyond 3 months. Thrombophilia syndromes, no need to bridge. Low risk endoscopic procedures, PY receptor analogs, continue. DOACs, omit on the day of the procedure. High risk endoscopic procedures, PY receptor antagonists, discontinue 7 days. DAPT, continue aspirin, discontinue PY blockers for 7 days. High thrombotic risk, continue aspirin, consult a cardiologist. High risk endoscopic procedures, warfarin. If it's a low thrombotic risk, discontinue for 5 days. If it's a DOAC, stop for if it's a low thrombotic risk, stop for 3 days prior. And if it's a high risk thrombotic risk, you can talk to a hematologist. Acute aspirin, if it's a primary prophylaxis, primary discontinuation, secondary prophylaxis, do not stop. DAPT, continue cardiology consultation regarding stopping. We did that. I'll skip this. Acute GI hemorrhage, oral anticoagulation based on severity of hemorrhage. Again, we had a discussion during upper GI bleed also. Without oral anticoagulation, correct coagulopathy, consult hemat or cardiology. Do not delay intervention for correction of coagulopathy. This is what I was telling during the upper GI bleed discussion. vitamin K antagonist. In case patient has got hemodynamic instability, try to give IV vitamin K, and also you can give 4-factor prothrombin complex, that's PCC. If not available, FFP. DOAC reversal agents are there, but that not easily available. I'll skip that. Safe practice for patient education. We need to balance the risk of hemorrhage from the procedure versus risk of thrombosis. All patients should be advised about the thrombotic risks and the hemorrhagic risks, and increased risk of post-procedure hemorrhage in case they are undergoing endoscopy or surgery. Skip this. This is about the BSG, ESG guidelines. I think it's more or less whatever we just now discussed in the previous slides. I will skip that. And we have a position paper in Indian Journal of Gastroenterology published. I think this is a chart. I think we can keep it handy in our consultation procedures or rooms or in the ward. It's more or less the same. I think in most of the situations, aspirin can be continued. Wherever there's a DAPT or the P2Y drugs are there, we can discontinue the clopidogrel or other drugs. Thank you.
As a hematologist, we keep on getting at the low platelet counts. We are asked our gastroenterologist to get the biopsy done either endoscopic or colonoscopic, or pulling out the GVHDs. So just for that, we keep our platelet count above 30 to 50,000. For sigmoidoscopic, we go as low as 20 to 30,000. We do not transfuse patients because all our patients are thrombocytopenic. For endoscopic procedures, we tend to keep our platelets at 50,000.
Yeah, I think it's recommended to keep it below 50,000. I think
because majority of our hematology patients are at that level. They're not on aspirin, but they're all like low thromboplatelet count being low.
Any other questions?
I have a question, sir, here on the rise. Yeah. In one of the spurting vessels that you showed us, if you have planned to close that vessel using a clip or Ovesco clip to be more precise, which is a mechanical compression and you are sure that it's not going to loosen, using dual antiplatelet in these patients after immediately closing that bleeding vessel.
Yeah, I think depending, because this is a cardiology patient who has undergone stenting just 1 week back, and if there is a hemostasis achieved, I think there is no harm in starting within 1 day.
So can I say that if you have mechanically closed the bleeding vessel,
yes,
you can start dual antiplatelets?
You can start.
Sir,
yeah. Ovesco clip.
Okay, not the regular.
But I
through
think
the scope
there
clips.
can be a technical problem. I will ask my gastroenterology colleagues, because already there are 2 clips, hemo clips. Applying the Ovesco clip might be a little more difficult. In that scenario, I probably have to use something like a coag grasper to achieve hemostasis. Or remove those clips and apply the OTSC.
Remove the clip and apply the Ovesco.
Sir, एक ना पैथोफिजियोलॉजिकली आप समझिए, बहुत ही सिंपल सवाल है. अगर आपने क्लिप लगाया, उस दिन तक वो दवाई ले रहा था एंटी प्लेटलेट्स, उसके प्लेटलेट्स 7 दिन तक डिसफंक्शनल है. There's a thromboasthenia for 7 days when you take a 1 dose of aspirin or clopidogrel. So you do a mechanical thing, you allow the thrombosis to create, and whether you stop it or you give it out of 24 or 48 hours, half of your platelets are either way not functional. Dual anticoagulation means that if you have to do a spine surgery, the biggest spine surgery, then I have to wait for 4 days, because by 4 days the platelet will be, half of the platelets will become normal by the time they come and replenish this thing. So जो आप क्लिप लगा रहे हैं, आपको पैथोफिजियोलॉजी समझनी है कि वो क्लिप मैकेनिकली थ्रोम्बोसिस करवा रहा है, एंड 24 आवर्स के बाद आप उसको एंटीप्लेटेट स्टार्ट कर सकते हैं, क्योंकि उसने क्लॉट को बना दिया.
Okay. Anyway, I mean, there is a mechanical force which is holding it, and there is no blood vessels which is exposed. So I think there shouldn't be any problem.
No.
Sir, any role of DOAC reversal agents, patient undergoing?
Yeah, that's one thing I think we need to
DOAC reversal agents, we have rightly asked, there are 2 of course, 2 of them. One is for dabigatran is there, and the adinexant.
Idoricizumab is there for dabigatran.
But the thing is, the guidelines recommend that these should be utilized only if the situation is a very life-threatening.
Yes.
Very life-threatening bleed. Otherwise, you can manage them very well with your 4 PCCs or 3 PCCs if required.
No.
That you can manage with that this thing, but in case if it's a dire emergency and the bleeding very profusely, There you can try this particular
But
reversal agent.
is there evidence that if you give them plasma, it stops?
Sir,
There's
tier
no
3
evidence
cities
for
में
that.
इसको इसका आंसर बहुत सिंपल
There's no
है.
evidence for that, but we all give it.
Sir, tier 3, tier 2 cities में FFP will be sufficient because if there's a GI bleed, 50-60% will stop with the FFP itself.
No,
If it
most
is-
of the times it stops, but
Stops.
it's better to
If it
know
is in a
that there are antidotes or reversal
if
agents
it is
available.
4 PCC, prothrombin complex concentrates, 80% bleedings will stop with that PCC only. So अगर आपके पास FFP है, आप tier 2, tier 3 cities में DOAX पे हो, यहाँ से कोई रीवा करता है travel, वो FFP से control हो जाएगा. उसके बाद
How many FFPs you want to, as a hematologist, how many FFPs?
15 mg per kg. First single dose is 15 mg per kg.
But where is the evidence for that?
Okay.
Yes, sir.
Where is the
Very
evidence?
weak evidence. Sir.
The evidence
Very
is not
weak
there.
evidence.
The
It's
only
not a
thing
class 1.
we are forced to also we use it.
It is. Sir, we are but
It is
in a
15
setting
ml.
else-
It is 15 ml per kg है.
15
15 ml per
per
kg. I know.
No,
और उसके बाद PCC है सर. अगर
No,
PCC मिल जाता है.
early morning.
इसी मिलती है हमारे
Early
यहाँ.
morning,
Only-
Dr.
only
Manisha she was told
situation-
you have to use at least 6 packs.
When you
Not
have a
less than
definite
that.
evidence,
15 mg per kg.
definite
No, I
source
see a
of bleed,
situation.
this approach does not work when you have a definite source of bleed. And most of the patients who present with massive bleed, they have got a reason. They have got an artery like an ulcer or a polyp. So their role of PCC or platelet is very, very secondary. Primary is hemostasis working on the side.
Local control.
Yeah.
But sir, हमारा तो bleed brain में भी है ना. हमारा सिर्फ as a hematology consultation, DOAX पे, it is not the GI bleed itself. It
Yeah,
is
I agree with you. Whether it is in the GI tract or elsewhere, if there is a persistent bleed, you want to have an hemostasis. I think good news is that there are reversal agents, probably NOACs.
But kitna hai
plus,
cost?
when the patient comes to us, if there is a renal failure at that point of time, they have got a very long half-life. You need to have a probably reversal agent. That situation may be once
we
in
have
a
also managed with one prothrombin, Novo 7, sir, activated factor 7. Again, there is no data for that. PCC was shot in the market. We gave at a 48 mics per kg of Novo 7 at 4 hourly doses. Though it's an expensive 2.5 lakh rupees each dose will cost. But in 2 doses, the bleeding stopped.
Yeah, I looked at
The problem, this is anecdotal. What is spontaneous or because
It's spontaneous. It's just spontaneous.
Rahul, now I have a question for you. Since you are talking so much
Attributing
about
the
platelets, in a situation, patient is already in aspirin, bleeding profusely, his platelet count is normal, but as we are saying, asthenia. What is your take on giving platelet transfusion in these situations? I am just saying because what our guidelines say, that I'll tell you. But what is your opinion of using
again, sir,
platelet transfusions in those situations? Platelet count is normal, they have only asthenia.
Perfect, sir. So we will not the corollary to that is if where the bleeding is happening. Even in a CNS bleeding with a normal platelet count on aspirin, there's no guideline to suggest or to give platelet in these conditions which will achieve the hemostasis. But there are two places where the platelets are normal and still the patient is bleeding. One is the Glanzmann thromboasthenia. So if a patient of a BSS, Bernard-Schauer syndrome, platelet is normal and comes with you with a GI bleed, you have achieved a local hemostasis. What will you do? In a Glanzmann and Bernard-Schauer syndrome, the platelets are not interacting with each other. So at that time, you have to give platelet because these are constitutionally inherited disorder where the platelets are not functional. One.
It's different.
Yeah.
So
this
what
is
I mean, in a
not an
conventional
aspirin,
situation,
sir. No, not an aspirin.
In a conventional situation, even our guidelines say that there is no role for platelet transfusions. One, there is one reason because the reason is not only that or this thing. The reason is the incidence of thrombosis is far more than it outweighs the risk of us continued bleed.
सर उससे ज़्यादा उससे इम्पोर्टेंट सवाल ये है कि अगर थ्रोम्बोस्थीनिया पे प्लेटलेट पे ब्लीड हो रहा है मैंने एस्पिरिन को स्टॉप किया अगले दिन का जो प्लेटलेट आएगा वो नॉर्मल आएगा बट ग्लैंसमैन और बीएसएस में जो प्लेटलेट आएगा जीवन भर वो खराब ही आएगा
functional गड़बड़ है
Those are rare situations.
I think any other
even after stopping aspirin for some days the platelets are not going to be normal.
Normal, sir.
नहीं count normal होगा
No,
function
but I
may not
think,
be normal.
sir, let me correct his point. we can discuss over the lunch. Already we are behind schedule.
Just a small comment. Whatever you do, correct the coagulation or give the platelet not to correct, but do not delay the endoscopy or endoscopy intervention. These are the clear-cut guidelines.
I showed that the light. I showed that slide. I showed that slide.
That we already discussed during your panel discussion.
Yeah. Okay.
That we do not wait for the coagulopathy to be completely corrected and wait till that time. You start doing.
Thank you all. Thanks our panelists for active participation. Thank all the audience for your active participation. We will conclude this session here. Thank you.
I request the panelists, the expert discussant and the moderator to please join us at the selfie point for a photograph.
We now invite you to join us for lunch, and we look forward to continue the sessions after the break. Enjoy your meals.
तेरे को छोड़ दूंगा तू वो तो घर वाले
हेलो किधर हो मैं बोल रहा हूँ भाई से बात करो
भाई किधर हो जल्दी आना
घर पे करके
नहीं नहीं चाहते लगा देते अपन और कितने दिन लग रही अपने वो अच्छा ये 50 मिनट हो मेरे पास नहीं चाह रहा मेरी कार्डियक वाली
क्यों तुमने बैकअप लिया है? बैकअप लिया उसका?
नहीं लिया ना
नहीं लिया कहीं भी?
हाँ
हमारे पास ही डेटा और दिया भी नहीं फोटो तुमने।
दे दिए तो
फोटो तो दे दी था।
हाँ उनने सिलेक्ट करके फोटो भी दे दी अपन वो ये कह रहे कि लाडा अपने को पार्टी को देना है तो अभी अपन इसलिए फॉर्मेट नहीं कर रहे थे अपन सोच रहे थे तो फिर वो उठा के उनको हेड डिस्क पकड़ा दिया
हेलो हेलो रो मैं बोल रहा था सुनो ना भाई तुम कल कितने बजे यहाँ आ जाओगे भोपाल? भोपाल भोपाल 10 बजे तक पहुँच जाओगे तो चलो 10 बजे आने के बाद दे देना मेरे को ना शाम तक पहुँचना वहाँ पे और रात भर की शादी है मतलब और सुबह रिटर्न हो जाऊँगा। हेलो ठीक है लेकिन 10 बजे आ जाओगे ना? 10 बजे तक तो आ जाओगे ना? कौन सी ट्रेन से आओगे वहाँ?
हाँ मैं एडमिन बना देता हूँ ना उसी लिंक पे करना है
ओके आप क्या जीमेल लॉगिन कर रहे हो क्या?
जीमेल ही में नहीं
ये तो ऐप्स का ऐप इंस्टॉल तो ऐप इंस्टॉल करना पड़ेगा वेब से डायरेक्ट।
हाँ मैं बस तुम्हें वो बना दूंगा तुम्हारी मेल आईडी जो
मैं इंदौर है, हमारी एलुमनी थी, वो हमारी बैच की मैडम है, वो ऑप्थेल्मोलॉजिस्ट है ना यहाँ, और आशुतोष है, आशुतोष इज माई बैचमेट, इन लोगों ने 4-5 लोगों ने मिल के करी थी, तो हम लोग नेक्स्ट डे थी यहाँ, तो उस दिन शाम को रहा मैं, और फिर निकल गया था। कुछ करो तो इंदौर में रखो तो हम आते हैं। अब अभी थोड़ा फ्री हो गया, या हटा दिया था, मैं हटा नहीं होता, तो उससे थोड़ा मैं फ्री हो गया। अच्छा, यू बीइंग वंडरफुल, आप सारी बोली इसलिए बहुत अच्छा लगा, कि आपकी इसमें फेलोशिप है, उसी में बना देख रहे थे, लेकिन अभी हम लोग पेरी फेरी में जा रहा है सारा दिन, और किस एरिया आज कर ही रहा होगा, रोटी आए देखती है गार्डन के साथ करके, तो पिछले 2-3 साल में काफ़ी ज़बरदस्त पिकअप, और अपनी लैब भी करता है, लेकिन मैं उसको ग्रेजुअली थेरापेटिक में एंडोस्कोपी में क्या फील्ड बहुत है, सर्जन्स बहुत हैं, जो बेसिक सर्जरी वो करते हैं बस। हाँ मैडम, हाँ नमस्ते, हाँ हाँ हाँ, हेलो, हाँ हो गया, अब वो उनके नाम से इनका करना पड़ेगा, कर सकेंगे?
नहीं नहीं, अब यहाँ तो खाना खत्म हो जाएगा, आप जाए तो वहीं खा लो खाना, कब से शुरू वहीं पर वहीं खा लो।
हाँ ठीक है,
तो ले तो दिए पैसे, चली जाना तो
आप बनाओगे किससे, अब मैं तो हूँ नहीं, बनवा
खाना खा ले, आ तो जाए,
झा साहब से बनवा लो।
हाँ
कितना ठंडा करवा रखा है, मैं कन्वेंशनल वार
कैप्चर कर लिया,
कन्वेंशनल वार बढ़ने का मतलब एक बार वो चालू हो गई ना, यहाँ ये चलता रहे ना तो ठीक है, तू मारना तू ज़्यादा मारना कम, ऐसा चलता रहे तो चल जाएगा ये, लेकिन किसी भी दिन कन्वर्ट हो सकता है, तो इंडिया तो नहीं करेगा, पाकिस्तान ही करेगा और मरेगा, और ये अपने को भी मारेगा।
बॉम्बे कर दो,
नहीं वो तो रेडी है, लेकिन इंटरनेशनल ऑर्डर में क्रॉस कर रहा है, ये नहीं कर सकते, वो नहीं कर सकते, नहीं वो करना पड़ेगा, सारा चीज़ डिपेंड करेगी हाउ पाकिस्तान विल गेट दैट,
पाकिस्तान के पास पैसा
ऐसी कोई केस कंट्रोल ट्रायल आई है कि जिन लोगों को ठंड में बिठाया गया वो कब पके?
सीधे ना कान पकड़ के,
सर
अरे कैसे हो?
एंटीबायोटिक
ठीक था? अगले ना ध्यान कराओ, थोड़ा सा बहुत ज़्यादा देर नहीं, सर बताएंगे क्या है, वेसल रिलैक्स हो जाती है तो सब कुछ रिलैक्स हो जाता है, इनका कहना यही है। क्यों सर?
वियाग्रा तो मालूम है, एंटी वियाग्रा नहीं मालूम,
ये शांति
मैं उनको कूल कर देता हूँ। क्या देख रहे हो सर, क्या कुछ गिरा है क्या कुछ? हाँ वो अभी तो यही चलेगा सर। अभी है ना, इस पर बहुत सारी थ्योरी भी आ रही है कि पाक वाले जो है हमको एग्जॉस्ट करना चाहते हैं हमारे उसको सिस्टम को, जिससे कि वो लोकेशन भेज के है ना।
तो ही सर हम एडजस्ट करने के लिए अपने फाइटर प्लेन उड़ाते जा रहे हैं, वो भी शादी हो जाएंगे।
युद्ध में एक्चुअली में पता भी नहीं पड़ता ना कि कौन कहाँ से कितनी सही इन्फॉर्मेशन
न्यूज़ कभी नहीं मिलती है, यू गेट इट आफ्टर।
पर यह है कि मेरे को ऐसा लग रहा है, पता नहीं गट फीलिंग ऐसी है कि वो पीओके की न्यूज़ मिलेगी सीधी।
वो नहीं देता इस बार,
बलूचिस्तान पीओके और पाकिस्तान क्यों सर पाकिस्तान हो सकता है सिंध वाले बोले कि हम भी सिंधी अलग हो जाएंगे।
अल्टीमेट सर पीओके की तैयारी है।
ये अच्छी चीज़ सुनो सर, इससे थोड़ी गर्मी आ रही है।
क्योंकि 12 तो ईयर बेस है, 1260 में बता दिए। तो सबमरीन कितनी पाकिस्तान के पास? एक वो बड़ी खतरनाक है, चली की लगी सकती है।
अपने पास आज के ज़माने में उनकी सबमरीन मिसाइल की क्षमता थी, वो अंदर ही अंदर चल जाती है। लाइव नहीं सेल्फी बनी
तो वो बना के रखते हैं नीचे, बंकर बना के रखते हैं।
तो आकर चले जा रहे हैं, तो सेटल हो गए ऑलरेडी पीस टेस्ट है।
इंडिया से डिफेंसिव खेला कि अटैक की जगह?
तुम जितना मारते उससे डबल, तुम जितना मारोगे उससे डबल। लेकिन अभी ये सब वो चल रहा है टेक्नोलॉजी। हेलो हाँ आनंद, हाँ गुड आफ्टरनून। नहीं कुछ बताओ, मैं अभी पहुँचा नहीं आया भोपाल। हाँ 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 बता दो।
सर शुरू करवाओ, बुला लो, घंटे बजा दो वहाँ पे।
हाँ
दो शुरू करना।
हाँ
ठीक है, कोई बात नहीं, बैठेंगे आप, दो शुरू होगा।
चलो एक बार मैं बता देता हूँ जो भी रहेगा, मुझे वहाँ का तो पता नहीं रहता क्या चल रहा है, बट एक बार बता देंगे। हाँ ठीक है, तो एक बार मैं बात कर लूँगा, फिर आज तो अब यही है दिन भर यहीं पे
इधर खड़े हैं, इधर से आ जाइए।
The lunch might be over, but the learning continues. Let's pick up where we left off, sharper and more energized.
Now we will begin with the video workshop, How I Do It.
I would like to invite Dr. Virendra Chaudhary sir and Dr. H.P. Yadav sir as moderators to please join us on the stage.
The first topic is non-variceal upper GI bleed managed by endotherapy. I would like to invite Dr. Ajay Jain sir as the speaker.
I would like to invite the chairpersons for the session, Dr. Mukesh Srivastav sir, Senior Surgeon and Endoscopist, Jabalpur, Dr. Nikhil Jalori sir, Gastroenterologist, Sagar Multispeciality Hospital, Bhopal, Dr. Vikas Raikwar sir, Gastroenterologist, Apollo Sage Hospital, Bhopal, Dr. Anand Singhai sir, Senior Surgeon and Endoscopist, Sagar.
Good afternoon, everyone. Now, this post-lunch session is a video workshop. And in this video workshop, we are dealing with all kinds of bleeds which we encounter during our endoscopic procedures. We'll be dealing with non-variceal bleed, small intestinal bleed managed by enteroscopy, refractory ascites, and bleeding during ERCP. So first speaker in that is Dr. Ajay Jain sir from Indore. And he is very well known. And I'll ask Dr. Ajay Jain sir to start his video presentation. The time is 10 minutes, and then for the speaker, and 5 minutes for discussion.
Good afternoon and welcome back to post-lunch session. At the outset, I would like to thank Dr. Sanjay Kumar and team Gastrocare for holding another outstanding update, which is a regular feature by Dr. Sanjay. And every time he comes with a concept of single theme, which is unique. The vascular disorders of GI tract and the liver are something which are missing from our main conferences, and emphasizing it is very important because they are life-saving once you diagnose them early. And if you miss these diagnoses, it is fatal or it's significant complications. So my video presentation it was supposed to be by Dr. Rajesh Puri, but somehow, so I'll be trying to cover some of the things. So we all know what is non-variceal upper GI bleed. So bleeding derived from a source proximal to the ligament of Treats. Variceal, we all know, that is secondary to portal hypertension, and non-variceal, most of the time we know, is multiple causes, and we will be dealing with some of these causes. If we look at the prevalence of bleeding, non-variceal bleeding, upper GI non-variceal bleeding is 4 times more common than lower GI bleed. And if we look at the prevalence, it is 50 to 100 per 100,000 persons per year. And if you look at the complication and mortality, though it is a data of 2012, but the mortality was about 10 to 14%, and it is said that there is not despite significant improvement, the mortality remains the same, and this is because of the comorbid conditions many of these patients have, and therefore the mortality has remained same despite those improvement. I'll skip this slide and let's go to the causes of bleeding. So if you see, variceal bleeding is much more common as compared to non-variceal bleeding. So whereas in our day-to-day practice, but then this was again is a very old data of 2005. And if you look at the Western data of the non-variceal bleed, the most common cause of non-variceal bleed is peptic ulcer, followed by Mallory Weiss. And then rest of the other causes are like gastritis, duodenitis, AV malformation, tumors. But if you look at the majority of the cases of non-variceal bleed, it is peptic ulcer disease and Mallory Weiss tear. If you look at the causes of non-variceal bleed in India, so duodenal ulcer is the most common, which is about 43%, followed by gastric ulcer, and then erosive mucosal disease, Mallory Weiss, and also esophagitis. Tumors presenting as a GI bleed is a less common cause, but it is an important cause, so one should not forget about it. So this is an etiological spectrum of upper GI bleed in my experience of 120 patients over a period of 1 year. So variceal bleed constitute about 48%, and non-variceal bleed was almost to the tune of 52%. And 17 patients in these two groups had both variceal hemorrhage with concomitant ulcer. So when you are doing an endoscopy in a variceal bleed, never forget that this patient also can have a non-variceal cause of bleeding. These are the etiological spectrum of non-variceal bleed in our experience. Total 62 patient, duodenal ulcer, gastric ulcer was 41 patient, esophagitis, gastritis, duodenitis, erosive mucosal disease 14 patients, Mallory Weiss tear was 3, malignancy was 1, gastric malignancy 1, GAVE 1, and vascular ectasia 1. This is our personal data. So management approach has already been discussed by Dr. Hari in the morning lecture, but again, the approach remains the same: initial assessment, resuscitation, history, brief history, and risk factors, because that is important. Localize the cause of bleed, early upper GI endoscopy, nasogastric tube plus minus, and then comes the therapy, and therapy includes pharmacotherapy, endoscopic therapy, and IR. So when we look at the management of non-variceal bleeding, pharmacotherapy and endoscopic management are the two cornerstones of the management. And if we look at the endoscopy, it is upper endoscopy, it is the diagnostic modality of choice, very high sensitivity and specificity, and it is recommended almost all patients following a initial resuscitation. So the international consensus on non-variceal bleed is early endoscopy within 24 hours, and it is also used for vascular ectasias, duodenal lesions, neoplasms, and active Mallory Weiss tear. I'll straight away now go to the GI interventions done by us over a period of 10 years. This is the experience from my previous assignment in Chitram Hospital, and we'll go to the first endoscopic management. So this was a patient which presented with a duodenal ulcer bleed. Now first thing is in a non-variceal bleed and a duodenal ulcer bleed is to identify the place from where this ulcer is bleeding. So the most important thing is flushing the area with water. And now all the endoscopy unit have those water flushing areas. So we have identified, you can see the area here, that there is an active ooze going on, and you take the hemoclip. Now before you apply the hemoclip, it has to be, you have to approximate the hemoclip, put a little pressure after this thing. Once you have fired that clip, wait for at least 10 seconds, continuously keep washing, keep under observation that the bleed has stopped completely. And now you see, with one clip, this duodenal ulcer bleed has stopped. Just wash that area, watch for about 10 seconds, 15 seconds, 30 seconds. Once you are satisfied that the patient has got a hemostasis, and then you are done. And these are the patients which are very rewarding. In next 24 hours, they are into the ward, and maybe another 24 hours, they are back to home. The next important
So here
area,
you apply one clip is sufficient?
sir, in this patient, there was only one clip applied. There was a spurter. Once we applied that clip, there was no bleed. I observed it for almost like 30 seconds, and there was nothing, so I didn't apply.
What is sad is because we don't see the feeder vessels, it is ideal to apply clips on both the sides so that the entry to that area is blocked.
Well, these these are the various concepts. They says कि apply above, apply below, and then apply in the center from where the bleeding is. But sometimes when you have a very pinpoint location and you are just putting it with a good grasping of the mucosa and submucosa, then feeder will also be captured in that. So even one clip is sufficient. It all depends on an individual and the kind of bleeding it is happening at that point.
You could see the response.
Yeah.
You are treating ulcer which is actively oozing or actively spurting like this patient. After applying the clip, you have already confirmed that bleeding has stopped. That is sufficient. But in case where there is a visible vessel and not active bleeding at the time of endoscopic therapy, at their switches you might be correct. Apply both the side, close the ulcer completely, apply as much as clip you can.
The bottom line is, after you apply, wait for 30 seconds. Keep flushing it and look for that there is no any ooze. Even a small ooze, yes, apply the second clip above and one clip below that.
So how do you choose the modality of treatment, like whether you're using clip or injections or gold probe? How you...
Okay, so first answer is it's an individual practice. There are no consensus or guideline that these are the parameters which will decide which will be the best modality. All individual experience and availability of the accessories with you in your endoscopic unit. 10 years back, almost every patient of bleeding used to be treated with an injection adrenaline in 4 quadrants, and then you used to decide what is the second thing which I will be using to control the bleeding in this patient. After the availability of and now the Ovasco, you don't think of the other modalities. These are the 2 modalities if you have available. And now, of course, sometime your band can also work in this. The idea is you compress the vessel, allow that vessel to thrombose. And because most of the duodenal ulcer or gastric ulcer are secondary to H. pylori infection. So the second thing is you immediately start them on anti-H. pylori treatment. The healing starts. Once you have healing started, then there is no problem. My preference is always hemoclip. I am not very comfortable with Ovasco, but hemoclip because you can apply 2, 3 and you can control the bleeding. Sometime if your area is not accessible, your endoscope is making an angle, then in that case what I do is I first put 4 quadrant adrenaline, control a bleeding little bit, get a little extra time for myself, position it. In that case what happens, you have the mounts available and you just close those mounts with 3 or 4 clips and the bleeding vessel is in between that and it gets completely compressed. So the initial, when the clips were not available, we always used to say the hemostasis by 2 methods. One is adrenaline, second is this thing. But nowadays you can choose only one method, if Ovasco, hemoclip. But if there is a difficult situation, then I will do first injection, create the mount, and then apply the clips.
Ajay sir,
yes.
So what are the advantages of your injecting adrenaline 4 quadrant, stopping the bleeding, and then doing the second modality like thermal or maybe mechanical?
Okay, the first and most important.
What is the disadvantage?
The first and foremost good advantage is that it gives you extra time to identify the source, make you comfortable, because if the patient is actively bleeding, despite that, and there is a pool of blood, you don't know where to catch, where to apply the hemoclip and all that. So when you inject, it gives you a temporary hemostasis. And once you have got a temporary hemostasis, you know exactly what is the cause and how do I, so you have a time to think about the modality. The only disadvantage is if the patient is having underlying cardiac disease and they can sometimes cause arrhythmias and other things. But most of the time, because it is 1 in 10,000, it is submucosal and mucosal, it takes time for absorption. So these kind of disadvantages are not there. It gives you extra time, which is the best advantage, and gives you a better field of vision and clarity.
Any questions from audience?
I have one more, the two more. Just quickly, I'll go through that.
We have
So-
very little time, so you could just project.
So will not discuss it. So this is a duolophile lesion, and in duolophile lesion, if you find like this, the best modality is Ovesco clip, because this is how an Ovesco clip, you keep the lesion in the center, suck it, while sucking there will be bleeding, don't get afraid, and apply the Ovesco clip, it will be done. The third modality is another important thing. So this is Mallory Weiss, and this patient had a hemoglobin of 14, dropped to 8 in 2 hematemesis. So that was a massive GI bleed because of Mallory Weiss, and we treated it initially with, again, a clip. So that's what Dr. Hari I was saying. First 4-quadrant adrenaline injection, because there was a massive bleed. I was not very sure from where it's, because it was a Mallory Weiss. So 4-quadrant this thing. And in next, I'll just show you. And next I could apply the clip on the teared area from where it was bleeding. And after, now I have a follow-up of this patient for almost like now 3 months, and the clip has now almost fallen, and the bleeding stopped completely. And the advantage is when you use XI, you can change and you can see if the bleeding has stopped completely. And you see that the bleeding has stopped completely. I think my time is over, so I'll stop it here. If there are any questions, I'll be happy to answer.
Because of shortage of time.
Thank you. Thank you.
We'll ask the second speaker. The second topic is fundal variceal bleed managed by US guided glue/coil. And the speaker is Dr. B.S. Ravindra from Bangalore. And the chairpersons for this session are Dr. Ambar Mittal, Dr. Alok Bansal, Dr. Shivesh Thakur, and Dr. Sandeep Aherwar.
I would like to request the speaker and chairpersons of the previous session to please gather at the selfie point for a picture.
In fact, we had good discussion about non-variceal bleed in the morning in the panel discussion itself. So that is why we have curtailed the questions. We have already dealt with the questions in Dr. Hari's panel. Dr. Ajay के साथ में थे, please.
All the chairpersons of the previous session, please come to the selfie point.
Because so the idea of having video workshop is that we get to see how a person would perform if challenged with such a case. So I think now Dr. Ravindra will tell us in a fundal varus how would he manage.
So till the session starts, one question like sometimes we see in upper GI bleed that there is a lot of blood, altered blood in stomach, but we are not able to identify the cause. What is the source of bleed? Because dilophy sometimes we cannot see. So what is the approach? You know, the audience can answer. What should be the approach in such cases?
I think,
If the best thing is keep flushing that area where you are suspecting. And sometimes dilophy after the bleed, they just collapse completely and you will not find it. But if you are suspecting, if you have flushed that area and you have a little suspicion, wait for a while. You will see another ooze coming from that area.
I think so what you are saying is that patient had upper GI bleed, you have done scopy, you have washed everything, you have not found any lesion. So one reason could be this, what sir has said, the Olaffoy's lesion, which is not seen. It is seen only when it is bleeding. The second could be other causes like hemobilia or hemosuccus pancreaticus. So it is a good practice to do if there is slightest suspicion, always go for a CT angio.
See, there are two,
CT
three.
angio.
Another important thing, Sanjay, always do a repeat endoscopy. If you have not found, resuscitate patient, bring the blood pressure up to 90 systolic, do a repeat endoscopy. And in between, because when he come for the first time, he has bled somewhere and then you are doing an endoscopy. Do a second endoscopy right at the time when he bleeds in the hospital. You will find the lesion.
So his point is when endoscopic examination is unsatisfactory because everything was full of blood, like the case I've shown in my discussion, nothing was visible. So we subjected the patient for CT angio, that is the one investigation. And second, even if your examination is satisfactory, but you are not seeing the lesion, then suspect Dulaffoy or suspect the lesion outside the lumen, like hemosuccus pancreaticus or something else. So in non-conclusive endoscopy, CT angio is one of the good investigations.
Another important thing is when you are taking a patient of upper GI bleed for an endoscopy and actively who has just bled in about last 6 to 8 hours, use intravenous metoclopramide or erythromycin at least 3 to 4 hours while patient is getting resuscitated. That will give you a much better picture because the blood has passed and you will have a clearer picture.
So second is like Dulaffoy's lesion, you put a Ovesco clip. Sir, it is not affordable by everyone. Like even a small bending can help in Dulaffoy sometime.
Absolutely. See, today in endotherapy, what you do is your personal preference, availability of the accessories, and affordability. There are absolutely no guidelines to suggest that in this particular lesion you do this and in this particular lesion you do that. So all innovations which can stop the bleed. Initially, 5 years, 10 years back, all Dulaffoy lesion used to be treated just by injection sclerotherapy. There was nothing else available at that time, and patient used to be treated and patient used to survive. So it is all availability of accessories, affordability, and your expertise.
So you have to be aggressive in a patient, like Hari said, when you have a lot of blood and you are not able to see anything. So try all measures, be very aggressive. Like you can put in sometimes a therapeutic upper GI scope to clean the stomach well, because or a dual channel scope where you can do better. You can change the position of the patient to look for lesions. So do all aggressive efforts. If the BP is very low, then bleeding may have stopped, so you can bring up the BP.
Is it taking time? Do we have time to discuss?
So what you can do is, Dr. Ravindra, if it is taking time, can we take next session? Is it done, or we connect to Mohan for the next session?
Otherwise, I mean, just one comment regarding this GI bleed. One of the things we often face is the problem of not finding a lesion, especially with respect to Dulaffoy's. If it is bleeding, most of the times you can find. Sometimes you will not be able to find anything. Patient has bled, but you will not find it. So best thing is to tell the patient to come when the patient rebleeds. That time you will be able to pick up something. Recently we had one patient, let me just share it. Elsewhere he had 2 endoscopies done. Came to us, we did one upper GI endoscopy, had a GJ. The GJ stoma, there was a little bit of, just erosion or something. He was not convinced that it's a cause of bleed. He had bled so much that, HB dropped to 5, 6. Then we called him, we told him we could not find anything. Now, be in the hospital. So he was there in the hospital, discharged home. After the 4 days, he bled again. Came to hospital just yesterday, happened to do an upper GI endoscopy. It was in the fold, a small ulcer with a clot, maybe visible vessel. And it was just at the junction of the fundus and body and the posterior wall. He had a GJ stoma as well. So maybe I think at the time of bleeding, you should do an endoscopy.
Another important thing in patient who has upper GI bleed while doing an endoscopy, please use conscious sedation. Doing without conscious sedation sometimes may make patient uncomfortable and you are likely to miss the diagnosis. So whenever you have a therapeutic endoscopy at hand and you want to, you are interrogating a patient of upper GI bleed, I will always suggest that patient should be under conscious sedation Patient should be absolutely comfortable. That will give your yield, or that will increase your yield of diagnosis significantly.
Ajay,
Yes, sir,
what about
agree.
what
But
about
it's very
intubation?
important.
then?
Sometimes we need
Ajay,
to intubate
intubation. The patient is bleeding massively.
Patient is sick, massively
Intubation, yes,
bleeding.
if patient is bleeding massively, hemoglobin is less than 8, patient's BP is less than 90, I will always ask anesthetist to intubate, because that will give me much more comfort and the chances of aspiration are less. But otherwise, a simple GI bleed and patient is, conscious sedation is something, don't do without conscious sedation.
Yes.
Recently, I have seen a patient with massive upper GI bleed. That patient have done twice endoscopy, and they referred patient for digital subsection angiography to SGPGI Lucknow. But the patient came to me. I have seen a large ulcer in diverticula in D2. Narrow neck diverticula is there, and there is a large ulcer with vessel at the base of the ulcer in that patient. Sometimes common things are missed.
Yes, yes.
So meanwhile,
That's the
Dr.
use of
Mohan
re-endoscopy.
is online, so we are having his lecture first.
Okay.
Okay. Yes, you can connect.
Yes, Mohan. Are you hearing us? Hello.
Can you hear me?
Unmute yourself, Mohan, please.
Hello, can you hear me, please?
Yes,
I'm
yes.
unmuted.
Yes.
आवाज आ रही है मेरी?
Yes, आ रही है, अच्छे से आ रही है भाई.
Okay. So, so thank you, sir. Once again, I apologize for my absence from there. But anyway, we have some technology to connect. So my goal was to talk about how do we do the small bowel bleed management, especially with the enteroscope. So I'll present a case. Recently we saw this case, sir, 65-year-old male. He had hematochezia and there was no hematomesis. So he had a red blood but no hematomesis, requiring 12 units of transfusion. There was no abdominal pain or NSAID history, no anticoagulant, no surgery. He came in a shock and he was very pale and he required almost 12 transfusions. There was no stigmata of chronic liver disease, and rectal examination showed no mass and other systemic examinations were normal. Hemoglobin was 6. Liver function test, kidney were normal. We did upper GI colon, it was done outside, which was normal, and ultrasound was also normal. So now we have a patient who is bleeding, but upper GI and colon are normal, ultrasound is normal, no CLD, 65-year-old male. How will you approach this patient? So normally when a patient comes to us with hematochezia and upper GI colon are normal outside, we must do the repeat endoscopy, second look endoscopy, because there may be 35 to 75% patient who will be positive for the repeat endoscopy, because some of the lesions which were bleeding may disappear while the first endoscopy was done, like fundal varices, sometimes angiodysplasia, dulafile lesions. Also, some lesions may be overlooked, like Cameroon ulcers or, the peptic ulcer on posterior wall. Even lower GI, sometimes neoplasm like gist can be overlooked. When it comes to mid-GI lesions, we must know the age of the patient. If the age of patient is less, we must think about tumors like gist, diverticulum, or dulafile lesions, or Crohn's disease. While if the patient is older, we must think about angiodysplasia as a common cause or painkiller medicine causing this. So this is very important to do a side wing endoscopy always. Whenever a patient who comes to you with GI bleed where nothing is found, we must look out for hemobilia, hemosuccus. So always do the test according to the age. Like our patient is 65-year-old male. So I will not think about diverticulum or tumors because they are seen in more younger population. But once it comes to you, then how do you manage these? So some of the causes are, we'll come to the algorithm in the end, But my topic was how will you manage by enteroscopy if you have enteroscope. So the enteroscope is either a double balloon or a proximal balloon. We have no spiral now, and these work on pull and push technique, where a over tube is there and through which endoscope will be passed like this. This is on the left is the double balloon. Balloon is inflated, which fixed it intestine, and then followed by a over tube. It fixed the loop in the stomach. Then you push forward, and then you inflate the balloon, fix the intestine, go with the over tube again, and inflate. Now you reduce. Once you pull back, the bowel gets pleated and intestine gets shortened. And then subsequently same, push and pull cycle, and then advancement will happen. So this has brought paradigm shift in management of the disease because you can reach to these lesions which are vascular in nature. Now this is the most common in older age population, like our patient, 65 patient old, you can see these angiodysplasias. And these angiodysplasias can be easily managed by APC. But the APC setting is 40 watts, 1 liter, pulsed, short burst, and around 2 to 3 millimeter away from the the lesion. You can see, you can just do this type of APC and get rid of these angiodysplasias. There can be many, but this is the way we use this. The second issue is when you see this is the patient who underwent stoma for GI bleed because operation was done outside, but they could not find. So we went inside with the enteroscope and saw a lesion like this. And in our unit, the clipping was done, but still the bleeding is happening. You can see there's a big pulsating vessel. This was done yesterday only, maybe 9/5, yes. So you can see a pulsating vessel. And the initial clipping didn't work. So must do elevation. Its elevation is important because small bowel is very thin. So you must do a tamponade first, and then like a duodenal ulcer morning we discussed, you can do either a gold probe or a quack grasper. You see, through the enteroscope, it's difficult to pass quack graspers but if you have a short enteroscope, short length enteroscope, you can pass the colon length quack graspers. So you can see we are doing the coagulations, complete coagulation, but don't overdo because you may perforate. That's why it is important for us to elevate or to do the tamponade first, and underwater you can deliver a soft coagulation. And once you have completely achieved this, you can always clip because once you have done a mucosal burning, there can be delayed perforation. So now we are closing the defect which we created while doing coagulation. So this is how the small bowel GI bleed is managed. Sometimes you may have a dulafy lesions like this. And then you must do you can do anything, but I think the clipping is the most important. Again, we injected and then put multiple clips. So if you have a short enteroscope, which is 180 centimeter long, it has got a 3.2 channel, and that helps in passing these clips because when the loop is there, then it is difficult to do clipping, not like a straight endoscope. So it's difficult to pass the accessories when you are deep into the small intestine. And 2.8 channel of a long enteroscope is more difficult. So if you have a short enteroscope, 3.2 channel is the best for this. The other things which, like a younger patient comes to you, then tumor is the most common cause. Like you can see here, this can easily be picked up by CT scan. But if you find such type of lesion, you cannot resect. Just in the small intestines are difficult to resect endoscopically. Must be sent for surgery after biopsy. Sometimes we take the biopsy to start imatinib. If there are lymph nodes and not operable cases, you can do that. But if actively bleeding patient, best is to do surgery. Or sometimes you can have a Peutz-Jeghers syndrome, which can cause such type of bleeding. And you can either do a EMR inside the small intestine and get rid of these tumors completely. So I'll not go into the full video. So these are the patients who are young, who have tumor or Peutz-Jeghers syndrome or diverticula. Always think about diverticula. If a patient is less than 25-year-old, come to you with bleeding, always think about Mickel scan. Always do a Mickel scan. And sometimes Mickels are falsely negative. But if you see this patient who was a 20-year-old guy, whom we did a enteroscopy retrograde, Meckel's was negative, but we found a big diverticulum ulcer. And this is the intraoperative picture. You can see a big Meckel's diverticulum. And these Meckel's diverticulum has ulceration because of ectopic gastric mucosa. These are the ectopic gastric mucosa. And these patients do well after surgery. Crohn's disease isolated ulcers are common, but they don't present as severe bleeding. They have occult bleeding, and patients usually present as anemia. As I said, don't forget side viewing endoscopy. Always look for hemophilia, or a CT angio will take care of the aneurysm or anything. So algorithm, one must see a CT angio always. Once your patient comes to with obscure GI bleed, always do a CT angio. Never give oral contrast. If you give oral contrast, such type of visceral blush will disappear under the contrast and you will not be able to see. So CT angio always with a negative contrast. And angiography is important. I'll not go into the more detail because of want of time. But if patient is briskly bleeding, hemodynamically unstable, you should not waste your time on doing tests like capsule, which will give you one diagnosis, then take time. We don't have time in this case. So we always think about modality, which is diagnostic as well as therapeutic. So brisk bleeding, always do angio first. Role of nuclear scan is not much, but there are two types of nuclear scan, technetium sulfur, which take the active bleed as the, it is good for active bleed, but mostly technetium's labeled RBC scintigraphy is done, and it is most sensitive because it can catch not only active, but also venous bleed, which is slow bleed. I'll not go into the details, but you can see once you are reading a nuclear scan, you must see a focus like this, and then it should increase in intensity, like gradually it is increasing in intensity. And then the movement of the tracer, it should go retrograde or antigrade or conformity to that organ like colon or small bowel, like in this patient. You can see there is a focus which was not there, and then gradually the focus is increasing. Then it is moving to and fro. Then it is conforming to organ like a descending colon. So if you have such features on nuclear scan, you can have a rough idea where it is bleeding from and you can take care. So small bowel is the key. Dulophyll lesions you can manage. APC I already told you. In India, you must not forget hookworm infestation. This patient has severe hookworm infestation and was only going here and there. This patient underwent a laparotomy for GI bleed, and this was obscure overt GI bleed. Hookworm usually have occult bleed, but if you have a severe hookworm infestation, they may cause overt bleed. And just mere one albendazole cured this patient. He was going here and there with, you can see these copper wire appearance. Whole of the intestine are infested with hookworms. That was in 2009. So in the end, I will say that enteroscopy is a good option, but if the patient has intermittent occult bleed, only anemia, don't go for balloon-assisted enteroscopy. Go for capsule endoscopy. If patient has overt bleed or hemodynamically unstable, you can think about balloon-assisted enteroscopy or angiography. But if patient has pain, vomitings, SAIO type of picture, anemia, bleeding, at that time you must take a help of CT or MRI and then go ahead. So these are my another same I told you, but coming back to the case, we have a 65-year-old male who was bleeding, hematochezia, His upper GI colon was normal. CT was, angio was normal. CT angio is normal in this patient. And IR says that if CT angio is normal, their pickup rate with angiogram will not help. So they did not do. Nuclear scan was also normal, not considered. Capsule endoscopy, we thought patient is actively bleeding. It has no therapeutic capability, so we did not do. So we were left with a stepwise approach of how to do. So you see, once we do endoscopy, repeat endoscopy, we find lot of blood in the stomach. So whenever you find lot of blood in the stomach, you must think that the bleeding source is proximal to ligament of Treats. But in this patient, we went inside, only blood was there, but there is nothing up to ligament of Treats. So upper GI was showing blood, but nothing up to ligament of Treats. The second step is to do side viewing endoscopy to see if the papilla, you see the minor papilla there, and the major papilla is also normal. So now we have exhausted everything. Patient is bleeding, but from where we don't know. Then we went ahead and put a cap on the enteroscope and then go into the jejunum. This is the single balloon enteroscope, a short single balloon with a bigger working channel, and then this is the pylorus, and then you go into the duodenum. There is, as you can see there, what happened? There is a big diverticulum. So this is the big diverticulum in the proximal jejunum. And then there is an adherent clot there. And this adherent clot must be removed. As we discussed in the morning, never leave the adherent clot. Don't think that adherent clot is there, I will not do anything. Remove the adherent clot, and now you can see there is a big vessel there. This is the vessel. See that? Now you suction, there is a bleeding. So this is a diverticulum, and the bleeding is not that brisk. That not brisk means angiogram will be normal. So patient is shocked, angiogram normal. And this is the only way we can catch by doing enteroscopy, but very difficult to apply clips. When it comes to the diverticulum, you may have to come back and then do suction and then apply the clip when the suction is there. You can see by that you can catch the vessel. So application, and you are using a openable and closable clip, which if you use a one-timer clip, you may not be able to put it rightly. And you can see now we caught this vessel, and then another clip. Important, you must put another clip so that the bleeding, because to reach there is so difficult, and once you have, you should at least put 2 or 3 clips to completely secure the bleeding. So you saw how this patient was managed, adult patient, elderly, we did everything, and ultimately it was balloon-assisted enteroscopy which helped to stop the bleeding. So with this, I'll end my talk here, and will be happy to answer the questions.
So because of shortage of time, questions will not be allowed in this session. We'll again start with the same. Dr. B.S. Ravindra will...
yeah, I think your presentation
is
is
ready.
No? Mohan, will come back to you because we are already running late.
Yeah.
Maybe that
Okay.
post-poem bleed, we'll think where to adjust. Huh? So thank you so much for your talk.
Okay.
It was really very enlightening, the way you approach this case. And I think he deserves a big applaud.
Oh, thank you so much, sir. Thank you. I think Virendra is there. Virendra is my batchmate, and I'm missing to meet him. I thought I will have beer with him in the night.
You can still fly.
You can have it online.
We'll have an online cheers.
Online, okay.
In fact, all of us are missing you, beer or no beer.
Oh. Anyway, let me know if somebody wants to hear about ESD bleed or poem bleed. I'll be there, sir.
Yeah, because we are late, we might not have that session, but we'll come back to you. Meanwhile, you can see few patients, manage few more bleeds.
Yeah. Thank you so much. Thank you.
Thank you. Thank you, Mohan.
I would like to request the chairpersons to please come to the session.
So there. Kshitij Nath from Jhansi. I'll request Dr. Girish Ramteke. Sir, you can also join. And Dr. Kamlesh Tawri. So the same set of chairpersons can take us through the next two talks. Dr. Amar, you are...
Yes, sir. Yes, sir. So, my screen is visible, sir?
Yes, yes, it is visible very much.
Okay. So, shall I start?
Yes, please.
Okay. So, first of all, I would like to thank Sanjay sir for having me here. So, I'll be presenting two quick cases, one for hepatic hydrothorax with ascites and one for refractory varicose bleed, where we did a TIPS. So the case one is of 60-year-old male, ethanol-related CLD, portal hypertension, who was on primary EVL. And then there was decompensation with ascites, right hydrothorax, hypertension, hypothyroidism was also present. And he presented with abdominal distension, shortness of breath since February 2024, had gross ascites and right pleural fusion on ultrasound. And for that, intercostal drainage tube was placed on in February 2024, which was draining almost a liter of fluid every day. So this is the X-ray of this patient. You can see that there is a massive hydrothorax, almost the complete lung collapse on the right side with mediastinal shift. If you see the trachea almost shifted onto the left side. And the fluid analysis was done for the pleural fluid. So it was a high SAG effusion. And there was no bacteria seen on gram stem and no growth on the culture. This is the CT scan, which was done on 11th. The next day, you can see still a lot of fluid. On 12th, there was some reduction. We can see some enlargement and some lung coming up. This is how it was seen. And again, on 15th, after draining 1 liter every day, you can see there is expansion of the lung, and this is the lung. If we see the lab parameters, then hemoglobin was normal, creatinine on a higher side because of diuretic-induced AKI. Bilirubin was normal, AST, ALT more or less normal, SAP, GGT more or less normal, low albumin. He was planned for TIPS, and for that, the MELD was calculated and MELD sodium was 16. He had a CTP score of 9, CTP-B. Age was 65 years, so just a borderline case. There was a sarcopenia noted in the patient, and there was no history of prior hepatic encephalopathy. But based on sarcopenia, severe sarcopenia, and we also know that hydrothorax may or may not improve with TIPS, and the outcome is very, not very clear. Like in ascites, we have a better outcome, but same may not be true for hepatic hydrothorax. So we thought whether should we do or not, but finally the consensus was yes, we should go ahead. So this is the patient position, how the patient is positioned. You can see there is ascites with hydrothorax. This is how it is. We place the patient. This is the video. I'll be switching on the video. So you can see these are the basic hardware. This is the metallic cannula, and these are puncture needle. The sheath has already been placed. You can see the sheath, which is from the neck going through the right atrium up to the right hepatic vein. And once it is placed, then we use this cannula. It has an arrow over here, and gently it is advanced so that it goes up to the right hepatic vein. You can see here, the sheath was already there in the right hepatic vein. The cannula has already reached over here. And then simultaneously, because for the ease and we don't want to puncture it time and again, we also take an ultrasound guidance. And you can see through that metallic cannula, we have taken a needle. So now we are trying to puncture the portal vein. So we take a simultaneous ultrasound and fluoroscopy guidance. So in the cath labs, initially we took fluoroscopy, and now under ultrasound guidance, we are trying to target this portal vein. You can see here, we are pushing our needle, and gradually the needle was first pushed inside. Then we felt that it is not going into the portal vein. We pulled it out again and again. We are trying to push it inside to target the portal vein. And you can see on this ultrasound, this needle is going, maybe slightly missing the portal vein, but now we feel, yes, maybe it should puncture the portal vein. So this is the ease what an ultrasound provides to us. So we can use ultrasound to best of its advantage to target. So previously it was slightly missing. So now you can see my needle going, and we are almost there. So we can keep looking at both the things, the fluoroscopy image as well as the ultrasound. And now on ultrasound, you find that we have punctured the portal vein radical over here. We have gone inside. And after going into the portal vein, we take a venogram. So this is the venogram what we get. It is the portal vein. This is the tip of the catheter is in the superior mesenteric vein, the main portal vein. And here in the right portal vein, we have punctured. This is our sheath catheter. And you can see the drainage catheter into the pleural fluid. And now we are inflating the balloon to dilate the tract. The tract is being dilated. And because this patient was a sarcopenic patient and we were not very sure, so we thought we should place a small stent. That's why a 7 mm stent was planned for him. But we further underdilated it. So you can see this is a very small balloon, a 6 millimeter balloon. So we are using a 6 millimeter balloon to dilate. And then after dilating, what we do, we use a marker pigtail. So you can see these dotted marks. These are gold markers, which represent 1 centimeter distance. This is to measure the length of the covered part of the stent. So we are taking a simultaneous run. So you can see a contrast over. You can see a contrast in the portal vein. So 2 people are injecting simultaneously contrast into the portal vein as well as the IVC end, so that we know exactly what is the length of the parenchyma, which is to be covered by the covered stent. Then we further ascertain, we take our sheath inside and we just see what was the puncture point. This is how we see the puncture point, and then the stent is placed over here. You can see this is a stent. So uncovered part is placed into the portal vein, whereas the covered part is into the parenchyma. And now what we see, we can see some flow coming. So because it is a small stent, you can see the central part has not fully opened because we have underdilated this stent. And there is a flow from the stent into the systemic circulation into the IVC. However, it is not great. But we chose for it. So you can see this is the dilated part of the stent, this is the dilated part of the stent, but the central part remains constricted. So post-procedure lab parameters, if you see INR more or less preserved, creatine in fact coming down, did not increase. Bilirubin, there was a slight increase, and AST-ALT more or less stable. SAP-GGT on the similar range, albumin on a similar range. But again, we saw that the fluid is maintaining, it is not going down. The fluid level is almost of the same level what we had done. Then on follow-up, we saw that again, the peak systolic velocity within the stent was low, that was 55 centimeter. And we were draining fluid, lot of fluid every day. So patient was required tapping despite tips. So we are not very happy with this picture. And further the pressure going down. So we thought that we should dilate the stent again. So we took the patient for venogram. We did a balloon angioplasty. So we further dilated the 6 mm stent. Previously it was underdilated. So we further dilated it with 7 stent angioplasty with 7 mm balloon. Post angioplasty, the patient had breathlessness on the next day. And X-ray, if you see, the X-ray has worsened. And there are features suggestive of pulmonary edema. Altered sensorium was also observed and suggestive of hepatic encephalopathy. So 2 things happened after dilatation because shunting increased. So pulmonary edema happened, and more or less there was ammonia building up and which led to hepatic encephalopathy. However, the patient was managed conservatively. And on 27th, what we found that there was some improvement in the X-ray, while the patient was managed in ICU with all diuretics, terlipressin, and other things. And on 2nd, we found that 2nd of March, maybe 5 days later, the lung was much better. Everything fluid has reduced. Patient responded, came out of hepatic encephalopathy. On 9th of March, we see that drain was very less. And on 11th, we were able to remove the drain. And so finally, the patient was discharged. And the patient is on follow-up. And even on today, he is doing well and didn't have any further episode of hepatic encephalopathy. Leukopenia, where you are scared of hepatic encephalopathy, putting a small stent may help. But graded expansion is another way how you can tackle these patients where you are not sure whether you should do a TIPS, so you can put a small stent and then you dilate it. So this was one good case where we did
Dr. Amar.
TIPS for hepatic hydrothorax and we got a good case.
Dr. Amar.
Next, a quick case
Dr.
for...
Amar, can I stop you here? I think one case would
another
be,
case, if I have time, I can...
You are already over the time. So you can stop here. We have already seen, we know the indications. If there are any questions with the chairpersons or audience, you can please answer those.
Okay.
Let us skip the second case.
Right.
Yeah.
Dr. Viren, this side, like you did
Okay,
this.
sir. Right.
Yeah. You did this case for hepatic hydrothorax.
Yeah.
So what is your data in case of hepatic hydrothorax? What role of TIPS and what is the success rate?
So for hepatic hydrothorax, we are very careful in choosing a patient. Unless until a patient is having a good liver functions, we generally don't take. So in this patient, the only contraindication what we felt was sarcopenia. So apart from it, if you saw the bilirubin was below 1 and MELD sodium was 15, CTP reducing the diameter. Further, if you are using a 7 or 8 millimeter, we can reduce it to 4 or 5 millimeter. Using a 7 or 8 millimeter, we can reduce it to 4 or 5 millimeter by parallelly placing 2 stents. So we do it in patients who are not placing 2 stents. So we do it in patients who are not being managed by the medical management. So that is one of the options. And in worse circumstances, we need to occlude the stent. That also may be required in, very less, but yes, may be required in some of the patients.
Thank you, Amar. Because paucity of time, we are not taking further questions. We can discuss it later on. Thank you.
Sure, sir. Thank you, sir. Thank you.
You announce for the next speaker.
I would request the moderators and chairpersons to please be seated, and I would request Dr. B.S. Ravindra sir to please join us on the stage for the presentation.
I think finally the third attempt is successful in the Apple phone. First of all, I would like to thank Dr. Sanjay for organizing a wonderful workshop. That is a theme-based workshop, which is very informative for all of us. Yeah. I think Dr. Sanjay told me it is like a workshop, how we do step by step, how do we do a US guided fundal varix and glue injection. That was the whole idea. Today, our armed forces are fighting a very hard battle. Let us all salute them. We are safe here because of them. And then with this, let us start this. Gastric varices and duodenal varices are submucosal collaterals in the set tension. It is seen in 12 to 20%. And duodenal varix is seen in less than 10%, 5%. And then bleeding from gastric varices is around 10 to 30%. And these two classifications are very important in the management. We all know Sarin's classification, GOV1 along the lesser curvature, GOV2 along the fundus, IGV1 no esophageal varix, only in the fundus, IGV2 this is in 4.2%. And then this is the very, very important classification. Who starts doing endoscopic ultrasound is this Arakawa classification, which is a new classification, wherein how to target the fundal varix. See, if there is a single vein and that branches into different vessels, You can just put a coil and glue in this area. This is a feeder vessel. Then entire these vessels will get obliterated. This is Arakawa 1. Arakawa 2, all multiple vessels are there. I don't think here that method will not work. This is a second very important classification. Who starts doing EUS, this is a very, very important classification. And how do we evaluate these patients? All of us, we do an endoscopy. After endoscopy, if we find a fundal varix, I think although just because we have a hammer, not all hammers should be only on EUS guided fundal varix. We do a CT with a angio sequence to look for a shunt. If there is a condition where we can do a BRTO, that is one thing we have to evaluate in all patients. And then all these patients will undergo the regular blood investigation, CBC, INR, create, sodium, potassium, MELD, hemoglobin, platelet, INR. They are very crucial before we do an endoscopic ultrasound. Of course, EUS, after an endoscopy, we do an endoscopic ultrasound. I think primary prophylaxis is not those who have not blood, and then those who have blood. I think primary prophylaxis still remains propranolol and nadolol in GOV2 and IGV1. Those patients who have not blood, there is no indication to put them on a coil and glue. I think still we can manage them on propranolol and nadolol. Whereas GOV1 can be managed just like esophageal varix. I think why we have changed from the regular glue injection which we were all doing. See, this was in 2010. All of us, we used to do this fundal varix injection and it was quite successful. But we all of us had this problem. See, in this case, patient is heavily bleeding, not able to see anything, full blood, and these are the conditions we see this very, very pathetic situation. We are in endoscopy is in pathetic situation. The patient is in pathetic situation. Nothing was visible in this case. And then finally we used to do blindly some glue injection and which never used to work well. This is how we used to work very hard to inject the coil, inject the glue. And then now, because of these two reasons, EUS guided coil and glue started becoming popular. How do I start? First is my hemoglobin should be around 8. INR better to keep around 1.5 to 2. Do a CT, look for the shunt. Always discuss with the IR before you do a EUS guided coil. This is very, very important. And an anesthesia clearance. This is what the thing I do. These are the things what we need. This is the EUS scope, 19 gauge needle, and then distilled water, coils, and then the glue. These all should be in a tray. This is very, very important. Let me tell you, at least this is most important. Most of the time we don't do this. 2 ml syringe, at least 5 to 6 should be there in that box. And then all the coils from 8 to 20 mm, 2 in number. This is very, very important because what we do, we start looking at the coil when we put a needle inside. That's why this is very, very important. And then points to learn before using coils. As of now in India, we have only Wilson Cook coils. 035 inches means 19 gauge needle we can use. 018 means you can use 22 gauge needle. Always coils presently available are between 8 to 20 mm Nestor coils, and width is between 50 to 200 mm. This basic understanding should be there for all of us who are doing EUS. 19 gauge means 035, 18 inch means 22 gauge. This is very, very important before you choose the needle. And then coil size, how to know the coil size. If there is a more than the width, 10 mm means go for 12 mm or 13 mm. This is how the coil which we have to choose. And then as I told you repeatedly, 22 gauge means 018 coil. Both Boston, Wilson Cook and Olympus, all of them we can use. And then next important thing is keep 2 ml syringe water. This is normal distilled water we should use. Coils to be pushed through the EUS needle and then put 1.5 to 2 ml distilled water. I will just go through this. See, this is how first is the endoscopy. See this? This was the large fundal varix which was there. This is the first step. And once the first step is done, the next step is put water. See, this is how 150 to 200 ml water you place. How to differentiate from collateral from fundal varix. See, this is the mucosa, just beneath this is the vessel. This is how to differentiate. Most important is don't puncture the collaterals. Put it to the varix. This is very important. See, this is a collateral. This is a fundal varix. How water is there, mucosa is there, submucosa is there. Behind this you have the fundal varix. This is how to differentiate a fundal varix from the collateral. This is the first step what we do. Next, the second step is the measurement of the size of the, once you put in, you just see in this case, it is coming around 15 mm. That means this patient needs around 18 or 19 mm coil. Means 20% above the width coil. This is very, very important. Second important point in this. Once you do this, see, then we puncture. And then this is how, this is the important step. See, this is how it has to be attached to our Boston needle, and then push it inside 2 to 3 centimeters, and then with the same 19 gauge needles, the catheter or needle you have to push. This is exactly how we do EUS guided coiling. See, we are pushing that Nestor coil into the fundal varix. See, slowly it will come. See, this will enter inside the coil. This is how the coil. See, even in a patient who is bleeding without EUS guided coiling, that's the beauty of EUS guided coiling. See, now the coil will enter now. We are pushing the coil. This is how the coil is pushed inside. See, now the coil has entered. See, this is how the coil is entered into the fundal varix. Now, suppose you put one coil and there is a fundal varix even below that. How do we do this? See, now you have injected 2 or 3 coils here, but you are seeing one more big bunch of vessel. This was a 4 or 5 centimeter large fundal varix. How did we do? First 2 coils here, and then what I have done is, once these 2 coils are there, puncture, don't pull the needle out. Once again go inside. See, now I am pushing the coil, the needle inside. See this, now I have come to the second area. And then you can put another 2 or 3 coils into this fundal varix. First 2 coils upper, next another 2 coil down. See, now we are putting another 2 coils inside. See, this is how we inject the coils. Now, what I do nowadays is, because the problem is in India is we have to reuse. That's a problem in India. See, after that what I will do, I will see whether there is the vascularity is reduced. This is how the vascularity is reduced now. Then I am sure that the vascularity is completely gone. Means, put the coil, see that the vascularity is reduced. Once the vascularity is reduced, see this, the vascularity is reduced. Then what I do, instead of do is traditional way. What you can do is just go in and then see, put 0.5 ml or 1 ml of glue on the endoscopic guided. But here you will not find any bleeding, because already this is everything is now obliterated. Just you need to put see, there is no bleeding at all. The same vein, if you directly puncture, lot of bleeding can happen, and you have to put lot of glue. This is how, and we can reuse the needle. There is no problem with the EUS scope also. This is a big advantage. We can use, this is how we can use. And then finally, see, this is one more method. Our other method is, so through the same, this thing now we are putting glue. But the problem here is, in India we always reuse. Our patients, there is a problem. That's why, see, now with the same needle I am putting the glue. But the problem is, after that this whole needle may get blocked. That's why we can use it, and then we can reduce the cost of the EUS guided coiling with the same efficacy. This is what I do in my practice day to day. And then, see, finally, this is the final picture wherein we have glued it, the completely obliterated varix. That's what is happens. See, this is a completely obliterated varix, the large varix completely obliterated. And after the various steps I showed you, keep the hemoglobin 8, broad spectrum antibiotics. I continue octreotide or terlipressin for next day, CBC 8th hourly first day, 12th hourly CBC, and then octreotide terlipressin is continued for 3 to 5 days. Most of these patients get discharged on 3rd or 4th day. On discharge, most of these patients will be on carvedilol or propranolol. And then how do we follow up this case? Endoscopy and EUS after 4 weeks. And then what is the success rate is 95%. Rebleed rate is still around 12%. Adverse events are still around 12 to 14%. Thank you very much for your kind attention. This is our team. Thanks. Salutations for all the teachers. Thank you very much.
Thank you, Dr. Ravindra. It was very good demonstration of EUS coiling technique. I am sure there must be many questions, but because of paucity of time, we are taking only one question.
Do the beta blockers work in gastric varices?
Because most of these patients isolated gastric varices.
Question is clear. Do they work in gastric? Yes, no.
If it's an EHPO, no. If it's a esophago-gastric varices, yes. If there is a esophageal varix, fundal varix, yes. Esophageal, sir, most of the time, sir.
GAVE and gastric varices, they don't work.
See, if the patient has got both esophageal, fundal varix, yes. If it is only isolated fundal varix, no use.
Yes. I think we can wind up this session, and you can call the next speaker.
I request the speaker and chairperson of this session to please gather at the selfie point for the photograph. And for the next session, I would like to invite our speaker, Dr. Jagdish R. Singh, sir.
I would like to invite the chairpersons for this session, Dr. Pradeep Nigam sir, gastroenterologist, Riva, Dr. Swapnil Pedarkar sir, gastroenterologist, Ujjain, Dr. Mohit Jain sir, gastroenterologist, Indore, Dr. Adnan Khan sir, interventional radiologist, Bhopal.
Good afternoon, everyone. So, at the outset, I would like to thank the organizers, Dr. Sanjay and his team, for having called me for this experience. So, I would be talking on how to tackle bleeding during sphincterotomy. Well, this is easier said than done for from the gastroenterologist perspective also to manage a post-sphincterotomy bleed. So how do they present in various forms? They can be, they can present just immediately post sphincterotomy. They can present 2 to 3 hours, 6 hours, or even next day also. So, transient bleed, trickle of bleed, which will extend to a large bouts of bleed, differing upon whether it's a venous bleed or an arterial bleed. So how we approach it is more important, because majority of the time it's the gastroenterologist who would like to do it with endoscopic methods to try to control the bleed which happens during sphincterotomy. So I would show some cases. At the same time, I'd like to discuss how we approach it. So this is one of the cases we diagnosed with CCP, and ultrasound showed a dilated PD with intraductal calculi. On the CT, you can see there are multiple calculi with calcification also. So the he was planned for ERCP with ESW and pancreatic stenting. So the thing was, they went to do a bacterial sphincterotomy, and bleeding started within half an hour with the patient being significantly hemodynamically unstable. So all the endoscopic methods tried failed. So they, and the patient being hemodynamically unstable, they directly shifted to IR. So in the IR, with the patient being significantly unstable, what are the types of angio appearances what we see in during a sphincterotomy bleed? So not all the times we will get a pseudoaneurysm or contrast extravasation. Majority, I think 80 to 90% of the times you will just get an hyperemia, just a blush, a hyperemia, and sometimes if the gastroenterologist has used as a hemoclip, it will be seen as a landmark for us. So majority of the times of this 80%, maybe 90% of the time, you end up doing an empirical embolization. So empirical embolization, how we do or what we do is what we are going to show. Although the case what I am showing is having some, all are positive. So you can see here, you can just see a focal indentation. That's the pseudoaneurysm part. That's the pseudoaneurysm which you see along the gastroduodenal artery. So another thing one may ask is, suppose we do not have any contrast extravasation or anything. So what do we do? From an IR perspective, what I would request is, you have a papillary artery, that is to the artery of the ampulla. So that arises from the posterior superior pancreaticoduodenal arcade. So if you can, if anyone can cannulate that posterior superior pancreaticoduodenal arcade and embolize that, so majority of the times your bleed will be controlled, if it is an arterial bleed. Venous bleeds, I think they get controlled by the endoscopists themselves. So in this case, you can see the pseudoaneurysm, and we have successfully done the coil embolization. So you can again ask, what are the agents of choice whenever we see a abnormal angio? So if we have a pseudoaneurysm, as we can see here, So best way is to have a sandwich technique. So sandwich is something we go beyond and we do it something proximal. Why we do this thing is, this GDA is one of the most difficult arteries to embolize, easier said than done. Because in these situations what happens is, you come from celiac, suppose you do a proximal embolization and do an angio, there is no pseudoaneurysm. But once you do a SMA angio, it recruits the blood. So you end up having another pseudoaneurysm, and doing an SMA angio again in an hemodynamically unstable patient, it will be an ordeal. So you will end up losing the patient, or you will end up having a surgery. So as you can as you can see, as we have taken both the shots from the celiac run and also from the SMA, and ensure that part of the artery which we have blocked is not opacifying again. So this is one way where we see a positive response, then we can do this way. So this is another case, a 85-year-old male with CA head of pancreas and history of coronary artery disease and on anticoagulants. This is another conundrum. So having patient being on anticoagulants with a type 1 biliary block, plan was to do ERCP and stenting. Difficult to cannulate, done a sphincterotomy. So bleeding 2 hours with multiple attempts to control the bleed, there is a failure. So repeat side view endoscopy done, showed persistent bleed and referred to IR. So as you can see here, see this is the celiac angio. There is nothing seen on this celiac angio. And next, we have done a super selective cannulation. Again, nothing, not much. So here we ended up doing a empirical embolization. So empirical embolization you should do after cannulating this, what we call this gastroduodenal arcade. So you have to try to cannulate both the branches of the GDA apart from the gastroepiploic. That is the anterior superior pancreatic duodenal arcade and the posterior superior. Only then, if you do not see a blush, then you start doing a empirical embolization. So the agents used for empirical embolization is either you use a PVA particles, glue, or a coils. Coils we end up using majority of the times when you can jail the particular artery properly. If you have a doubt that you are unable to jail completely, because sometimes what we see is the branches are not arising from different parts of the artery. So to jail the complete artery, it may be ideal. Sometimes you may not be able to cannulate those particular branches. So at that time you end up doing a PVA or a glue. So you need not overdo this procedure of significantly putting more PVA or glue. We end up causing significant necrosis of the duodenum, and you end up having an ulcer, and that per se will be difficult to, because it will start bleeding. That per se will be difficult from the endoscopic perspective also. So these are some of the things what we do. So that's another case. What we see is a 45-year-old male with history of choledocholithiasis, presented with fever and jaundice, cholangitis, that's it. Plan was to do an ERCP, ENBD, then ESWL once the patient stabilizes. Again, unable to cannulate CVD, sphincterotomy done, hematemesis after 3 hours post sphincterotomy. So as you can see some contrast extravasation here. Here, you can see the blush. We have luckily cannulated the offending artery and we have jailed it. So this is the coil embolization of the offending artery. So this was another case where this sort of appearance you will get in a sphincterotomy bleed, that is such a big pseudoaneurysm. This is very, very rare. This was referred from outside. So such sort of presentations is very, very difficult to see on a just a sphincterotomy. Pardon, sir? So we, luckily the patient, we could take him quickly and we jailed it with the multiple coils. So that's it. So thank you once again. So if you have any questions with respect to the spectrotomy related, I would be able to.
Thank you,
Have
Dr.
you, just a minute, sir. Have you seen pancreatitis following GDA embolization?
No, sir.
For
No,
sphincterotomy?
no, not
We
at
had
all,
one
not
patient
at
who
all.
had pancreatitis after.
Maybe inadvertently, if they have done a dorsal pancreatic artery embolization, if some part has gone, maybe you can end up having. But per se, I do not think so. Just by blocking the gastroduodenal, we end up having a pancreatitis.
What are the chances of the glue going proximal?
Very much, sir. So we need to be very, because usage of glue by an IR should be in an experienced hands. So you should use 0.5, 0.2, 0.3, something like that, and flush with dextrose very quickly so that you can reuse it. Otherwise, you end up losing the catheter, you have to recannulate it.
So you flush it with dextrose or normal saline?
Dextrose.
Sorry.
Whenever we use glue with lipidol, you should use
So
dextrose.
you want to coagulate, basically. Yeah. And as I told in the morning, one of my patients recently, I have the videos with me, he developed a total necrosis of the entire duodenum after GDA embolization.
That's also if we shouldn't overdo it, because majority of the time you don't get
We have
such
also
cases.
seen pancreatitis occurring like.
You don't get pseudoaneurysms, you just get a hyperemia. So we end up doing this.
One question, like most of the time post-sphincterotomy bleed is not very common. Post-sphincterotomy bleed is not very common to be dealt by IR because most of the endoscopists can deal in the endoscopy suite itself. The cases you were referring were basically both aneurysm cases were there.
Yeah.
So I think that is the
rarest.
Yeah, that is the rare where we require IR, right?
80% of the time you just get an hyperemia. So empirical embolization, how to do that is to be done, not overdo it.
What was the cause of the pseudoaneurysm in one of your patients? It was congenital or formed because of something?
This one, sir, the last one.
It's too far from the papilla.
Yeah, the last one.
Yes, last
they
one.
had done a sphincterotomy, they had a bleed, but that was not due to the sphincterotomy. That was
because of that.
So we'll close the session
too
now.
far from the.
And thanking all the speakers who gave us an insight into different kind of GI bleed we encounter in different procedures. Thank you very much. Thank you all.
I would like to request the speaker, chairpersons and moderators to please gather at the selfie point for a group photograph. With this, we will begin with our next segment, Symposium on Laterogenic Bleed, Post-Endoscopy, On-Table Management. For this segment, I would like to call Dr. C.C. Chaubal sir and Dr. Venkat Iyer sir as the moderators. I would like to invite the chairpersons for this segment, Dr. Arvind Namdeo, Gastroenterologist, Bhopal, Dr. Onkar Patel, Gastroenterologist, Bansal Hospital, Bhopal, Dr. Anupam Pathak, Senior Anesthetist, Gastrocare, Multispeciality Hospital, Bhopal, Dr. Sunil Kasturi, Gastroenterologist, Fortis Hospital, Bangalore. First speaker of this session will be Dr. Zahir Nabi.
So I call upon Dr. Zahir Nabi to present his talk on general principles of prevention and management in iatrogenic bleed post-endoscopy.
Thank you, sir, for the kind introduction. So I'll start. I'll search my presentation first. So I'll be discussing few points regarding the principles of management. Let's hope the slides, yeah. So, in the next few slides, I'll be talking about iatrogenic bleed, what are the risk factors, and some of the devices and accessories, and how to make the optimal use of electrosurgical unit while you are trying to prevent or manage a bleed. So let's start with prevention. Most of us are doing polypectomies now, and pedunculated polyps, they are the favorite polyps for every gastroenterologist. And they can be divided into those with thin stalks and thick stalks, right? So the risk of bleeding is correlated to the width of stalk, especially if the stalk is more than 5 millimeter, and if the head is more than 17 millimeter. So this is a very elegant study which studied the number of blood vessels related to the diameter of the head as well as the diameter of the stalk. So the vascular anatomy of the polyp, if you see the blood vessels near the head and blood vessels near the base of the polyp. So the blood vessels are widest in diameter along those regions, and that is the reason whenever we plan to resect, the plan is always to resect in the middle, not at the base and not at the top. Another reason for not cutting the polyp at the top is to get an R0 resection. But then the very important reason is that the correct position is in the middle also, because the chances of bleeding are less, and even if there is a bleed, you have a reasonable amount of stock to apply endoscopic clips. These are the recommendations, and this is one of the broad stalk polyps, and you can see the number of blood vessels, and you can see that some of these are arteries, like with thick walls, and you can imagine that a post-resection you'll have 3 jets if you have not applied a clip before. So there are recommendations from ESGE as well, that prophylactic clip closure for defect, if you are doing polypectomy, especially for large non-pedunculated polyps, you have to close it, and the main reason is to prevent delayed bleeding. For pedunculated polyp, especially if the head is more than 2 centimeter or the stalk width is more than 1 centimeter, injection, dilute adrenaline injection is also advisable, but remember that this is not practiced everywhere, and this recommendation is based on low quality evidence. So not everybody is doing it, but if you do it, the chances of immediate bleed are less. Now coming to EMR or ESD, that is also very commonly being performed now. And if you see the vascular architecture when you are doing resecting a lesion, especially large non-pedunculated lesion, see the vessels, how the penetrating vessel and how they branch in the submucosal layer. So if you are at the base of submucosa, you find single large trunk of vessels, which are penetrating vessels, which branch as you go upwards towards the superficial submucosa. And that is the reason that when you are doing ESD, you have that control of deciding the plane of dissection, the base of or towards the bottom of submucosal layer, to encounter less can be easily coagulated using. So this is regarding the plane of dissection when you are doing EMR, because the plane of dissection is not decided by the endoscopist himself. The snare grasps, and usually it is the superficial submucosa where you have thin branches of blood vessels. But in ESD, we decide that we should be at the bottom of the submucosal layer, in the lower third of the submucosal layer, where you encounter these blood vessels less frequently. You encounter only the major trunks which are being coagulated using coagulation forceps. Now coming to the principles of management, and before we go towards the principle of management, we have several devices now. The most important, I'll say that whenever you are controlling any bleed, you should have a water jet equipped scope along with a cap. So this is the prerequisite when you are going inside and trying to control any bleed. We have mechanical modalities. Hemospray was also discussed in the morning during panel discussion, so I won't discuss that. Whenever you are deciding a modality for hemostasis, the most important thing which I feel in my view is the thickness of that lumen wall. In stomach, you apply heat, nothing happens. In esophagus, the wall is still reasonably thick, but then when you come to small intestine and right colon, duodenum, cecum, the wall is really thin. And why this is important is when you apply heat there, be sure that the chances of delayed thermal injury are very high. So this is very important. What modality you are using to control that post-procedure bleed, that modality should take into account the thickness of GI tract across different sites. Now coming to, again the same point I want to highlight, when you are deciding which mode, which coagulation current you are using and what should be your mode on your electrosurgical unit, this is also some of the basics that are very important. So the first one, if you see, this is soft coagulation, less than 200 volts. It can do only coagulation, it has no cutting power. The second is more than 200 volts, continuous waveform. It can do only cutting, no coagulation, so we don't want this. The third one is typical of like endocut and all the blended currents, interrupted waveforms. It can do cutting and coagulation both. But see the last one, that is the common currents that we use during POEM, we use during ESD like forced coag, swift coag. So these are strong coagulation modes which have cutting power as well as coagulation power, but look at the zone of coagulation that you get. So these modes we use for small blood vessels that come in our way, but not for particularly coagulating or particularly targeting a blood vessel. The reason being it has cutting power. If you use these currents, then there are chances that if it's a thin wall structure, you'll get a big perforation or delayed thermal injury. So we use the first one, which is soft coag current, which is less than 200 volts. These are different modes that you'll find in RB as well as Olympus, YO300D or YO3. And you'll see that what are the voltages that we come across. But look at the bottom cycle where the voltages are extremely high. So it's very important that these voltages, when you use, you have to use them carefully. A rough idea is that higher is the voltage, higher is the thermal injury, higher is the depth of penetration, and these can be really damaging if you are not very good at controlling these coagulation modes. So just a few examples. So this is an ESD that we are doing, and you can see small blood vessels, small branches that we see. We are coagulating simply with the same mode, that is the swift coag mode. A larger vessel, we have to use a coagulation grasper. For example, this is a case of stir that we are doing, and suddenly we hit a big blood vessel. And when we hit a big blood vessel, that we know that here we have to use a coagulation forceps. Sometimes if it's a big vessel, you have to apply it along the course of vessel at a couple of sites. So these are some principles of controlling bleed using the same electrosurgical knife or using a coagulation forceps. But what about without coag grasper? Now the fashion is to control bleeding. You don't want to change accessories again and again during your procedure. So these are some of the techniques where you don't, if you are using a snare EMR, you can simply use the tip of the snare in soft coagulation mode to control the bleed. Very effective coagulation accessory that you all can decide to use. So this can save one accessory from use and very effective. Another, save your exchange of accessories. It won't disrupt the flow of the procedure by changing accessories again and again for coagulation, because sometimes you encounter too many blood vessels, and then it can save one accessory as well. So same is for swift and forced coag. If you use them at a very low energy, their cutting power is reduced, and they work very well for coagulating blood vessel. For example, the same forced or swift, we are using an effect of only 0.9, which is very low, and at this power it has only coagulation capacity. There were few other slides, but then in the want of time, I'll stop here, and I'll be happy to take any questions. So this is just a video of RDI, that how RDI works, and this is an underwater EMR that we are doing for gastric NET. You see, once we remove it, there is a lot of blood, and we don't have a very good site of bleeding point. And then we put on the RDI mode, and you can see that it concentrates the blood, and you can see the blood vessels quite effectively. Always remember, when you cut a big artery, there are always two ends of it. So once you coagulate one end, you have to coagulate the other end, or search for the other end, because it's going to bleed underneath. And we always inspect the cut specimen to see that which thing bled, which was the artery, and just to gather a knowledge that how can these small entities also harbor big vessels? So that's all from my side. Thank you.
So Zahir, you have this RDI, here I am, this RDI mode, you have TXI also with the same thing?
So TXI is mainly to increase the contrast.
Texture.
TXI mode.
Same, is it there with the same?
Yes, same. So it's a function of the processor, that is Avis X1 processor from Olympus. Now Fuji is also coming up with something like similar.
Zahir, once you're using underwater coagulation, doesn't the energy dissipate in the water?
So the temperature of the water is rapidly decreasing as you increase the distance from your knife, sir. So a few millimeters away from that particular site, the water is, the temperature of the water is very low. So never produces any collateral damage and works precisely.
The energy dissipates.
Yes, sir. Definitely. Now I got your question. So the coagulation is typically slower as compared to coagulation grasper, but then the coagulation is very effective and rebleeding rate is very low. If it cooks slowly and cooks effectively till the deeper portion of the vessel.
Like our grandmothers did it, slow cooking.
Yes, sir, exactly.
Is that really water or is that saline?
Saline. It's basically saline because water is not a good conductor. Saline is a good conductor of electricity. So it's a misnomer that we say it underwater. But we have been evaluating it and it's like 80% of the times it's effective. So we reduce the use of coagulation forceps by say 80%. So in 8 out of 10 cases of ESD or POEM, we don't use coag grasper anymore.
Just one more question. In your experience, you have done so many cases and you have faced so many bleeds also. How many times you have to go for help of the IRs or surgeons, and what was the predictors for that type of severe bleed?
I have heard cases that couple of occasions IR was being involved in post-poem delayed bleeding, because in these cases you close the tunnel and then it's very messy to open the clips and go inside the tunnel. In couple of cases, there were abnormal branches of arising from aorta, and there they were being handled by IR. But I'm not very, I don't have a personal experience that in so many cases, in none of them we required IR for delayed bleeding. Almost all of them can be managed using.
Zahir, once you use IR, what about the hematoma in the tunnel then? Would
So,
you get infected?
Hematoma in the tunnel, actually there's a very good cycle that occurs. So I have almost 10 cases of delayed bleeding where hematoma occurred, but hematoma eventually ruptures through the lower end of esophagus. So that tunnel eventually decompresses. So nature is very forgiving in esophagus, and that is one of the reasons why POEM became so popular, because sins were being committed almost on a daily basis, but still esophagus was.
Where does it drain then, outside?
So it drains into the lumen, sir. The clot comes out at so all my cases, the clot came out of the lumen.
So after that you clip them or leave
Nothing,
it?
because the tunnel seals off in 48 hours. So there is no communication with the mediastinum or peritoneum. So tunnel seals off in 48 hours.
Thanks, Zahir. Zahir, you can join us here. May I invite Dr. S.P. Mishra, sir? Dr. S.P. Mishra from Prayagraj doesn't need any introduction. He basically is a legend in gastroenterology, well-known figure in India, formerly the president and the general secretary of the Indian Society of Gastroenterology, extensive experience in ERCP, and he's going to speak about post-sphincterotomy bleed.
Well, by the time we're getting the things ready, thank you, Sanjay, for calling me here. And it's always a pleasure. Morning you were telling about people not coming. My alumni meeting. So my job has been made easy because of IR people. Zahid did not speak deliberately, I think, about ERCP. And the morning about the DOACs, it's lecture on DOACs. डाउनलोड किया हुआ है, ये है तो ये है ना, ये है हाँ दिख रहा है, दिख रहा। So good evening, everybody. We are a bit late, and at attendances like this, I count the brains and not the heads. So basically, you can see the outline, what I'll be speaking. I'll be try to be brief to save some time. You all know that you are doing ERCPs, and you know that it's a very commonly used procedures. The complications occurring are from mild to being fatal, and prevention and early detection and management of complication is very important. So the complication can be general or procedure related, generally because of anesthesia, hypotension, hypoxemia, and because of the procedure you can have common or rare complications, and that includes pancreatitis, bleeding, infections, perforations, pneumothorax, hepatic hematoma, air embolism, splenic injury, and basket impaction. And there are miscellaneous complications which occur, once in a blue moon, and you have to you have to think outside the box to manage them. So the incidence is pancreatitis is the most common, about 5.4%. Bleeding is 2%. Infections are 1%, and perforation less than 1%. Again, fortunately, in India, we have lesser number of complications, including pancreatitis and bleeding, and I'll show you some data. Maybe we are not reporting them as per protocol, or probably we are blessed. So post-ERCP bleeding, from outside it's 1.4%. A study in 2022 found a 0.35% incidence. So it was 1/3 of what is reported outside. So the classification depends on the timing of the presentation. It can be immediate or delayed. And also the clinical presentation, it can be significant or occult bleeding. So this is one of the, I just want youngsters to see this. So this is, you can see over here, the moment we do a sphincterotomy, it starts bleeding. But then you see, I continue to incise it. See here. So the incision is increased because I have to get out the stone, and the bleeding stops. Why is that? For the youngsters over here, so once you cut the artery's bleed stops because of the spasm of the artery. It seals by itself. If you have cut it half, then it's not going to retract. So just to retract, you cut it full. So I told you about it can be an immediate bleed, occurs during the procedure or immediately afterwards. More common, it's much more common than the delayed bleeds. Delayed bleed can occur hours to 7 to 10 days later. And most of the bleeds shown by Dr. Jagdish were in the delayed bleed. The severity of bleed can be mild. It's clinical, not just endoscopic evidence of bleeding, where the hemoglobin drops by 3 grams per deciliter. Moderate is when you need 4 units of PRBC, but no angiographic intervention. Dr. Jagdish has not to be called then. And if you have transfusion of more than 5 units PRBC or intervention, surgery or angiographic, then it's a severe bleed. The clinical manifestation, you all know, hematemesis, melena, hematochezia, hypotension, dizziness, and tachycardia. The risk factors are definite risk factors like coagulopathy, anticoagulation intake less than 3 days before ERCP, pre-existing cholangitis, bleeding during initial endoscopic sphincterotomy, and a lower volume of ERCPs done in a center. Maybe in cirrhotics, dilated common bile duct, you have periampullary diverticuli, or a pre-cut sphincterotomy. Not associated, definitely not associated, or aspirin, NSAIDs, longer length of sphincterotomy, or you do extension of a sphincterotomy done earlier. So these are not related. The risk factors, this was from a single center over here. Bleeding occurred in 0.35%, number were 60 patients. Among these, endoscopic sphincterotomy was 66%, pre-cut fistulotomy in 15%, balloon sphincteroplasty 8.3%, and balloon trawling in 8.3%. Fortunately, I've never found it to be in balloon trawling, but I did encounter a balloon sphincteroplasty, a massive bleed. Risk factors were found in 63%. It was mild in 53%, moderate in 26%, and severe in 20%. There was mortality, 8 patients died because of this. How do you prevent it? So you can use a papillary large balloon dilation. So you make a small cut and use a balloon to dilate it, and it is found the bleeding is less than that of endoscopic sphincterotomy. However, when I started doing large balloon dilatation, we were one of the first to do it. my even dictum now is you do a full sphincterotomy and then you use a balloon, because you're remodeling the lower end of the CBD. You're not stretching the fibers. Don't cut the fiber. So even now I do a full balloon, full sphincterotomy and then remodel the lower end of the CBD by using a large balloon. You can also use a mixed current, and it's been found in a meta-analysis of 804 patients that mixed pure current has a high bleeding, but you trade off with pancreatitis. Pure current has a lower incidence of pancreatitis, mixed current has a higher incidence of pancreatitis, although the difference was not significant. What about the location of incision and prevention of bleed? In this cadaveric study, they have found that the most dense arteries are there from 3 to 9 o'clock. 10 to 11 o'clock, there are less number of arteries over there, 10% only. Therefore, if you do a sphincterotomy at 10 to 11 o'clock rather than 11 to 1 o'clock, the chances of bleed by this anatomical study will be less. So this is a Japanese study where they found that prophylactic endoscopic injection of hypertonic saline on the apex of the papilla prevented post-sphincterotomy bleeding. This has to be proven in other studies. What about management of anticoagulation over here? This has already been taken up, but I'll just explain it. If you have high-risk procedures like polypectomy, ERCP with sphincterotomy, ampulectomy, EMR, ESD, dilation of strictures, therapy for viral PEG, EUS and FNA, esophageal and entry colony stenting. If the patient is on DOACs, then the last dose of the drug to be taken about 48 hours or more. For dabigatran, if the creatinine clearance is less because the patient has renal problems, then you have to make it 72 hours. For warfarin, if low-risk conditions are there, like prosthetic metal heart valves in aortic position, this morning we had a discussion about that, but this was not clarified. Xenograft heart valves, atrial fibrillation without valvular disease, after a venous thrombosis, embolism, thrombophilia syndrome, these are low-risk conditions. Then you stop warfarin 5 days before endoscopy, check the INR prior to the procedure, restart warfarin on the evening of the procedure, and check the INR 1 week later to have an optimal result. If there's a high-risk condition, like prosthetic metal heart valves in the mitral position, prosthetic heart valves and atrial fibrillation, and mitral stenosis, or less than 3 months after embolism, then stop warfarin 5 days before endoscopy, start low molecular weight heparin 2 days after stopping warfarin, give the last dose about 24 hours before the procedure, and restart the anticoagulation immediately after the procedure and titrate it. Sorry. So what about aspirin and non-steroid? I already told you that this was a study and they found that aspirin and NSAIDs do not increase the risk of post-sphincterotomy hemorrhage, and they can be safely be used before the procedure. And this was a consensus from all of us in the morning. What about if the bleed occurs? Most immediate bleeds stop spontaneously. So when I started doing ERCPs and we had a bleed, I missed a few beats of, but nowadays it doesn't bother me at all. Endoscopic therapy has to be undertaken for treatment when the bleed is significant. Minor bleedings, you don't have to worry, they stop on their own. So the first line of therapy is injection therapy. You inject dilute epinephrine, especially at the apex, and most of the bleeds will stop. So about the bleeding will stop in 96% of the patients. Only 4% will have a rebleed. Then you have thermal, like Zahir said, you can have cooperative coagulation for post-ARCP bleeding and can be performed using bipolar or heater probe device or even a coagulosper now. After injection therapy has failed, this should be tried before considering angiographic and surgical intervention. And Dr. Jagdish, I'm sure you said that all of them failed, so probably they have tried all this. What about mechanical therapy? Hemostatic clip placement can be done. Balloon tamponade can be done. And sometimes you can use a fully covered expandable metal stent in these patients and remove it after the bleed has stopped. These are some of the examples over here. So the algorithm over here, basically, if you have immediate post-ERCP bleeding, if there's limited visibility, then you consider endoscopic and its bleeding is significant, then you can consider monotherapy by epinephrine injection, because if you inject here and there, there's no problem. If the bleeding is controlled, you continue the procedure, whatever you're doing, stone removal or stenting, whatever it is. If the bleeding is not controlled, then you have additional combined modality, like I told you about thermal or clips. The bleeding stops, continue with the procedure. If it doesn't stop, then you can use angiographic embolization. If it is still bleeding after angio, then the surgeon has to be called in. And in one of the patients in the morning, surgeons were called late, and therefore the patient died of sepsis. So surgeon should be involved in the algorithm always. Similar management for delayed post-ERCP bleeding too. So the take-home message is, the bleeding is a common complication of endoscopic sphincterotomy. Bleeding may be immediate or delayed. Both patient risk factors and technical risk factors contribute to the bleeding. And most of the post-ERCP bleeding is primarily supportive and endoscopic. Occasionally, you may need angiographic control as well as surgeons has to be called in. Thank you very much, and I'll be glad to answer any questions. So Sanjay, I saved 2 minutes.
I think in the algorithm, you did not show the balloon usage of the biliary balloon for the control of the bleed.
Tamponade. I've told about 20 minutes. In the algorithm, it's not there, as mentioned by the AGA guidelines.
Yeah.
But that's what I told you.
In fact, that's the most commonly used.
I'll make everything clear.
Fully covered,
Over experience of 30 years, 35, 40 years, you have to think outside the box. You may encounter so many things that you have to devise things over there immediately. And I've devised many things, and that's why I've got so many publications. So algorithms are there to help you, but not for an individual case. Correct. So sometimes you use a tamponade, sometimes you use a SEMS. Coag grasper is coming right now, so the coag grasper is also not there in the algorithm.
Yeah,
so
that's surprising.
Well taken.
That's one. And second thing is, many times we may not have that SEMS in case we have a bleed. It's one of the rescue way of controlling the bleed. I think we can use the balloon sphincteroplasty. The same balloon can.
So the balloon tamponade, I told you, you can use that.
You can use both biliary balloon, stone extraction balloon, as well as even balloon sphincteroplasty balloon.
So the sphincteroplasty balloon is thicker.
Yeah.
Large balloons are thicker. The extraction balloons are very flimsy. So you will not get that much pressure in the balloon extraction balloon. They are very flimsy. So always use a large size balloon so they can inflate and keep it over there.
Correct.
I think many years back, Costamania's article was there on this, where he said probably that post-sphincterotomy bleed should not be considered as a complication. It can happen in the best hand with best technique also. And many times he has said, even if you have a bleed, take a deep breath, don't get excited, put a balloon, inflate it, come out, have a cup of coffee, go back again, deflate it, many times it will be controlled.
If that were true, then Dr. Jagdish's lecture would not have been here.
Many times it happens.
Yes, most of the bleed, majority of the bleeds stop spontaneously. Just increase the sphincterotomy. The vessels will contract. That is the best tip I can give you right now. Don't worry, just increase the sphincterotomy. If the artery contracts and the bleed may stop. Majority of the bleed will stop. But sometimes, if it doesn't stop, you have to use this measure.
The first step is that only, because if you transect the vessel, both will contract, both ends close then. That is how the bleeding stops.
So when I was doing a study on large balloon dilation somewhere in the early 90s, one of the patients bled, and he was known to me. So I panicked. I had to call my surgeon, and the stone was out, everything was done, but then he just underrun it, and he did a simultaneous cholecystectomy, so it was a definitive surgery for him.
Just one question. Where do you keep the plastic stent placement while handling the bleeding? Because sometimes you are handling the bleeding, your all measures have failed, and you have to subject this patient for some intervention. Before sending that patient for intervention, would you consider putting a plastic stent?
So if the bleed has stopped,
it has not stopped.
So the bleeding is there, then you can put a plastic stent. It makes the life of the surgeon easy to palpate the CBD. So that can be done. But use a large SEMS now. Earlier we didn't have the large SEMS. So that will stop the bleeding.
Fully covered stents are used now.
Yes.
Yes. That the lumen of the plastic stent is very small.
No, his question is very genuine. If you put it there, the surgeon can palpate the...
Yeah, before sending. So if a post-sphincterotomy bleed is not stopping, you do not have a SEMS, just take a breath. It will take another 30 seconds. Put a plastic stent, 7 centimeter, 10 French stent, and then send the patient for surgery.
Absolutely, Ajay.
Sir, is there any way of predicting this papilla that which can bleed, or the length of the sphincterotomy or pre-cut?
The length of the sphincterotomy has no correlation with the bleeding.
Or pre-cut up or down?
Pre-cut, again, I didn't find the bleeding to be in more. So the
So it is
definitely
just
coagulation. So wahi jo Ram rachi rakha.
So even after 30, 40 years of experience,
nothing, you can't
papilla
predict it.
It's just accidental.
You can't predict it.
I think we have a short question, only one question.
Sir, while controlling the bleed, sir, you have told us two armamentarium. One is a thermal and second is a hemoclip, sir. Putting a hemoclip with the side view scope, it is very difficult, sir. Do we have some special techniques so that we can
No,
use it?
it's not difficult. If you are used to it, it's not difficult. Just open the elevator, put it there, and then use the elevator. It may be a bit difficult, but you can use it. No problem there. And we have used it. And we have the second year resident also does it. And it's good. Thermal, again, is used, but not very good. Zahir will bail me out that clips are better than that.
Commercially available clips, they are different in their ability to rotate as well as their proper application in strained position. So I won't name the but you'll find their respective utility, that which clips they obtain. But as sir told, that little expertise is required before you can. Use of elevator makes things a little more tricky. So try to minimize initially the use of elevator.
Have a full open, then go there, and then you can use it. Second thing is we also have a bipolar thermal, which can be angulated. So that helps you a lot now.
I think we stop this session, I think.
Sir?
Sometimes, yes.
Maybe counterproductive.
Maybe sometimes, yes, it does.
Maybe
happen.
counterproductive. Yes.
Ajay, only when you are doing a pancreatic sphincterotomy, this problem. Once you are done towards the CBD, the chances of putting on the pancreatic is less. But what we said is, if you are not getting a good position, that can happen.
Sir,
but most of the time it doesn't happen.
Once you have
you
reached
have to put it at the apex of the sphincterotomy.
Stage of clip means you are desperate now.
Yes.
Once you have reached the stage of clip, it means
And
the bleeding is
even
more than usual.
even injection readily has to be given at the tip of the sphincter.
And if you are calling your IR, you are more desperate.
I think Dr. Mishra, we...
Just one thing, even when some experts are telling that when we are washing, so at that time some epinephrine can be added in the wash. I mean, I don't know how much. There's no evidence.
I don't find to be very useful. Earlier we were doing cold saline lavage and all those things are gone. Now you've got armamentarium improved.
Yes.
Thank you.
Sure. Thank you.
I think we close the... Thank you, Dr. Mishra. Next, I call upon Dr. Ashmit Chaudhary to speak on post-polypectomy bleed. Dr. Ashmit Chaudhary, consultant gastroenterologist at Apollo Hospital, Indore. He's a very dynamic endoscopist and a good work in liver disease also. Politics.
क्या हो गया, नाराज हो गए? अच्छा आ गया नहीं, but that is the introduction. आगे Ashmit, it is there. Please be brief, Ashmit. Some part he has already discussed. Zahir has already shown a nice polyp where to cut.
I'll
skip many of my slides then, because many of the things have today been. First of all, thank Dr. Sanjay Kumar for inviting me for this lecture. The important thing, many of the parts have already been covered, so maybe I'll skip some of the things. The most important thing is why you want to cut a polyp. The natural history in a study in 2022 shows that there are 24% chance of invasive adenocarcinoma at the site of original polyp. And there are 35% likelihood of carcinoma emergence at colonic locations, at any other colonic locations. Recent studies show that colorectal cancer screening and removal of percutaneous or precancerous colonic adenomas can reduce cancer incidence and related deaths by about 50%. So it is important to remove the polyps. What are the techniques? There are two techniques. Everyone is familiar with hot snare, which we usually do, and cold snare. This is by the ESG, it says that it should be done in less than 10 mm polyp, because the chances of bleeding and perforation are less. So this is just a way. In the upper slide shows the hot snare technique, in which you have to encircle always a small amount of normal mucosa also. I'll just come to the main thing. This is what we call is fried egg concept, in which there is the polyp is placed in the middle at 6 o'clock position, and we apply, we push down the snare and take a normal margin of the tissue is also captured. Then suction is applied. The suction is applied so that the more of polyp and mucosa gets stuck into it, and then at the end, the endoscopist asks this assistant to transect the tissue. So this is the hot technique, hot snare, and mostly it is used for polyps, cold snare technique, and this is used mostly for up to polyps up to 10 mm in size, and now they are using it for cold snare EMR also done. So what not to do? This slide shows that we should not apply the polyp at the base, snare at the base of the polyp. They should always be in the center. It should not be at the base, otherwise we'll have bleeding. And immediate bleeding in cold snare polypectomy often concerns endoscopists starting out with cold snare polypectomy. It is rarely significant. As Zahir had already showed, that the major vessels are in the mucosa, are lower in the submucosa. So it will be superficial capillaries that will bleed, and usually they stop on itself. Complications, polypectomy. This was the English National Registry comprising of 1,67,208 polypectomies in hot snare polyp under 10 mm size. So you can see as the size of the polyp increases and the sessile polyp morphology are risk factors for perforations. Post-polypectomies bleed. The incidence of post-polypectomy or post-EMR bleeding ranges between 1 to 7%, mostly manifesting between several days and 2 weeks after the procedure. Post-polypectomy bleed can be divided into two parts: immediate bleeding, which lasts up to 2 days, and delayed bleeding, which can occur up to 30 days. It manifests approximately 4 to 7% of patients after colorectal EMR, according to some studies. So immediate post-polypectomy bleed is bleeding occurring during endoscopic procedure that persists for more than 60 seconds and requires endoscopic intervention. Post-polypectomy bleed is bleeding occur after endoscopic procedure up to 30 days. And it is said that there is an unplanned medical presentation such as emergency department visit, hospitalization, or re-intervention is required. So most patients, most cases of bleeding are treated endoscopically, and pre-procedure and peri-procedure planning can effectively prevent. We have already seen from morning how things can be planned out. Recent advances using CO2 insufflation, submucosal layer injection with chromo-injectables, employing systemic inject and snare technique, and remove a margin of 2 to 3 mm of normal mucosa significantly enhance the safety of polypectomy, preventing major bleeds. Avoiding, the main purpose of cold snare has come out to be that this avoids the thermal injury to the deeper submucosal layers, will leave the deeper and larger submucosal layers vessels intact. Recent studies have demonstrated that cold snare polypectomy lower rate of post-polypectomy bleed than hot snare. In fact, recent meta-analysis, there were no post-polypectomy bleed events with cold snare arm of any of the included studies. Other studies of larger lesions removed using piecemeal cold snare also demonstrated no post-polypectomy bleed events. So what are the risk factors? There are two guidelines that I have shown, and according to this, the polyp size, American guidelines say more than 10 millimeters, the ESG says more than 20 millimeters. The polyp type, pedunculated lesions, thick stalk and lateral spreading tumors. Sessile polyp, EMR, and non-pedunculated large colorectal polyps. Both the guidelines say it is the right side of the colon which is more prone to bleeding. Removal technique not specifically mentioned, but ESG says electrosurgical currents not controlled by microprocessor. So you have to have the processor units. Use of anticoagulants. The American guidelines do not specify anything, but aspirin use, clopidogrel use, and anticoagulant use as per ESG. It is in the form of cardiovascular diseases, CRF, have been said by the Americans, but quickly mention any patient risk factors. What happens if there is intraprocedural bleed? They have classified intraprocedural bleed into 4 parts. Grade 1 is spontaneous hemostasis within 60 seconds. Grade 2 is defined as continuous but decreased oozing over 60 seconds. And grade 3 was defined as continuous oozing after 60 seconds that needed endoscopic treatment. Grade 4 was defined as active spurting that needed endoscopic treatment. In case of immediate post-polypectomy bleed, additional clips can be used and also loop can be used. In immediate post-procedural bleed, adrenaline injection may be used to gain initial control over the active bleed, but should always be used in combination with second mechanical or thermal hemostatic agents. Further management with soft snare tip, soft coagulation, coagulation forceps, and endoscopic clips have been used. The management prophylactic closure of resection defect. Prophylactic closure, the American guidelines say that there should be prophylactic closure of defects with margins more than 20 millimeter. The ESG says routine prophylactic clipping after polypectomy of lesions less than 20 millimeter and polyp greater than 20 millimeter in the left colon were not recommended. Prophylactic clip closure of mucosal defects after polypectomy in right colon they have recommended. So as you can see, the ESG guidelines do not mention clipping for patients being administered antiplatelets or anticoagulant, but American guidelines recommend it conditionally. Therefore, the guidelines for managing colonic polyps vary between the organizations, reflecting the differences in approach to balancing the risk and benefit. So, what are the treatment clipping strategies? Currently, several preloaded clip systems are commonly used. The resolution by Boston Scientific, I think Zair was referring to this clip only. Quick clip by Cook Medical, Instinct clip by Cook Medical. All existing clips are developed and preloaded and are rotatable after introduction of the 360 resolution by Boston Scientific. The over-the-scope clip, OSCO clip as it is called, is used mostly in cases of perforation. Treatment strategies, these are the clips, the EZ clip, the quick clip, the OSCO, the resolution. I'll go through the clipping techniques. 2 strategies for achieving hemostasis. The first technique is just to clip the bleeding vessel, but then it can cause further problems. So they call it the zipper technique. The zipper is a modified version of zipper closure technique. A spacing of several centimeters in between, and the clips are applied at both the ends and also in the middle of the. So as you can see, this is the zipper technique. The clips initially are applied at the margins and then in the between. So is this cost effective? For proximal lesions, there was cost saving of about $434. Large lesions, $287. And lesions with antithrombotics, about $69. Just wanted to show one study. This is a recent observational study conducted in 6 Spanish tertiary care centers, evaluated therapeutic intervention and active bleeding during colonoscopy for patients with post-polypectomy bleed. The authors reported 71.9% of patients underwent repeat colonoscopy, 2.6 underwent angiographic embolization, and 25% were managed without intervention. The authors concluded that colonoscopy may be overused in post-polypectomy bleed because active bleeding was found only in 1/5, that is 20% of colonoscopy, and nearly half of the patients of post-polypectomy bleed did not require any homeostasis. Patients treated without intervention had excellent outcome in terms of rebleeding and transfusion. There are some new techniques like hemospray. We have already seen. It is a non-reactive powder made of mineral. It is also most often used. Studies support the use. The only problem is it causes a layering and lower vessels cannot be seen. Adverse events are rare, with rebleeding rates of 11% at 7-day and 14% at 30-day. One case of endoscope adhesion to the mucosa for 48 hours was also reported during this hemospray. Another innovative thing Dr. Chobal was pointing out in the morning was Purastate. This is a biocompatible synthetic polypeptide gel from 3D Matrix Europe. Is another hemostatic agent, is used for endoscopic therapy. The only thing is it is a crystal clear thing and the vessels can be tackled properly. Its transparency ensures visibility of bleeding area and clear endoscopic view. Its formulation avoids catheter clogging, which is a common problem with powder formulations. Purastat is additional hemostatic method achieved successful hemostasis in 91% of cases, with rebleeding rate of 10% in patients that underwent EMR. It was also used to stop intraprocedural bleeding during EMR. Currently, no recommendations can be made of the use. In summary, bleeding after polypectomy is uncommon and rarely fatal. Cold snare of small polyp is safe, and also on patients on antithrombotic. Large polyps, resection in the right colon in an elderly increase the risk of bleeding. Clips prevent bleeding and are cost effective after large right colon resection. About half of patients with delayed bleeding after resection do not need emergency colonoscopy. And I thank you for your patient hearing.
I think we don't have time. Any questions required can be taken out at the time of dinner. Thank you. Thank you, Rashmit.
I request the speakers, moderators, and the chairpersons of the symposium session to please gather at the selfie point. Before we continue with the sessions, let's take a few minutes to stretch, breathe, and simply be present. It's time for Vaso Relax session number 2. Now, with a huge round of applause, please welcome Dr. Ravindra Kale once again on the stage.
So, lot of bleeding can cause lot of stress, and if we are in stress, we cannot manage anything properly. So it's time to relax. Just close your eyes. May I request to dim the lights, please, if possible. Your neck and spine erect, eyes closed, no talking. Take your attention to your breathing. When you are breathing in, your stomach is expanding. When you are breathing, stomach is coming inside. Take attention to your surrounding. पंखे की आवाज, लोगों के बोलने की आवाज़ स्वीकार करें। जो भी आवाज़ें आ रही हैं उनको स्वीकार करें। Now take attention to your body. Keep your eyes closed. Take attention to your both of your feet. Both knees, thighs, hips, back, entire back, lower abdomen, upper abdomen, chest, both the hands, elbows, arms, shoulders, neck, ear, chin, lips, nose, forehead, top of the head, whole body. The whole body is relaxing. Take attention to your thoughts, good thoughts or bad thoughts. Accept them. जैसे भी विचार आ रहे हैं स्वीकार करें। Take attention to your emotions. आप ही आनंद हैं, you are the bliss. Shanti, Shanti, Shanti. Take a long deep breath in. Become aware about your surroundings. Become aware about your body. And whenever you feel right, you can open your eyes. Thank you.
Thank you.
Thank you, sir.
It was truly relaxing. कुछ लोगों को नींद भी आ गई.
Now discussion on the topic lower GI bleed. I would like to request Dr. Ravi Rathi sir to please join us on stage as the moderator.
I would like to invite the expert discussant for this panel discussion, Dr. S.K. Nigam sir, General Surgeon, Relief Autorectal and Piles Day Care Center, Bhopal, Shirish Upasni sir, Senior Surgeon and Endoscopist, Bhopal, Dr. Rajiv Sharda sir, Laparoscopic Surgeon, Sharda Hospital and Diagnostic Center, Bhopal, Dr. Lavkush Tiwari sir, Gastroenterologist, Gastro World Hospital, Riva.
Now I request the panelists to please join us on stage. Dr. Venkat Iyer sir, Dr. M.T. Noor sir, Dr. Naveen TMU sir, Dr. Pankaj Kumar Goyal sir, Dr. Vishnu Jain sir.
Good afternoon, all panelists and chairperson. Today, we are going to discuss about lower GI bleed. It's a common condition in our gastro practice, at time OPD practice, IPD, and even ICU patients. So we'll just try to cover the topics. Many of the things are already been covered. We'll cut short those things, but we'll discuss certain things which still needs to be discussed. So this is a typical case scenario, a 66-year-old male, diabetic hypertensive. He's post CABG 6 months ago, obviously on antiplatelets, and he presented with acute onset lower GI bleed. And there was no past history of abdomen pain, constipation, fever, or NSAID ingestion, and there is no history of similar episode earlier. On physical examination, there was tachycardia, the blood pressure was borderline, 106/70. He had pallor, there was no guarding rigidity or tenderness. And on parectal examination, it was fresh blood, otherwise unremarkable, and proctoscopy showed no hemorrhoids. Investigation revealed low hemoglobin, 6.5. Creatinine was on a higher side, 2.1. LFT and PTINR was normal. So what next? Dr. Naveen, would you like to tell us that how you are going to approach this patient regarding ICU care?
As this patient, we can see there is a tachycardia, there is a slight hypotension with a HB of 6.5. I think there is a, I guess there should be a massive GI bleed in this patient. So he has to be managed in the ICU with crystalloids, and also as he is a patient of a CABG, like his HB to be reached at least 9, so the blood transfusion should be given. And his creat is also high, so I feel he is much dehydrated. So depending on the ICU care, the intensivist should check for the IVC, and depending on the IVC, like they should transfuse the fluids, and ABG should be done to see the level of acidosis.
So what is your target hemoglobin in this patient? And
as he is a CABG patient, I think 9 to 10 should be okay.
Okay. So most of the guidelines say that more than 7 hemoglobin is okay, but
he's a CABG patient.
But
he's a 9.
good. And anything about platelets? If suppose this patient having platelets of 1 lakh, in that situation, what you will do? You will transfuse or not? Regarding platelet transfusion?
I don't recommend. I don't
Yes.
think
So obviously platelet transfusion should not be required unless it is less than 30,000 in these patients. And Dr. Noor, how will you further go about this after initial resuscitation? What will be your approach?
So as discussed, after initial resuscitation, next thing is to decide about the investigation. So foremost, the definitive test for the lower GI bleed is a good colonoscopy to look for the culprit lesion. But usually it should be non-emergent. Most of the time it should be after 24, because in the initial 24 hours, usually because of the presence of blood and colon not being well prepared, we are not able to find the definitive lesion. So it should not be very urgent. However, if the bleeding is rapid, then in that situation, a good CT angio can be performed. And if there is contrast extravasation, then interventional radiologist can be called to block the vessel. However, in those patients who are having minor bleed, in that situation, doing a CT angio will not be very useful. It is useful only if it is active bleed. And in that situation, either IR person can be called to embolize for embolization, or in the setting where good endoscopic setup is available with our armamentarium, in that situation a colonoscopy can follow.
So this patient is having hematochezia. Would you like to rule out upper GI source? Would you like to do an upper GI endoscopy in this kind of patient, or wait?
It can be in those where the blood flow, the blood loss is rapid. In that situation, even an upper GI lesion can present as hematochezia.
And regarding sigmoidoscopy in the such settings, would you recommend sigmoidoscopy, or you believe in a full preparation colonoscopy?
So usually it is not recommended to do emergent lower GI endoscopy. It should be after 24 hours when the things have been stabilized.
So in real world, when you start preparation, I mean, you start preparation immediately in this patient, or you wait for resuscitation?
Stability has been achieved. Only then you start the preparation, and usually with the peg leg preparation. However, in those who are having volume overload, a low dose preparation can be given so that they can maintain their volume status.
So according to you, it should be good colon preparation. Then we should do a planned colonoscopy. If patient bleed massively in between, we can go for a CT angio.
CT angio, yeah.
So what is lower GI bleed? Historically, lower GI bleed has referred to the bleeding source originating distal to the ligament of Treves, which includes small bowel also. So small bowel bleeding is also, but in general, small bowel bleeding is considered a separate entity with a distinct diagnostic and therapeutic algorithm. In clinical practice, we say lower GI bleed refers actually to hematochezia or bright red blood per rectum originating from the colorectal source. So, Dr. Iyer, this is regarding spectrum of this acute GI bleed. What are the common causes of lower GI bleed, which you can?
So the most common causes for lower GI bleed is, one is diverticulosis, second is hemorrhoids. Hemorrhoids actually in this patient a PR proctoscopy was done and hemorrhoids were not there, but hemorrhoids is an important cause. Other is angiodysplasia, which is present in the colon. If the in our region where I stay, IBD is quite common, so IBD is also one of the cause. And if the patient has undergone a polypectomy, of course then the first thing to suspect is a post polypectomy bleed. Considering the age of this patient, neoplasm also should be kept in mind. Infection is very less likely. There are less common causes like infection, ulceration, Meckel's, aortoenteric graft fistula. Of course, there will be a history along with that. So that to be as a rarer causes, but most common causes are, and as Dr. Noor said, I agree that it is always first better to give a resuscitation, prepare the patient, and then do a colonoscopy, because most of the lower GI, 80% of the lower GI bleeds will settle by themselves.
They did right hemicolectomy. Non-specific ulceration was the most common cause of lower GI bleed.
Indian study, yes, sir. So the key important points in history and clinical examination in patients with acute GI bleed. How should we interrogate them?
In relation to the history, again, the age of the patient, the nature of the bleeding. When it comes to nature of the bleeding, we have to take whether it is in bouts or in a single, or most of the patient give a history like they went to a washroom, there only they collapsed. That itself indicates that it was a massive GI bleed. So, and history suggestive of associated symptoms like giddiness, perspiration, palpitation, and history of medications, especially in our case, use of antiplatelets, and history of NSAID also should be important. And previous medical history, especially in these kind of the patient, a history of a chronic constipation is very important because they can have a diverticular related bleed also, and of course the medications.
Yes. So in associated symptoms, one can ask for painless or painful bleed also. The painful bleed might be in ischemic colitis. The other causes diverticular and In physical examination, what are the points you would like to
Physical examination, though there are n number of the risk score things, even the ACG recommends it is the importance is the clinical judgment rather than the depending on the all these scores. So in the physical examination, the assessment of the baseline heart rate, BP, saturation, and abdominal examination, whether there is any associated tenderness, especially over the left side, lower down, that indicates the diverticulitis with the diverticular bleed. Having a presence of the fresh blood or no. And general examination, of course, the presence of the pallor, the patient being like a dull, drowsy, they all indicate the amount of the bleeding to be significant.
Now, again, I'll discuss with Dr. Noor regarding approach to a patient with acute lower GI bleed in terms of the need of the blood transfusion, in terms of target hemoglobin, in terms of using vitamin K, tranexamic acid, FFP, and other procoagulant medicines. What are the indications?
So as far as the need of blood transfusion is concerned, in hemodynamically stable patient, it is recommended to transfuse only if hemoglobin is less than 7. Otherwise, in a hemodynamic stable patient, they can be managed with IV fluids, antibiotics, whatever, depending upon the clinical situation. As far as the role of vitamin K, in those who were on oral anticoagulant, there is role of vitamin K for reversing, but it takes time. So during that time, you have to cover up with FFP transfusion, and in those who are having who are on anticoagulant, better than FFP will be prothrombin complex concentrate transfusion. However, the availability is limited. As far as tranexamic acid is concerned, there is no role of tranexamic acid administration in this patient. So in those who are for reversing, and for those who are on DOAC or NOAC, directly acting agent, there are specific agents available to reverse their procoagulant effect. However, in most of them who are on, in those who in whom the bleeding has stopped after stopping the oral anticoagulant, there is no need for a specific agent. The need of a specific agent arises only in that situation in which the bleeding is continuing even after stopping those agents. So in most of them, after stopping those agents, the bleeding or if there is continuing coagulopathy, then FFP administration can be done.
So very important point has been raised here by Dr. Noor, that we shouldn't use tranexamic acid in the patients with the lower GI bleed. In fact, there has been a large studies on this, and it's been found it is associated more side effects than the actual good effects. So it can lead to seizures as well as venous thrombosis. So and it has no role in prevention of the further lower GI bleed. So this is one of the way how we go about lower GI bleed. If it is an occult bleed, it's a different story. This patient may have all these reasons: colorectal cancers, angiodysplasias, or occult upper GI, or a small bowel bleed, or asymptomatic IBD. If there is an overt bleed, and if the patient is, those are patients who are stable, we should we can manage them on outpatients. These are the patients who have hemorrhoids, fissures, or stable IBD or colorectal cancers. But the patient who is having brisk bleeding, then we should interrogate further if they have painful or painless bleeding. The painful bleeding may be with the acute colitis, which may be ischemic, infectious, or inflammatory, or painless bleeding may be because of the diverticular disease or angiodysplasia. And small bowel bleed, Meckel's diverticulum, we should suspect, especially when a young patient comes with a rapid hematochezia. We should always suspect Meckel's diverticulum in these patients. So now, Dr. Pankaj, how should we investigate in a patient with lower GI bleed? What are the different available tests, and how to sequence these tests?
Basically, the investigation of choice for us is CT angiography. But most of the times what we have found that when we do a CT angiography, like we don't find any positive source of bleeding, or we don't find anything positive to do further. So the best time to do a CT angiography is to do when the patient is actively bleeding. So what we do is we admit the patient and we wait and watch, and when we feel that the patient might be bleeding or the patient's vitals are not improving or vitals are deteriorate suddenly, then we take up the patient immediately for CT angiography. And that is the time when most of the time we find something. Either we find a dilated vessel, tortuous vessel, we might even see a blood in the bowel, we can even find active bleeding in that cases. And if we find any bleeders or something like that, or any AVMs or any thickening which we suspect that this might be bleeding, we can go and embolize further. We do directly vessel angiography.
Yes, yes. So I'm just discussing, yeah, you can take the mic. So I just want this
in
thing.
this patient, where the data which was shown, the creatinine is 2.1. So like CT angio, you need a large amount of contrast to be given.
So the important question here, suppose like this patient or any other patient who is having a raised creatinine but is having brisk bleeding, still would you do a CT angio to localize the disease, or you will wait for what you will do?
Yeah, so brisk bleeding, of course, first in upper GI. Once that is ruled out.
Upper GI is normal, suppose.
Yeah, upper GI is normal, then we have to explain the risk and then go for a
use a
so
low,
I think we should
use a low iodine contrast.
Yeah, non-ionic contrast can be used, but of course this has to be presented to the patient and to the relatives.
My personal view on this is we should always know the source. That is most important actually.
As these cases are more like I would say dehydration related, so once like the resuscitation and other things will take care, even that will settle. Rarely they may go for a further worsening.
Because mainly raised creatinine should not deter us from doing a CT angio in a sick patient. You can always do a dialysis later. Explain the thing to family, but
contrast-induced nephropathies are self-limited disease. We hardly requires 1 or 2 dialysis.
One more thing is that now we have isoosmolar contrast. We don't use low osmolar contrast. Low osmolar contrast has osmolarity of 600 plus. We have isoosmolar contrast where the osmolarity is exactly same as blood. It's around 300. So these contrasts are said to be renal protective. Like they will not have any we have a special called Visipack.
So yes, 2.1 is not a problem. More than 2.5 is a bit of a problem.
So we are not using we are using isoosmolar, not low osmolar. Low osmolar is traditionally used contrast, which is which has an osmolarity of around 650, 670. Isoosmolar contrasts are those which have the osmolarity exactly same as blood, around 270 to 300. So those are supposed to be safe in case of patient with renal failure also.
Suppose that this patient we use a CT angio and we see actually the patient is having brisk bleeding. Obviously the next approach will be doing a DSA and doing a coil embolization or something. What is your experience about it? Because there is always a concern post-coil ischemia at that area, then colonic ulcers or perforation there. So I mean, what is your approach?
We have done few patients like this where we have seen that the patient, we can see that the artery is bleeding. So in those cases, we may not always use coils basically. See, embolization doesn't mean only coil. Yes. We can embolize with PA particles, we can embolize with glue, we can embolize with gel foam even. So and what we do is we do super selective embolization. We don't just embolize the proximal artery. We try to go as distal as possible and we just try to focally embolize the vessel. So in our practice, what we have seen in the past 7-8 years, I don't think we have seen any ischemic complications related to embolization. I think Sanjay sir will.
And suppose we do this thing CT angio and we find just there is some blush but there is no active bleed.
Exactly.
So what next?
That should be embolized. If we find any abnormal blush, there might not be active bleeding at that point of time, but we need to embolize it. We may not put a coil. We may just put a gel foam or a PVA particle just to eliminate the blush. It might be a dual foil lesion. It might be a small AVM.
So suppose we get it somewhere near descending colon or somewhere near sigmoid colon. So would you like to embolize this, or would you like to do a colonoscopy first and then, because there are studies actually in these patients where if you don't embolize that time and if you just localize, it might be in the left colon or something. Yeah, you can do a colonoscopy and then.
Most of the times we get patient after colonoscopy. So like we don't get patient, we don't send after embolization.
Patient had a brisk bleeding. We, as Dr. Noor told, that he waited for 24 hours, but he had brisk bleeding and reached to you. So now you did it.
The thing is, in our center, I think the first we go for colonoscopy. electively we manage. Most of the times I think the colonoscopy will manage the bleeding in case of a colon, like they will do some inject adrenaline and they may clip and all. Even if sometimes what has happened is sir has seen that there is a bleeding from the lower ileum, which which can be seen in the colon. So in that case, like maybe a scope may not reach up to that the place where the bleeding is. So in that scenario, I think our role comes into play, where the colonoscopy might fail.
So if you refer the patient to the IR, if they do an angiography, they'll embolize.
It is always
There are studies.
Logical.
There are studies. It helps in localization, and then you can always put a scope if it is in a distal colon, and you can do some.
No, but are you saying that in all such brisk bleeding cases, we should do CT angio first, without doing a colonoscopy, and localize if at all it is there in colon, then take the colon inside?
No, when it is a blush, like it means that it not necessarily that it will be a massive bleed, because massive. So they can actually see the extravasation. When it is a blush, I think still there is a role of the endoscopy and colonoscopy and
yes,
this thing.
yes,
right?
that was
many times in massive bleed,
suppose you get a blush in the
Basically, not in all cases. Depending upon when the patient has stabilized after, because most of the time, what will happen at the end of 12 hours, most of them will stop bleeding. So then you can plan for the next day colonoscopy, but in those who are having continuous bleeding, then you have to plan the
See, algorithm is that you first do a colonoscopy.
Yeah, I think
in all cases, I think.
So in our, if we see in hypotension, I think we agree CT angio followed by this.
Agreed.
Otherwise, if the patient is hypotension, first line of investigation should be a colonoscopy.
Agreed.
60% we can find something. Otherwise, everybody does a CT angio first. I think that's not an idea to do.
Agreed.
Hypotension, CT angio followed by conventional angio.
I'll
All
tell-
other things, colonoscopy first.
So I'll tell you a case which we did yesterday, day before yesterday. Patient in shock, BP dropped from 110 or so systolic to 70 systolic. He was bleeding blood, fresh blood per rectum. We took him on table. He is a known case patient of diverticulosis. We found a bleeder at 20 centimeters. It was an active spurter, and we did an OTSC. Suppose we had gone for a CT angio, the things would have been delayed.
True.
So I feel that colonoscopy is the first investigation.
Yes.
Except when, I mean, you feel that you cannot do it for some reason, or when family is unwilling.
So
Colonoscopy
what
should
point
be
I wanted to raise, so the first colonoscopy you didn't point out anything, then you go for a CT angio, the patient was bleeding. If CT angio shows something which still can be approached with the colonoscopy, again you can repeat an endoscopy before going for the DSA, because DSA and embolization is more associated with ischemic colitis.
So not every city is blessed with a interventional radiologist. In my city, there is no interventional radiologist.
But if you do doing an angiography, he'll embolize.
Sir, I was asking about CT angio.
That's logical.
So it all depends on the availability, the team which is
No,
present.
you can't tell him, don't do embolization, I'll do a
obviously,
colonoscopy.
yeah, sir.
No, once
So it
patient
has to
on
be
a
a
DSA
team.
table,
I have
team
one
agreed,
question.
agreed,
I have
agreed.
one question.
Yes, sir.
The toughest things I found in lower GI bleed is bleeding typhoid ulcers. What do you do there?
Ileal ulcers.
Typhoid.
Ileum, usually in ileum.
Cool, huh?
Right.
Anybody?
I have one experience of a enteric ulcer with massive bleed, and the patient was sent to higher center for embolization. But even after that, he expired. He was a young chap,
So
26-year-old. Blood culture was taken, came positive for Salmonella typhi.
We always tried endoscopy and ileoscopy in this patient, and if possible, we try to control this endoscopically. We can use.
We
They are
have
big
managed
ulcers.
few with
Actually, these
they are big. But
they are very
if
fragile
doesn't work,
ulcers.
then if doesn't work, then obviously as an approach, angio or at the end surgical.
So,
surgery.
Can
That's what.
Can I just make a
Yeah,
comment?
please.
So I'm Dr. Nitin Shetty. I'm from Tata Hospital. I'm an interventional radiologist. So what I would say is that in case if there is a risk of bowel necrosis injury,
Yes.
which we come to know when we do an angiography, what we do is that we just place the microcatheter at that point, and then we shift the patient to OT. So in OT, the surgeon would know where exactly to resect, because on table he can inject methylene blue, and the entire the segment will get identified, and just he has to resect that particular segment. So this is what can be done if we feel that it is not possible to do embolization for the risk of necrosis.
We are forgetting one more thing. We lost the technique of intraoperative endoscopy probably. So that's also very useful.
So this is one of the flow chart. I mean, in acute GI bleed, we should always rule out if there is any suspicion of this may be upper GI source, especially in those patients. We should upper GI endoscopy is a very simple thing. You can always do it. And then colonoscopy is obviously the investigation of choice. If, as we were discussing, CT angio only if the bleeding is active and the patient is in hypotension. And if we do not get any bleeding sites, then and if we suspect that this patient might be having a small bowel source, then there is a video capsule endoscopy there. And if we localize, then we always try to control it endoscopically or with the radiological embolization. And finally, surgery only in those patients where we are not able to control this. So this is again regarding this initial management. I think we have discussed this, this resuscitation, ICU care, and the management. One question actually, Dr. Iyer, what will be the decision? Suppose this patient had a CABG just 6 months back. When you will receive, his bleeding has been stopped. When you will restart antiplatelets?
Yeah, so this is a joint decision. I mean, not a cardiovascular disease. For what indication has the antiplatelet been started? If the patient has been started on primary prophylaxis for prevention of cardiac and not had any cardiac event just because age and family history, so then actually it can be stopped for some time. But if the patient has had a cardiovascular event, and then for that antiplatelet has been started, aspirin can be started early. But in this patient post CABG, the problem comes when PTCA with drug-eluting stent is there. So where the cardiologist is not comfortable when you stop the Brilliant or the
I think we had a good discussion in the morning about this. We can
so
skip
I think
this.
that we can skip that part.
Dr. Rati, one more thing. Once upper GI colon CT normal, see then I think rather than going for a video capsule endoscopy where the patient is actively bleeding, in that situation a enteroscopy should be an ideal, because video capsule endoscopy doesn't make any sense. Do a double balloon or a spiral enteroscopy, go up and down, mark both the sides if you don't release anything, and do a intraoperative enteroscopy rather than wasting money on video capsule which doesn't give any treatment for this.
That's what highlighted was by Dr. Mohan Ramchandani also. You can
But
proceed.
it's the issue
it
is
all
availability.
depends upon the hemodynamic
By
status.
Availability.
and large, if the bleed is substantial, the angio will pick it up. If it doesn't, then no use of doing a capsule endoscopy.
Capsule or she's only blood in most of these cases.
Obscure
That's
GI
the case.
means
If it's
anemia with bleeding, not
No,
for a bleed.
Yeah, if it's a brisk bleed, over it, bleed, small bowel bleed, you can go with double balloon.
So the issue with the double balloon not availability.
Sir,
is
that is the
also
main
very
problem.
Yeah.
If you are dealing with the tier 3 cities and tier 4 cities, sir, where the basically gastroenterologist.
Where double balloon is being used, there also to localize whether to go retrograde or antigrade. For that, I think video capsule is.
See, 40% of the time you can treat. Another 60% you will not be able to treat. Video capsule, 100% you cannot treat anything. Why? What is the fun in doing when the patient is actively bleeding?
No, if a patient is actively bleeding, if there is a brisk bleeding is there, even when you do the upper GI endoscopy, you can do a little deep enteroscopy, you can go up to jejunum. And during colonoscopy, you can do the terminal ileoscopy. You can almost minimize or you localize. If it is still there, then you can probably consider other things.
Yeah. The other option where I think double balloon is not there, that is where intraoperative enteroscopy comes.
Directly, I think video capsule can be skipped and directly you can, if there is no availability of video.
Brisk bleed,
If
then
cost is not the issue, can
intraoperative
we still try
endoscopy
it?
is the way
It's there
to
in
go.
the website.
When time is so crucial, then angiography is a simple, straightforward solution.
Upper GI colon ho gaya, CT ho gaya.
Enteroscopy takes lot of
No,
time.
sir, this is what we are speaking is upper GI done, colon done, CT angio done, conventional angio done, you have not found anything, patient is actively bleeding. Then the remaining is only two options. If there is no money, no enteroscope, do a intraoperative enteroscopy or do a
So if you have a pediatric colonoscope, better use it rather than upper GI. You'll get a longer length.
30-40 centimeter more. Yeah. So what are the, I think we have discussed this, but still if you can put some light on endoscopic treatment options for acute lower GI bleed. Dr. Naveen?
Endoscopic treatment, as discussed in the previous, so it depends on the type of the lesion, size of the lesion, the acuity of the bleed what we are seeing. So depending on all that, and here just I wanted to add one point is, in a situation where we are unable to see the bleeding, I think nowadays use of cap should help more actually to localize the bleed. I think I would like to highlight that point. Use of the cap should be considered. And other, depending on the lesion, we can consider adrenal injections and the clips and the OTSC, depending on the lesion and the size.
We have discussed already post-polypectomy bleed. Would you like to tell something about that, or should I skip this?
So most of the things have already been
Covered.
discussed. Prevention, injection and clipping at the base using endoloop, and for the treatment also. Only thing it is whether it is immediate or delayed. So in immediate post-polypectomy bleeding is easier to control because we are already knowing the site. Post, however, the delayed bleeding is a little challenge.
Okay, we have discussed this. So again, finally, the role of the IR in the acute lower GI bleed, tips and tricks. Would you like to tell something?
Tips and tricks is basically we just don't go and embolize. We intervene when we feel that there is a very high chance that we'll get a bleeder and we need to embolize it. Most of the time we analyze the CT angio very thoroughly. If we feel that there is no point in doing a conventional angiography, then we don't intervene. And once we feel that we need to intervene, we have a lesion to embolize, then we go in and we try to embolize it as distally as possible. Always and always we tell the patient there is a risk of ischemia, and the patient might have to be operated at some point of time. But luckily to us, it has not happened till late. To prevent this, what we do is we do super selective cannulation. We have very good microcatheters. We have which are 2.1 French, around 1.9 French. We go as distally as possible, and we just do focal embolization. We just go and blindly embolize any vessel. When we find that this is a point where we are convinced that this is bleeding, this is a point where we find abnormal blush, the artery is tortuous, then we go and embolize it basically. And we have so many things to embolize nowadays. PPA particles, we have glues, we have coils, so we can use whatever we are comfortable with.
Great. And regarding surgical intervention for GI bleed, Dr. Vishnu, would you like to tell something about surgical things?
In the surgical intervention in lower GI bleed, hardly 2 to 5% of the patients require any surgery now. Most of them can be managed through endoscopic or interventional radiology means. And as you sir already have told, that surgical management can be divided into two broad categories, whether we know the etiology or whether not. Sometimes if it's a malignancy, it's an mecal diverticulitis, that kind of lesion definitely needs a surgery. A salvage surgery for patient in a hemodynamically unstable patient. So two things are there. One could be a partial colectomy or a total colectomy. So if we know patient is a known ulcerative colitis patient, or he's a very unstable patient and we are not able to localize, then total colectomy is otherwise partial colectomy we can do, but studies have shown around 25 to 50% of the patients require a redo surgery for these patients, and surgery is definitely the last modality because it is associated with high complication. Up to 1/3 of the patient may have a very significant post-operative morbidity or a mortality.
One last question I would like to ask to all the panelists and all the experts here. Suppose a patient have a major GI bleed, major lower GI bleed, and you tried everything, you did endoscopy, colonoscopy, CT angio, everything is normal and the patient bleed has stopped. How far you would like to go to investigate this patient? Would you stop at this point, the bleeding has stopped, or would you like to do anything else for this patient? Anybody would like to answer?
I think if the patient is a young patient, less than 40 years, and it was a major bleed, I think that's the patient which we need to evaluate further. Elderly patient, most of the time it is diverticular bleeds which might have stopped. I think that's how I look at these things. Otherwise, age group is very important.
Suppose you didn't get any diverticular on colonoscopy.
See, usually this is the problem what we can see. Means elderly population more than 70, that's okay, you can stop. But if there is a young patient who is a 35 or a 40-year-old had a major bleed, I think that patient needs further evaluation.
Will it be
I
then
think
capsule endoscopy or something else?
This
No,
is
no, if there is a major bleed, it was a means he had a if his blood pressures are low, no point in capsule endoscopy. I don't do at all. My capsule endoscopy is only for patient who have got anemia. Otherwise, you are wasting 80,000 rupees for a bleeder. Unnecessary 1 lakh rupees gone.
No, the situation what Ravi is saying in this capsule endoscopy is a good investigation because you have done CT angio, you have done upper and lower. This is the patient who needs a small bowel evaluation.
True.
You have not found any diverticuli. You have not found even telangiectasia, angioectasias. Then this is the patient who needs capsule endoscopy. I don't agree with what you say.
So it is, you're missing the small entire small intestine. And
So
there the role of, the bleed has stopped, probably you do a capsule endoscopy, what Sanjay is saying. And I'll differ with Ravi. I like to investigate the elderly more because the moment they bleed, they may pop up.
But they
So
will pop up
that's a bigger problem. Elderly, they tolerate the bleeds very badly. Youngsters will tolerate
Because
bleeds
this is
badly.
also a scenario which happens. That's what I
Of
thought
course,
we-
yes. That's a real life scenario.
real world
See,
scenario.
other one is you can do when there is an active bleeding. If you don't find anything, then you can use a capsule. Everything you have done, nothing you have found, then you can use. See, but if there is an active bleed which has resulted in an hypotension,
Here the
yes,
patient's bleed is stopped.
yeah,
That
stop.
is
No,
why-
the bleed has stopped and you have not found anything.
Yeah.
You
Then
have
he's
to
asking
image.
the
You have to
question.
image the small bowel.
Then there is no use at all. Why do you do this?
If there are other investigation negative, you have not found anything, I think still worth doing a capsule because if he rebleeds, what are you going to do?
Yes, and that is science. You have to know why the patient bled.
Sir,
In managing the patient, you forget science.
Sir, my question is.
So CT
Yeah,
angio
there
with
are
CT
several-
angio, the bleed has to be more
several
than
such
1 ml
Sir,
per
many
minute.
situations it happens,
Sir,
sir.
it is there, it is there.
Most of
CT
it
angio will
More than
miss-
1 ml per minute, otherwise you won't
Yeah.
pick up
No,
anything.
that's
It
the
is-
bleeding,
it's
but
capsule
even
def-
they miss small lesions in the small tumors in the small bowel, they are missed. Lipomas, cysts which are bleeding, they will miss. So small lesions on CT
Ulcer.
angio may be
Any
missed.
ulcer in the
And
small bowel.
even a dolifi may be missed.
NSAID-induced ulcers which bleed. So,
Sir,
I
my
mean, this is a good indication for capsule endoscopy. Otherwise, where will we do?
Yeah, no, sir.
In
indicates-
suspected anemia, you are very right.
Yeah, anemia. Only thing is if there is an active bleeding, then
Not active.
no.
What he said is it is stopped and you want
Stopped.
to investigate or not.
Yeah.
Yes.
Thank you, everyone. I think if there are any questions. Thank you.
I would like to request the speaker, panelist, expert discussants and moderator to please come to the selfie point for a group photograph. Now, to begin with the next panel discussion on the topic portal vein thrombosis with or without CLT, I would like to call Dr. Kaushal Madan sir as the moderator. I would like to invite the expert discussants for this discussion. Dr. S.K. Saxena sir, Senior Surgeon Bhopal, Dr. Pradeep Saxena sir, Professor of Surgery AIMS, Bhopal, Dr. Ravindra Kale sir, Gastroenterologist Indore, Dr. Shailendra Jain sir, Associate Professor, GMC Bhopal. Now, I would request all the panelists to please join us on stage. Dr. S.P. Mishra sir, Dr. Neeraj Saraf sir, Dr. Sonal Asthana sir, Dr. Nitin S. Shetty sir, and Dr. Rahul Bhargav sir.
एक माइक यहाँ और दे देना दोस्त हम लोग 3 ही हैं चल जाएगा
I would like to
चल
request
जाए, चल
the
जाए, चल
speaker,
जाए।
expert discussants and the panelists to please come on stage.
all online moderator is online, he's already there.
Good evening, everyone.
Kaushal, good
Can
evening.
you hear us?
Yes.
Dr. Mishra, can you hear us?
Yes, I can also see you.
Good evening. Can you hear us?
Yes, can you hear us?
Kaushal, we can see you, we can listen to
And
you.
our slides are also visible. Neeraj is also there.
Yes.
Okay, perfect. So I think we'll start if the chairpersons allow us. So good evening, everyone. So first of all, I really apologize for not being there physically because of the ongoing condition. Maybe I was too scared, more scared than Dr. Mishra. Here we are online to be able to finish or complete this.
Kaushal, you are still young. I'm in the
On portal
70s,
vein
so
thrombosis,
I can
and I
take that
thank
risk.
Dr. Sanjay for inviting me for this. So we have right. So you have to be as young as Dr. Mishra to be able to travel during these times. So what I've done is I've taken two cases mainly as props so that related to that we can initiate our discussion rather than completing the course of the cases. So it's just a prop so that we know how the experts manage these cases. So the first case is a 53-year-old female who was a known diabetic for 15 years with HCV-related cirrhosis. HCV was eradicated in 2018. She also had portal hypertension on EVL for primary prophylaxis. She came to us on follow-up from another hospital for a second opinion, and she was totally asymptomatic. This was her labs at presentation. You can see it was almost a compensated disease. Albumin was 3.4. Hemoglobin A1C was 7.3. Alpha-fetoprotein was normal. Her hemoglobin was low. During the workup, we did a triple phase CT, which confirmed the presence of cirrhosis and collaterals. There was minimal interbowel fluid, and we also detected an eccentric partial thrombus in the portal vein, which was extending to the superior mesenteric vein. It occupied about less than a third of the lumen of the portal vein. So with that, so what the nomenclature and classification which is usually used for portal vein thrombosis, it could be acute or chronic. Acute again could be with or without cirrhosis. Chronic is of two varieties. The one which we see in India, especially in the younger individuals, is extrahepatic portal vein obstruction, in which you also have a cavernoma formation. The other one is a long-standing chronic portal vein thrombosis, again in patients with or without cirrhosis. So this is how we classify it. The other classification can be based on location, the intrahepatic portal vein branches, the main portal vein, or extending into the tributaries like splenic vein or the superior mesenteric vein. Then, based on the length of clot, intrahepatic, extrahepatic portal vein, and most importantly, the percentage of lumen occluded, it is less than 50%, more than 50%, or complete occlusion of the lumen. So with that background, let me bring in my first panelist, Dr. Mishra. So I would like him to teach us what are the risk factors for portal vein thrombosis in patients with cirrhosis, what is the burden of portal vein thrombosis when we come across patients who have cirrhosis, and coming to non-cirrhotic portal vein obstruction, how frequently do you see portal vein thrombosis, especially EHPVO in non-cirrhotic patients, and do you feel has the prevalence of this has reduced over last couple of decades? Dr. Mishra, please.
So, Kaushal, the basic cause of portal vein thrombosis basically is reduced portal blood flow, and that can be because of increased intrahepatic resistance or because of shunts and use of non-selective beta blockers. Then you have vascular endothelial injury, in which she was receiving banding. Banding has also been implicated. So sclerotherapy, banding, epithelial dysfunctions, and surgical interventions. Then one of the most common cause in cirrhotics is hepatocellular carcinoma, other solid tumors, myeloproliferative disorders, acquired and congenital thromboembolic phenomena are there. Protein C, protein S deficiency can be there. So all these factors can lead to portal vein thrombosis. But in addition to that, since alpha-fetoprotein was normal, otherwise it can be also confused with a malignant involvement of the portal vein. That can be confused. So coming to the incidence, it varies from 4% to about 40%. So it's very variable depending on the child's book. So A will have less, B will have more, and C will have more. So the cumulative incidence at 1 year was about 5%, 3 years it becomes about 8%, and 5 years becomes, this is on follow-up, 10 years, 10%. Again, I already said that it correlates with the disease severity. And you have come to the slide. So liver transplant, about 10% of the patient will be found to have portal vein thrombosis, but 50% will have, once you intraoperative, once you remove the liver, you'll find some evidence of portal vein thrombosis in most of them. And coming to the question of EHPVO, yes, when we were students, we saw EHPVO patients like anything. Every day, we had at GB Pant, we had a long list of EHPVOs undergoing sclerotherapy. We had sclerotherapy at that time, no banding at that time. But nowadays, definitely, I find that the incidence of EHPVO as NCPF has gone down, and we rarely see patients with EHPVO. Probably because of more sanitized delivery. Most of them are, cesarean is more common than vaginal delivery. And most of the, even in the villages, you have medical facilities available. That may be a cause of problem, whatever it is cause. The incidence of EHPVO, all will agree, has gone down considerably.
Dr. Kaushal, another interesting phenomena which we have been tracking for almost a year is the gut microbiome in the cirrhotic patients. There's some evidence which says that there is more inflammatory markers of the gut microbiota in a patient who develops develops thrombosis in cirrhotics versus who does not develop thrombosis in cirrhotic patients. So between the two subgroups, there's a more inflammation in the gut microbiota, and that is what is happening right now. We have been investigating that at Fortis. Y16S RNA is about the gut microbiome, which is the culprit in both having a thrombosis in portal vein thrombosis in a cirrhotic patients.
No, there comes the problem. It's the egg and the chicken theory. So was it because of the portal vein thrombosis get it, or because of that? And second thing is, gut microbiota has been implicated in every damn thing. So you don't know how much it works.
So a very interesting phenomenon to suggest from a standpoint of view of from a hematology. We did a study on 260 patients with Indian core binding factor mutations in AML versus the Americans. And you will be surprised that we have got 3.5 times more mutation, which is more inflammatory in nature in Indian subsets. So if you start getting more chips at a younger age, which is clonal hematopoiesis, I'm sure people in this room give their blood test for the genomic testing and they search for a chip. I'm sure 10% will have the chip in there right now. So it means the inflammatory markers are the ones which is governing more aggressive behavior of the diseases in India. So if Dr. Kaushal and Dr. Mishra is there, I would like to get an idea from you, amount of thrombosis in a cirrhotic patients in America versus India. Is there any difference between the incidence of thrombosis in these patients? Because if there's a more thrombosis in India, then you have to really ask yourself, is the inflammation really playing a role or not?
That's what we said, Kaushal and myself were discussing. Thrombosis, extrahepatic portal vein obstruction, which was very common, is nearly disappearing nowadays. So probably what you say, the inflammation has come down, I believe. And that was most of the infection at the time of delivery.
Right. I think that's a very important point. As far as association is concerned, I completely agree there is an association.
Causation is not.
Between inflammation derived from the gut and development of portal veins is the association. But whether it is causative or not, like Dr. Mishra said, it's a chicken and egg issue. Which came first, we still do not know. And once we come to prophylactic, and I'll again talk about it. I think, but that's a very important issue you've raised. So
I don't think so. EHPVO is a different entity. I don't think incidence of PVT is higher in India in cirrhotics as compared to the West.
Yes.
Completely agree. Completely agree.
It's about the same. Yeah.
Right. It is about the same. Yeah. So what was more higher was the incidence of EHPVO, which we were seeing earlier, which also is declining, like Dr. Mishra said. So I think we'll move on. Dr. Nitin is there. Dr. Neeraj, what do you think would be the natural history of this kind of portal vein thrombosis? A patient is asymptomatic. By chance on CT scan, you picked a eccentric thrombus. So first, let me start with Dr. Neeraj. What do you think would be the natural history here?
So this is a partial thrombus, and I think about probably 40% maybe would resolve or, get less. Probably about 40%, roughly, I'm just giving you rough figures, I'm not quoting any data, would probably progress, and about 20% would probably remain stable. That would be my
But Neeraj, it's extending to the SMV.
Right. So what are the outcomes associated? Yeah, I think even those which are extending to the SMV, but not
extending to the SMV has implications on treatment. So, because that would indicate treatment for this patient. Otherwise, there would be no indication for anticoagulation. But I think natural history would be similar, probably.
So, Dr. Neeraj, is there any criteria to predict who will progress and who will not progress? Because that's a key element. You said 40% will have a stable course and 60% will progress. Over a course of thousands of people, is there any guidance to the clinician that who is going to progress and who's not, and how to follow that up? Because
Maybe
before putting them on,
will tell that.
Because on putting on an anticoagulation in these subsets of people is a dual-edged sword. So you need to be very clear that these are the 1, 2, 3, and there's a percentage chance. Dr. Mishra.
Well, right now, prediction is very
So
difficult.
obviously,
but those who have got
percentage
myeloproliferative
of
disorders
occlusion,
or
the extent
congenital
of-
things, protein deficiencies and things like that, they might progress more.
So
they have a more aggressive, and they require anticoagulation for a longer duration of time. And those undergoing liver transplantation.
Yes. So there's another caveat which I tried to bring, why I brought this was, when in a liver cirrhotic patient, when you try to do a thrombophilia checkup by assays where they have to quantify the thing and not look at the mutation, genetic mutations, they're all going to be fallacious. Why? In a cirrhotic patient, both the antithrombotics and the thrombotics have interplayed in such a manner that their whole balance has come down, and that's why you don't get more thrombosis or you don't get more bleeding in the subsets. So both has come down proportionately, but in which proportion to test the assay for protein C, protein S is difficult. So the only thing which you can actually check is MTHFR or a factor V laden or any genetic mutations which you can see whether there's a heterozygous or a homozygous mutations which are there, which is either way around going to be less than 5% of patients.
I just have a
Please.
I just have a question in this regard itself. So, would the call also be dependent on the percentage of occlusion and the length of the occlusion?
That's what. Yeah. So that's
what Neeraj said. If it's a partial occlusion, so you're a bit safe there.
So that's the 50% is the cutoff?
Yes.
I don't know.
Yes.
Right. So I think you heard Dr. Mishra regarding the risk factors of in cirrhotics. So one of the major factor is a slow flow in the portal vein. Okay, so since it is a flow dependent phenomena, that is why in many patients this clot appears, then disappears and reappears. And what Rahul is, I think Rahul made this point of which are those patients. And since this slowness depends on the degree of portal hypertension and degree of liver dysfunction, so patients who are in advanced liver dysfunction possibly are more likely, but we still need to have, say, scores or predictors which can tell us that these are the patients to be put on this. And again, we'll talk about it towards the end of this discussion. We have a topic on this separately. So, Neeraj, what do you think are the outcomes when we look at these kind of clots? I mean, all clots taken together.
Yeah, so the outcomes, I think, like I said, it will be based on the natural history. So if the clot resolves are good or similar to a person without portal vein thrombosis, if this remains stable also, I don't think there's any change in outcome. If the clot progresses or especially goes into the SMB, then I think the outcomes can be different. And the other implications it has will be on liver transplant in the future, if there is a progressive clot.
Right.
Dr.
We'll
Kaushal,
that, but there are a few meta-analysis which have Sir.
Yeah, Dr. Kaushal, Rahul this side. So on the sidelines, I was discussing with Dr. Mishra, shouldn't it be binary whether there's a clot or there is no clot? Because the whole treatment modality depends upon if once the clot has started, it is invariably is a nidus to progress to the occlusion. Because I've not seen the natural history. I really don't know, I've not read about it. But in all the experts' guidance here, once there's a clot, there is always a clot and there's always a progression, whether 50%, 40%, or 90%. So, Dr. Mishra, what is your take on to that?
I was discussing with you same thing. Probably people having clot, they have more problems as people who don't have a clot. Same thing we discussed in the morning for Budd-Chiari syndrome.
Yeah.
But what Neeraj says is correct. If it's a partial thrombosis, you're better off.
Yeah.
So I think we are discussing.
Spontaneous recanalization is there.
I think that
What I ask you, sir, what
some
is
problem
the
with
role
the
of
audio. We are
your work of
what I am getting.
Can you use the mic? Can you give closer to your mouth?
Okay, okay. In a patient of cirrhotic, there is a chance of recanalization, spontaneous recanalization, or more or less. 50% patient remain stable. They do not progress for the ischemia. What we have problem is only the ischemia, bowel ischemia. We do not have any problem other than the EHPPO. In the EHPPO, we do not coagulate, we do not even give the anticoagulate. So here the problem with the only the progression toward the mesenteric ischemia or SMB progression.
So that is what he said. If once you have a clot, the chances of all complications, portal hypertension, all they increase as compared to people who don't have clot. That's well known.
We most of the time, cirrhotic patient we see, it will not, rarely it will cause the mesenteric ischemia, very less. But chances of bleed is there, and chances of post at the time of the liver transplantation, the difficulty is there. That is nothing and more than that.
So, sir, Meera's question is very simple. It's not about the bowel ischemia we are talking about. It is the partial thrombosis feeding to the liver versus the completely occluded portal vein not feeding to the liver. The outcomes are different in both the ways. And as Dr. Neeraj said, it becomes an implicated thing when you have a liver transplant on board with a thrombosis. It will always be difficult than having a non-thrombotic portal vein. So the only thing is once you develop, so if I'm a young patient, say 47, alcoholic, now cirrhotic, has got a portal vein thrombosis which is like 30% blockade, will you give me anticoagulation because I'm next on block for a liver transplant, or will I not give that? That's a question in my mind.
So once you transplant, you have to adopt all methods to clear the clot.
Perfect. So that's a
And Neeraj is in the best position to answer that.
Perfect.
50% clot only in the portal vein, then anticoagulation not recommended, and you just follow these patients with regular imaging. It's only if it's more than 50% that you give anticoagulation.
Kaushal?
Right.
Kaushal?
So I think let's move forward and we have separate discussion on these heads. So
Hello. Dr. Sonal Asthana has also
Sir.
joined. Is a liver transplant surgeon, so you can put this
So
question
there's a problem with the audio.
Hi, Dr. Kaushal, Dr. Neeraj. Pleased to see both of you, and thank you, Dr. Sanjay, for having me. I apologize because of a deceased donation. I got a little busy in the morning. I wasn't able to take the flight. So, thank you for inviting me to be part of this.
Right. So we'll move forward now. So talking about outcomes, so there are a few meta-analyses which suggest that the outcomes are inferior, but they have included all patients who had clots.
Can we go to the slides of
complete
Dr. Kaushal?
occlusion versus partial occlusion, and we'll have more discussion on this, whether we really need to treat partial occlusions which are asymptomatic. So can we have the slides on the screen, please?
Yeah, Dr. Kaushal, slides, please.
I can see the slide.
Yeah, I can see it as well.
No, the main screen in the hall.
Yeah, now we can see the slides.
We are on Zoom, that's why we are able to see the slides are to be seen in the hall also. All right. So I think the next question was to Sonal. He just entered at the right time. So Dr. Sonal, I think we were discussing this earlier also.
Kaushal, I hope he knows the case that there's a SMB
This was a
involvement.
patient who had a partial asymptomatic thrombus.
With SMV involvement.
Who has portal vein thrombosis and is a cirrhotic. And
Sure.
would you treat this particular patient who has about an eccentric thrombus occupying less than a third of the lumen and extending partially into the SMV?
Sure. I think that the treatment in this situation, as Dr. Neeraj has already said, is a little contextual. If the thrombus is occupying more than half the circumference, then there is a strong case to treat it, especially because if liver transplantation is conducted, because you would try to mitigate the risk. If there's extensive collateralization, if, for example, there was a previously occlusive thrombus which is currently, resolving, I think those things would also be indicators to treat this kind of thrombus. I think the view for treatment in this situation perhaps is to see whether we could mitigate the risks of the surgical risks of performing a liver transplant later on.
Right. I think that the Boveno 7 also transplantation irrespective of extent of thrombus. But again, you also know that that's a controversial issue. Not everyone, uses anticoagulation in such patients. And we'll come to that issue again since you're here. And for example, in this particular patient, for example, if you ask me, if this patient did not have an acute thrombus, had I known for last year that she's been having this kind of thrombus and she was asymptomatic, I wouldn't give her anticoagulation. So let's take the opinion of panelists. Neeraj, would you, knowing that this, for example, if you had known that this patient had a thrombus for last same kind of thrombus without being on anticoagulants now. So I'll move on. So Dr. Sonal, since we did decide on starting this patient on anticoagulants, how effective are anticoagulants in patients who have cirrhosis?
I'd say that in acute thrombosis, anticoagulation is relatively useful. In chronic thrombus, probably less so. The reason is because there are slightly different pathologies. Acute thrombosis are softer, and then perhaps anticoagulation would work better in them. In chronic thrombosis, what we really find is that the thrombus typically gets endothelialized over, and there's a layer of endothelium on top even when you operate on them. So once you have, say, an eccentric, I did not know this part about the thrombus extending to the SME there, but what I'm saying is that if we knew that the thrombus had been there for a long time, then the odds are that it would have endothelialized over, and anticoagulation would not nearly be as effective. So acute thrombosis is probably a little bit more effective, and thrombosis less so.
So the issue is, and there are meta-analysis which suggest that once you treat them with anticoagulants, there is partial or complete response in most of these patients, and portal veins do recanalize, and there is not much increased risk of bleeding. So risk of bleeding remains the same whether you give them anticoagulants or you don't give them anticoagulants. So there is always a fear, like Dr. Rahul raised this issue, that in a cirrhotic, the issue is also of bleeding. But it has been seen that even patients who have CTPC, the risk of bleeding is not more than what it was in controls. And it did lead to recanalization and reduction in all-cause mortality. So I think coming to the hematologist, and I must tell you, he's one of the most famous hepatologists in the country, hematologist in the country. He's been associated with, I think, kickstarting of bone marrow transplant centers across our country, and I must congratulate him for that. So Dr. Rahul, so what is your choice of anticoagulant for a patient with cirrhosis with portal vein thrombosis who requires treatment in terms of safety and efficacy?
So Dr. Kaushal, it will be a slightly prolongish answer. If it is for the definitive period of time, which is for 3 to 6 months, then probably the choice will be always low molecular weight heparin, because we have to understand when we read these meta-analysis coming from China or US, they have an extensive lab which can actually measure the anti-10A factor assays and they can modulate their doses. In terms of DOACs, it is easier said than done. So if your patient is not willing to get a jab every day for 3 to 6 months because he's on a liver transplant list, still the choice will be the VKA inhibitors, which is warfarin, and not the DOACs. We know that there's a lot of data which has been pushed and meta-analysis from China being pushed saying DOAC is as good as or non-inferior to VKA. But we have to understand the problem in Indian setting is threefold. One is monitoring. If there's a DOAC data, does the DOAC data is inferior? No, as good as the VKA inhibitors. People in the West say you require more PTINR. There's people in the West say you require more PTINR. There's people do not require any monitoring. In our setting, it is easier to get a PTINR done than managing a bleeding in 1 in 1,000 patients of a DOAC.
So the choice will be warf or acetrom?
So warf. So warf is being all for a long time. We tend to prefer warf, but still, if 3 to 6 months is the time period, low molecular weight heparin is the standard.
Why warf? Why not acetrom?
It's just the ease of doing the things. We've been using the warfarin for a very longish time, and we have got our assays well built on PTINR, so I don't think so that's a problem.
The study favors acetrom over warf.
So, yes, so some data suggests that acetrom might be superior in terms of in liver cirrhotic patients not altering the vitamin K dependent inhibitors, but we have not seen that a problem in our setting, so we still continue to use warfarin. Dr. Kaushal, over to you.
All right. So you suggest, yeah, thank you, Rahul. That was very interesting. You want to take the data on DOACs with a pinch of salt. That is completely agreeable. But I think most people in our practice have started moving from VKAs to DOACs. I think in terms of ease of managing their anticoagulation rather than getting
you don't have to monitor
PTINR
them.
done every week or every month or every 3 months. Yeah, so DOACs become, it's easier to manage in that way. But I think we'll come to the bleeding part and the side effect part. But just wanted to highlight this particular study. This meta-analysis in decompensated cirrhosis, in thrombosis, when DOACs or VKAs were given, there was a higher rate of portal vein recanalization, lower rates of thrombosis progression, but the mortality was similar. So there was no impact on mortality or outcomes.
So Dr. Kaushal, one more thing which you have to be very careful is,
once we start this, how long would you like to continue the anticoagulation? For example, in this particular patient, how long would you want to continue?
So once we started, we like to see the recanalization, or if it doesn't recanalize in 6 months, then you stop. And second thing is, if you want to go for liver transplantation, then you have to recanalize by hook or by crook.
so Dr. Kaushal, the most important thing is, what is the aim in this patient? Is this a young patient or an elderly gentleman? The aim in the gastroenterologist's mind is the biggest factor which will determine how much anticoagulation to be given, one. Second, the second biggest factor is what is the inherent risk for this patient to develop thrombosis. And that is why the science is moving towards, people will say that's quite futuristic, but I think the exon sequencing, the way of doing the exon sequencing and picking up the mutations in these subsets will guide us whether they really require the anticoagulation or not. So two things, what is the aim at the end of the day, what you're requiring it, and what is the baseline risk for the patient to determine how long to give. Because if you have any thrombophilia, if you have got a JAK2 which is there, that means that you have to give it for a longish time and not for 3 to 6 months.
That's correct. If you have thrombophilia, then you have to give for a longer duration of time.
Lifelong.
Yes.
Right.
So I think inherited
I think
risk
that's
factors.
well known. You have a prothrombotic state, you have to give it. Yeah.
So I think what Rahul is saying is that in order to pick up thrombophilia, you need to move towards this genetic chip testing based on the NGS or the whole exome sequencing. That's what I think Rahul is trying to make the point. So if you want to exclude a prothrombotic state, you must get these tests done, maybe not now, maybe in near future. Rahul, is that what you want to say?
I think yes, Dr. Kaushal, the gastrogenomics is the new trend and new buzzword. Next year, we will have some data on 50 or 100 patients in these subsets on exon mutation. So let's wait for the next year data. We'll
Don't
show
worry,
around.
don't worry, Rahul. AI will take over and they'll tell you what is going on there.
So, I think the point which Rahul made, and he asked us which particular patient you would, what do you want to achieve by giving anticoagulation? So, the quick answer to that is what we want to achieve is that it should not progress and lead to further decomposition. That is what we want to achieve. If that is not happening, we don't want to treat, is the bottom line from gastroenterologist. We are only
So the cutoff is 6
scared about
months
further
then.
decompensation. If it remains intact, then there is no risk.
So Dr. Kaushal, from a DVT...
So I think coming back to Rahul.
Yeah, perfect.
Yeah.
So from a DVT data, which shows whether to give for 3 months, 6 months or 12 months, the two things which were very, very remarkable were whether the complete canalization has happened or not, and what is the D dimer at 3 months. If the D dimer was high and there was a partial recanalization, they subjected this patient for a 12-month anticoagulation, and they found the chances of recurrence in these subsets by 12 months was cut down by 70%. So I think D-dimer is not a good idea in a liver cirrhotics, but the recanalization...
Can you extrapolate to portal vein?
So we
It's a
don't know.
high flow.
Yeah, we don't know that, sir. But that recanalization theory is a good one, and that's a good thought.
The portal vein is a high flow area, so and that time it will have a centrifugal.
And sir, at the second time, is the flow getting more than 15 centimeter per second or not? Various trials from China and US has shown that one criteria, which is if the flow is less than 15 centimeter per second, is there any utility of continuing the anticoagulation for a long time? I don't know. I have not searched for that. But that 15 centimeter per second is the flow velocity which we keep on saying. We keep on finding it out.
Every patient of a cirrhotic patient with the portal vein thrombosis,
Right.
you
So
like
Rahul,
to
one more question to you is which particular DOAC are you?
I didn't understand your question. I'll take it. Yes. So Dr. Kaushal, the majority of trial has been from rivoxaban, which has been the standard. I think that's the one. But from if we have to see from our standpoint of view, which is the easiest one, because both dabigatran and rivoxaban gets cleared from the kidney, and the creatinine clearance is a major important things. And in a child pugs B and C, the dabigatran is contraindicated. So I think apexaban remains the very easy choice for us. 5 milligram BD is what is easy to remember.
But now they have used it in B and I was also of the same opinion, but they are used in B and C now.
B and C also, but still they say use with caution. Okay. So apexaban for us remains the choice of drug at our center.
Warfarin.
Warfarin, and if you have to use apexaban. So, yes,
I agree. I think most of the gastroenterologists.
So ideally you have to do it in every case. It's
So he's
not practical.
asking some questions, sir.
My question is that your
I think
message
most of
that
the
every patient of cirrhotic with portal vein thrombosis should be subjected for anticoagulation workup or myeloproliferative or subgroup of the patient you want to work up?
So, sir, at our center, when we are starting gastrogenomics, every single patient who is getting a cirrhosis and a portal vein thrombosis, we are trying to compare them with the non-cirrhotics.
No, that is not for.
So
What for a general message?
So general message is not. General message is not.
That must be under the protocol.
That is not
Rahul, that must be under protocol.
Under protocol. So that's not a further general message. That's an innovative idea.
But
of
what he
finding
says
out.
is this is going to come.
Innovation is what we are trying to say, not the general public to spend thousands of rupees because it will be useless in a cirrhotic patient to do a thrombophilia workup. So there is no need for doing a thrombophilia cirrhotic patient. It is only in those patients where the first thrombosis comes in and then later on the cirrhosis happens because of the thrombosis itself. That is where you have to find out the thrombophilia workup, as well as the pH, as well as the NGS for myeloid neoplasm, to search for a hidden myeloproliferative neoplasm.
Or even a patient who is having cirrhotic with high platelet count. Where you are subjected for some patient with
So very good question.
myeloproliferative.
Any cirrhotic which presents, it's a very heartfelt thing for me. Thanks to Razor. Any cirrhotic patient who has got a high WBC count, cirrhotics should have a low WBC count with a neutrophil lymphocyte ratio preserved. Any patient who has got WBC count higher, which means more than 10,000, 12,000 and 15,000, you can keep your cutoff limit. We keep at 12,000 as a cutoff limit. If with a hypersplenism you're thinking, WBC's counts are high, please do myeloproliferative neoplasm workup in these subsets. Platelet is the second thing. The commonest thing to diagnose for a myeloproliferative patients in a cirrhotics is high WBC count, and the cutoff is 12,000.
And in these patients, will you give a cytoreductive therapy?
Yes, sir. So we give hydroxyurea to reduce the WBC, because the interaction between the platelet, even they are low, interaction between the platelet and the WBC leads to more of thrombosis in a myeloproliferative neoplasm. That is why the idea in a myeloproliferative neoplasm is to give ecosprin to reduce the platelet interaction, as well as give hydroxyurea to reduce the WBC count to less than 10,000.
I think it's time to wind up. Kaushal, Dr. Rahul has to reach back. There's delayed, then he won't.
Right. So I'll just rush through. There was some problem with the audio. So many things I was not able to hear. So the choice is apixaban. I think everyone agrees with that because of a number of studies which have shown that it is superior both in terms of drug interactions and in early child's age cirrhosis in terms of its we always ask. So before we wind up, so Dr. Rahul, since you are the hematologist, in the absence of an antidote, which is very difficult to get for DOACs, can FFP or prothrombin concentrate be used to reverse the toxicity?
Forced to the wall.
We have discussed prothrombin concentrate PCC is in the absence of antidote is the first choice, and then FFP is to satisfy your gut.
Dr. Rahul?
Yes.
FFP is to satisfy our gut because we are sitting with a gastroenterologist.
When forced to the wall, you don't have anything else to offer.
No, satisfy our gut because we are sitting with gastroenterologist.
I think he's putting up another case. Let's tell him to stop because we are already late.
So, Kaushal, we are running short of time probably. We have to stop over here, I think. Can you hear us?
Actually, audio is not good, so he is not getting what we are saying.
Bandwidth is not good.
So, thank you all panelists and speaker for.
So, can I just,
Dr. Kaushal, please summarize. Please summarize your talk.
So I'll come to the take-home messages. Can you hear me now?
Yes, yes, we can hear you.
You're audible on the show.
Okay. So these are the take-home messages that patients with cirrhosis are at an increased risk of developing portal vein thrombosis, and it increases with the severity of liver function and increases with duration. Patients with cirrhosis may result in decompensation and higher mortality, at least in short term. Recent onset portal vein thrombosis, symptomatic portal vein thrombosis, extension into SMV, you should endeavor to treat it with the goal to recanalize the portal vein and prevent extension. Coagulation, anticoagulants result in recanalization of portal vein in more than 3/4 of patients. But does it result in improved survival without increasing the risk of bleeding? We still are not absolutely clear about that. We need more data on that. Yes, DOACs are safe in terms of risk of bleeding complications, in fact, safer than vitamin K antagonist. Though the data is limited, especially in CT, B, and C, DOACs do demonstrate good efficacy in terms of portal vein recanalization, especially apixaban. Portal vein thrombosis that does not resolve with anticoagulants can be effectively managed with portal vein recanalization with or without combining it with TIPS. And even patients with the young onset extrahepatic portal vein obstruction are now being treated by portal vein recanalization or reconstruction with or without tips, and we have favorable long-term results, but data is small. We still need to have more data on this. Thank you very much. For
Thank
the
you, Kaushal.
discussion.
Big round
I
of applause for
thank the panelists
Kaushal.
also,
Kaushal, please.
for their
And
participation.
Neeraj and Sonal. Thank you.
Thank you.
Yeah. Thank you for having me. Thank you.
I would like to request the expert
Thank you, sir.
discussants and panelists to please come to the selfie point for a group picture. There is a slight change in the schedule. We have switched the second last session with the last one as Dr. Rahul has to catch his flight. For the session, acute febrile illness with purpura, I would like to invite Dr. Rahul Bhargava as the speaker of the session. I would like to invite the chairpersons for this session, Dr. Reeni Malik ma'am, ex-HOD Pathology, GMC and Dean of Academic Chirayu Medical College, Bhopal, Dr. Simmi Dubey ma'am, Senior Physician and HOD Medicine, GMC, Dr. Anil Kapoor sir, Professor of Medicine, PCMS Bhopal, Dr. Vinod Narkhede sir, General Physician, Gastrocare Multispeciality Hospital, Bhopal.
Okay. Good evening, ma'am.
Good evening, Rahul. So Rahul is the alumni from Gandhi Medical College, Bhopal, and I just tell you that he is so loud since he was a PG student, and usually, yeah. So it is a good interaction with him during his PG time also. So yeah, welcome Rahul, and just start your delivery.
Thank you. Thank you, Dr. Sanjay. I'm odd man out from a gut conference. Okay. So I think, thank you, Dr. Sanjay. So there are 4 cases. I'll run you through very different subject for all of us and what we need to see through. Acute febrile illness with purpura. 21-year-old female undergraduate presents with high-grade fever, 7 days, heavy menstrual cycle, no prior history, no aspirin since morning, no DOAX, no warfarin, and she just presents with this. There's a lot of petechial spots over the mouth, and the typical diagnosis, these patients, once they present to you, either soft purpura, why the gastroenterologists are required in these cases. If there's a soft purpura in the mouth, 1, mucosal bleed. 2nd, there's a GI bleed, then there is a requirement for to give the platelets. Otherwise, there's no requirement for to give the patients this platelets. What is most important requirement is to have a peripheral smear to be looked at, then the hemoglobin has to be looked at. The Coombs test was positive and the double-stranded DNA was strongly positive. This patient is a case of ITP, immune thrombocytopenic purpura. Why I kept on asking whether you can do an endoscopy, colonoscopy at a low platelet count, 20,000, 30,000. That is the reason, because in ITP patients, even if you give platelets from one arm to the second arm, they will all get destroyed. So the easiest thing is to give steroids. And if there's a GI bleed, please go ahead and do your endoscopy and colonoscopy, even at a platelet count of 20, 30,000. So that's not a major contraindicated. If there's a biopsy which is required, then probably you require a platelet count of 50,000 in lower GI, but in upper GI, you can still take a punch biopsy and get out from there. So this patient turned out to be SLE, fever with purpura, and a young female needs autoimmune workup, and immunosuppression steroids is the mainstay. With aspirin you are talking about, steroids is another culprit for causing more of a gastritis and leading to GI bleeds. That's one of the commonest thing we tend to see more often, because we give tons of steroids for tons of years together. So on a steroid, generally tends to people have a GI bleed and they're nothing else. Platelets are normal, we thought so. If you say there's corticosteroid does not cause this, we are happy people will go and find out something else.
NSAID and steroid combination is bad.
So for a hematologist, NSAIDs has long been forgotten. I even don't remember any name of NSAIDs. So tomorrow somebody can say Rahul Bhargava has written diclofenac. We are completely forgotten. It's out of our mind. As a hematologist, we use only ultrasets and tramadols and so on and so forth. So 42-year-old banker report to the ER with a high-grade fever, bleeding gums, fatigue, spreading purpuric rashes. He was usual state health 3 days back, now finding hard to get up from the bed and is breathless at rest. You see the WBC counts. So simple message for the gastroenterologist is, please have a look at the CBC count before we do any procedures. If your WBC counts are high, every time it is not infection. WBC count is not every time infection or drug induced. It could be something else. So in these patients, the next thing which is fibrogen is low and D-dimer is high. Why we said APTT, PT and serum fibrogen always needs to be done is because that will help you to guide what to give. We were all trained to give FFPs 15 ml per kg body weight, but if your fibrogen is less than 100, please give cryo first and then give FFPs and not only FFPs and do not give and get away without giving cryo. So please get APTT, PT and serum fibrogen. This promyelocytic leukemia, this can be diagnosed in 10 seconds, life can be saved within 7 days with a simple drug called arsenic plus atra. So diagnosis was done and atra plus arsenic is not very expensive. Third case, female wakes up in the morning with these legs. Suddenly wakes up in the morning, platelets are normal, there's nothing else. She gives a history of 3 weeks back. There was fever, nothing else, some cough was there, and she is petrified and terrified, which comes to us. Sudden shower of petechial spores on the lower limb, platelet, APPT, PT is normal. Diagnosis is HSP, Henoch-Collin purpura. Please remember, even without a platelets, you can have a palpable purpura, which is a IgA vasculitis. And GI is one of the very common symptoms to have an abdominal pain. So if you see 3 things, abdominal pain, joint involvement, renal involvement, and histological features, GI bleed also. So it is very important to analyze this patient. Platelet is not the culprit, it's the vasculitis. One thing which we have not discovered and discussed here is the acute intermittent porphyrias, because the porphyria for the first time comes to the gastroenterologist many of the times. Porphyria because of the abdominal pain. And then the whole list of classification comes in later down the line. To transfuse or not to transfuse, 24-year-old presented with 5 days fever, delirium, had a toxic look. Hemoglobin was 5, TLC was 34,000, platelet was 5,000. Next investigation shows APTT, PT normal, bone marrow. Debate between angiography, CT angio versus colonoscopy. Similarly, hematologist continues to play whether to do a bone marrow test or not, or see the peripheral smear. The peripheral smear was ordered. LDH was 3,400. Any looks, again, comes many times with the bleeding. And these people actually gives a history that they had diarrhea 3 weeks back or 2 weeks back. And now they have turned out to you because you have treated them for diarrhea, and now they come back to you to bite and say, doc, you gave me something for diarrhea, now my guy is delirious, his platelets has gone down, and this is all because of you. So very simple, ask your pathologist to see the smear. This is the schistocytes, and the treatment is not the platelet, but the treatment is plasma exchange. You do a plasma exchange in the night at 12 o'clock, finish at 12 o'clock, 6 o'clock he comes up, he'll be eating a breakfast for you for sure. So that's how the dramatic the TTP is at this present moment of time. Purpuric eruptions can be all in these various acute meningococcemia, chronic, purpura fulminans, viral hemorrhagic fevers, TTPs, and other vasculitis. This 24-year-old present with altered sensorium, history of upper respiratory tract infection 3 days back, not responding to inotropes, rapidly enlarging purpuric lesions on the limbs. So those were chronic histories 3 weeks back. Now this is like 24-year-old, which has just one day history of, and he says that, yeah, he had undergone some operation for splenectomy long back because of some reason. He does not remember anything, could be sickle cell, could be thalassemia intermedia, but he lands up with you with a purpura to you. Because you are a famous gastroenterologist in the town, so he comes to you for the first time. The diagnosis is, yes, acute meningococcemia. You treat it, the patient will become better. So these are the things which tends to come on a day-to-day basis. This is what I represent, a team of 16 people. What I represent is 5 hematologists, 5 pediatric hematologists, infectious disease specialists, geneticists. This is a huge thing for us. Geriatrics, critical care hematologists. This is all within our department and not within hospital. This is what we have published, which leads to the team building, leads to a saving of $5,000 in each patient. And this is the future. What we are working is on artificial intelligence and the genomics, which is like we have got machines, which is the world's fastest NGS machine, which gives reports in 3 days rather than 3 weeks. So we have an ability to do your whole genome, transcriptome, and methylation. Methylation is the new buzzword. Everything you add into your patri, genomic patri is methylation, and this is what the future looks like. the unlock of your power of your DNA. Next year, probably we'll be talking more of gastrogenomics because we have found interesting things in a DVT patient doing an exon sequencing and a recurrent mutation which predisposes to you, which is not part of a thrombophilia workup as such. So I think this is the future for all of us. We stay tuned to that, and this is going to bring us more healthier and brighter world. With this, thank you everybody for your patient hearing. Thank you.
Thank you, Dr. Bhargav, for summarizing so many things in just a short time. I would just like to add one thing. We need to consider dengue.
Of course, dengue is the
This
bread and
first
butter.
thing which
So we have understood that dengue, malaria are all being done, tuberculosis, now we are moving beyond it. That's why probably.
Yeah, just to.
Yeah.
But how many cases you have seen of this meningococcemia in last few years? Because it used to be earlier.
So my ID specialist tends to see more often because we tend to get more people from across the world. So we 5 to 10 patients a year of acute meningococcemia. Still the vaccination is not very predominant in these subsets. The sickle cell patients who undergoes an autosplenectomy, we tend to see more often in these subsets.
Any questions from the audience?
What is the natural history of these HSP patients?
So very simple, sir. 70% people will go into auto remission by giving rituximab, steroid, and plasma exchange. They will not require any modulation thereafter. 30% people will have a refractory nature. You have to continue giving rituximab for a longish time. Out of these 30% people, 50 to 60% people will have autoimmune disorders, underlying autoimmune disorders, which need to be treated in the background. So 70% of TTPs tends to be de novo, and ADAMTS13 level is very helpful to know why, how much antibodies are there, and you can serially monitor them without now waiting for a longish time. So the autoimmune is SLE, APLA, those are the autoimmune disorders. In de novo conditions, now because we know because of some viral infections, say like ITP, the autoimmunity has been triggered. That is why without waiting for the plasma exchange alone to work, the combination of plasma exchange plus rituximab plus steroid tends to work very well. Now there's a drug called ADAMTS13 in US. Now that's in monoclonal antibodies which can be utilized in these subsets.
So ADAMTS is for TTS.
TTP, not for the HUS.
What about HSP? I asked about HSP.
Achha, Henoch-Collin purpura. Okay, sorry. So in a Henoch-Collin purpura, the general natural history is it is in less than 10 years of age. The predominant thing is the moment the age starts going up, it's a chronic in nature, which means you have to monitor your urine for blood, RBCs, and you have to continue monitoring them. If that is not settling at 3 months duration, then it becomes chronicity, and then you have to use mycophenolate or IVIG in HSP patients. In less than 10 years of age, it is self-limiting. 80 to 85% people will not require anything beyond that. Higher the age, higher the complications of chronicity, it is as a rule. So steroid is only, it's only steroid is required if you have got a hematuria, which is urine, which is causing a problem. Other than that, so again, GI bleed is not an indication to give steroids in this. The only thing is because of the glomerulonephritis which is happening in terms of a kidney, that is where you have to use immunosuppression. Because glomerulonephritis tends to occur more often in IgA-induced, glomerulonephritis tends to occur. That is why you have to give steroids in patient who has got hematuria. And not the isolated GI, because IVIG and the rest of the things will settle it down. Which one, sir? So once it is more than 6 months to 12 months, which is not going, and the RBCs are still full field RBCs are there, then you have to do the kidney biopsy to prove there's a chronicity which is occurring, and you have to give immunosuppression in terms of mycophenolate to suppress the IgA, vasculitis. Which one, sir? Acute intermittent porphyria. So there are various types of porphyrias which we need to understand. It is not only acute intermittent porphyria, but there's porphyria cutanea tarda also, where you tend to use. There's a heme which is available now, where you can use in acute intermittent porphyria. So plasma exchange, we have not done for a long time, plasma exchange for acute intermittent porphyria, because heme is easily available. doing it in as an inflammatory markers in aplastic anemia, doing it in as an inflammatory markers in aplastic anemia, MDS, and AML of our subsets to see what is happening. And the last, not the least, is the inflammatory bowel diseases, where we need to understand in ulcerative colitis how and what is the gut flora which is leading to these immunological problems.
Other than GI issues, other than gastroenterology, what is the commonest thing used
For us?
For any specialty.
So for a hematology, the common, everything in hematology is genomics. We do not function without genomics. That's why we have the world's fastest and the biggest machine for 3 days. You'll be proud enough to fact, not only 1.4 billion people, but across the world, when they give their genomics in 3 weeks, we give in 3 days. Our hematology, whether it be ITP, whether it be myeloid malignancies, whether it be lymphoid malignancies, whether it be lymphoma, everything is governed by genomics and what is called as a precision medicine. So anemia. So elderly anemias, MDS is long drawn. Less than 40 years of age, atherosclerosis, CHIP mutations being found to know whether you have a high inflammation score to cause more of atherosclerosis in less than 40 years of age. So for us, everything is genomics in hematology and oncology.
Thank you.
Dr.
Thank you,
Bhargav, what's
Rahul.
the cost of machine? That's your big machine.
The
What's
cost of the machine, sir?
Yes, sir.
So cost of machine is 5 CR, sir. The genomics, the whole exome costs 12,000 rupees and the myeloid NGS costs 22,000 rupees.
Okay.
Thank you, Rahul. You have
No
to
road
catch
for
the
cultures.
flight. Okay, thank you. Thank you so much.
Thank you.
I would like to request the speaker and the chairpersons to please gather at the selfie point for the photograph.
Very good. Good to have you here. We enjoyed.
Now, to begin with the last but not the least session, small bowel bleed, what is new? I would like to invite on stage Dr. Zahir Nabi as the speaker. I would like to invite the chairpersons for this session, Dr. Jayant Yadav sir, interventional radiologist, Gastrocare Multispeciality Hospital Bhopal, Dr. Achal Gupta sir, professor and head of surgery, GR Medical College Gwalior, Dr. Arvind Rai sir, professor of surgery and ex-dean, GMC Bhopal, Dr. Kailash Mishra sir, gastroenterologist, Jabalpur.
So I'll be speaking about small bowel bleeding. What are the new things? So these are the conventional things that we know that we use to diagnose small bowel bleeds. And if you see about the diagnostic part, all of us will agree that motorized spiral endoscopy was the best thing that happened to the small bowel evaluation over last 1 decade. So it had better, less procedure time, better diagnostic yield, almost similar adverse events. So if you see over last 4 years, the number of publications, they were tremendous. Unfortunately, then started appearing the list of adverse events, and very nice editorial written in a recent time was motorized spiral endoscopy, this is the end, my friend. So these all started appearing in 2024, and which is surprising that almost it took 5 years for people to report adverse events, and I don't believe that they didn't occur over all these years. And then it was a sort of Me Too movement that started, that everybody started reporting that, okay, even I had a very fatal adverse events or near fatal adverse events. Olympus finally decided to take this product off in 2023. And it was very, being very honest of Olympus to straight away state that the problem was with rotation of the power spiral, which could stop at any point of time, but especially in esophagus and proximal small bowel. But just to give you a brief perspective about motorized spiral, that still I believe that this technology has potential and it's likely to come back with selected indications. For example, the complications were reported mainly in esophagus and almost never in lower GI tract. So, which means that done through perennial route, it was pretty safe. So, I believe that in near future, for selected indications, motorized power spiral will come back. Coming to the capsule, so because besides power spiral, I'll just brief that what are the innovations that have taken place. So this is what all systems that are available to us as of now, and most of us are using PillCam, the third generation PillCam capsule. So what is new in capsule endoscopy? Let's talk about the preparation. There have been a lot of studies, lot of debate that what is the ideal preparation for capsule endoscopy to get the best visualization of small bowel. So this is one recent study where the preparation, either you give half and half in the morning and half once the capsule reaches duodenum. That gives you a very good visualization. And the second group, which also gives you an equally good visualization, is that you start preparation once the capsule reaches duodenum. So this gives you a better small bowel visualization as compared to other protocols. So what's new about capsule besides improved optics, better frame rates and better half-life? The problem with capsule is that few areas are being missed, and especially the proximal small bowel like duodenum and proximal jejunum, because this is the area where capsule progresses very fast and there is abundance of bile secretions, and in fact even larger masses have been reported to be missed. So what has been done in recent time is now we have double-headed capsule. Means they have wider angle of visualization. Their angle of visualization has changed from 170, 180 to 360 degrees. These are double-headed capsules, so camera on both the sides, so that the rate of missing these lesions has come down drastically. For example, this is Myrocam, and if you see that this has dual cameras and the front camera is missing this large proximal small bowel gist, but the rear camera has picked it up again. So this is something which is revolutionizing the detection of lesion and increasing the diagnostic yield. And this is just a comparative study suggesting that these capsules have better diagnostic yield than single-headed capsules. Now, coming to another paradigm that can be changed. Now, the conventional definition of small bowel bleeding is once you get a negative upper GI endoscopy and normal colonoscopy, which means that before you label or before you proceed for further evaluation, you need these two evaluations. But then several recent studies have raised that question, that is colonoscopy mandatory before small bowel evaluation. So this is one recent study and quite innovative, that in cases with suspected small bowel or suspected lower GI bleeding where the endoscopy was normal, what should be the first approach? So they did pan capsule endoscopy, and in this group versus colonoscopy first group. So they found that the diagnostic yield was much better. Of course, it will be better, but then ultimately the actual colonoscopy was required in very few subset of patients, and these authors, they recommended that in cases where you have a strong intrusion, you have a melena or iron deficiency anemia, you can proceed with pan capsule endoscopy, which can detect small bowel as well as large bowel lesions, and this will lead to avoidance of colonoscopy in majority of the scenarios. So this is one thought process. It has been replicated in couple of other studies, and in future we need to see whether we can employ the same strategy in our subset of patients. Another significant development that has taken place is the role of AI in capsule endoscopy. So capsule endoscopy, we know that it misses a subset of lesions, especially neoplasm and vascular lesions localized to proximal small bowel, and it takes substantial time to read these images. So there are few studies which are coming up which says that suggests that AI can compensate for that human error, where it can detect more lesions as compared to the if a human eye is evaluating the same images. So in patients with negative capsule report by humans, AI detected significant lesions in 60% of cases. And what about the speed? Definitely AI can compensate for the speed. AI can, the time taken by AI assisted reading was only 1.6 minutes as compared to 19 minutes by standard. So it can also reduce significantly the time taken to reduce this lesion. So AI is coming up significantly with regards to capsule endoscopy. What about Pillbot? And this is one of the most recent talked about things. Pillbot is nothing but a capsule, miniature robotic capsule. It has the property of self-propulsion. It can give you live video feed, and it can be remote controlled. So that's the best part of it. So it has different propellers, different parts, where the most important part is that it has 3 propellers at one end which propel the this capsule, and it can be manipulated across different areas of stomach and upper GI tract with a remote control. So this is how it works. You just hospital, you can have a capsule delivered to your home. You can ingest that capsule and inform your physician, gastrophysician, that I have ingested the capsule. He can remotely see your this stomach using that remote control and direct this capsule to different areas of stomach to see if there is any bleeding point or any worrisome finding in that. So this is the future of capsule endoscopy, and this is a sort of robotic capsule endoscope which can be manipulated using a remote. In future, Pillbot is going to extend its wings. Right now we have Pillbot 1, which is being evaluated. It's yet not FDA approved. It's going to be expected to receive FDA approval next year. But then Pillbot 2 will have further miniaturization. Will have a pill surgeon which will also do some therapies like polyp removal, tissue biopsy, bleeding control, and ultimately you will have a Pillbot of a size of a rice grain, and you will ingest multiple rice grains which will do some surgeries and just like microsurgeons performing different complex surgical tasks. So this is expected in next decade or so, because Pillbot 1 and Pillbot 2 is also under evaluation, and gradually this is the dream that the Pillbot company Endiatics is building. Coming to therapeutics, and I'll just share a couple of slides for therapeutics. Thalidomide has been recently being evaluated and published in NEGM for angiodysplasia related bleeding, which is the major cause for small bowel bleeding, especially more than 50 to 60 years of age. And you'll see that thalidomide 100 milligram as well as 50 milligram was significantly more effective than placebo, not only in reducing the bleeding episodes, but also the frequency of blood transfusion in these patients. Of course, adverse events were there, but majority of them were not major. What about polypectomy? Small bowel is a risky organ because of its thin walls. So what if we, especially these are cases with Peutz-Jeghers who frequently require polypectomies, and these cases can be managed without cutting these polyps, because cutting induces bleeding or thermal injury, and to control them in small bowel may not be that easy. You just apply clips in a crisscross direction, and this induces this ischemia, and this is the way to go in these patients and shown to be very effective. To summarize, there are a lot of things that have come up with regards to evaluation of small bowel bleeding source. What we have seen so far, the developments is since the introduction of first capsule in 2000, now we have Pillbot. We use thalidomide more often due to a landmark study that shows it reduces, and we have pan-enteric capsule that may probably replace colonoscopy before evaluating small bowel. That's all from my side. Thank you.
Thank you, Dr. Nabi. It was a very good talk about very difficult terrain of small gut, where the opportunities are more because it is a more difficult terrain, and you have given a glance of future development to us. Any questions from?
Zahid, is this already commercially available, Pillbot?
So Pillbot is available only for trials, and because it's yet not FDA approved, but the version 1 is, I think, ready for prime time. Pillbot 1.0 is ready for prime time. Cost, even because it's not FDA approved, so cost has, it's under trial. It's under trial.
This applying clips in Pute Jaggers is a very good concept, I think.
Yeah, 90 degrees. I think one clip, the second clip is 90 degrees to the first clip, and it the bleed, no risk of perforation, nothing. And Japanese have stopped cutting polyps because of the risk of delayed bleeding. The area of polyp is not within very easy reach. So I think this is something which they are, and they don't use loops because loops are sometimes difficult to apply if the head of the polyp is not visible. So
they cut through also sometimes.
They cut through also, exactly.
Nice, very good.
So if there are no questions, we can conclude the session.
I would like to invite the speaker and the chairperson to please come to the selfie point for a group picture. With today's session now concluded, we warmly invite you to join us for the big night, an evening of soulful music followed by a grand dinner. Let's come together to celebrate, unwind, and create some wonderful memories together. Enjoy the musical, magical, and delicious night with us. See you all tomorrow. Thank you.